Ask so now we're live. कौन सी मॉड्यूल Give it one minute. This screen. It's good. Yes, integrate is the thing. I think that what about the database? Select it. Screen. See on the big screen is what you will see. This is a video. So you say A does this. You say B to the camera. See that. So for example, I switch to B using the both. Now the idea is when there small thing other than having this
Good morning, everybody. Hi. Just for us to know, okay, I'm Aaron from Excel Department. Iacts Score from Bangalore. So everybody is present and our president of the association, Dr. Bashi. And we are here today morning up to young elections. Our very old young design from Satyasai Puttaparthi, another departments. So we are all here to enjoy next 2 days with you. So I thought rather than just sitting and looking at the screen, so I thought of introducing and knowing each other. So let us know more from where each year training. Let's start from the last. Looking down is looking into focus. Unless you go from other part, number 2 you are. So what is forward?
now to show the camera. So
Not my check. Not my check. Okay. Thank you.
now prayer will just go to B.
It's
a camera there.
And Dr. Arjun Narayan Dialog.
okay.
I'm Ashley George Joseph of IPGMR Hospital, Calcutta. Calcutta.
We are sitting so close to Narayan. Oh, really? Really?
I'm Swanand Kabri from Tagore Hospital, Kolkata, second year.
Second year DNP.
Second year DL. Oh, DL is 6 years.
I hope you are, I'm sure, it's good to hear you. Second year
I cleared theory exam.
Okay.
Partner is in DL.
We can't ask you to go back, don't worry. Dr. Sitaram was right. Very happy. Especially for the chair.
Did you finish, sir?
Where are you? Sir is asking.
Good morning, everyone. I welcome you all to the Indian Association of Cardiovascular and Thoracic Surgeons Course 2020 program. After the well-appreciated grand success of Iacts Score 2019, with the positive feedback from the resident and faculty members, we have organized this year a 2-day program for exam-going students on the basis of stations we have received. We thank the Indian Association of Cardiovascular and Thoracic Surgeons for their help and support and including this program as a part of continued medical education program every year in training CTMS resident across the country.
Oh, yeah,
Score.
part of the course.
She set aside cardiovascular thoracic surgery practical examination rapid orientation program. Is a simulation of final practical exam conducted by the resident for the resident under the guidance of eminent teachers. So why do we need a program like Iacts Score? With this program, we help the examinees by giving them a crash course of syllabus for final practical examination and help the examiners by giving them better prepared students. Let us begin this extensive session of teaching and learning with prayer invoking Lord Ganesha and Goddess Saraswati. For lamp lighting, I invite Dr. B.B. Bashi, President of Iacts, on stage and request the Iacts Score faculty to join me. Dr. Shekhar Rao, Director, Shri Satya Sai Institute of Biomedical Sciences, Senior Pediatric Cardiac Surgeon, and Organizing Treasurer of Iacts Score 2020. Dr. P.S. Sitaram Bhatt, Organizing Chairman of Iacts Score, Professor of Shri Jayadeva Institute, Dr. Anil Tendulkar, Senior Most Teacher by Excellence of our country, Dr. Balram Iyer, ex-HOD of AIMS, New Delhi, Dr. Shri Krishna, DNB Coordinator and Consultant Thoracic Surgeon, Narayana of Delhi, Dr. Neelam Desai, HOD of Situation, Satya Sai Institute of Higher Medical Sciences, Kabardi, Dr. C.S. Sirimal, HOD of Situation, Satya Sai Institute of Higher Medical Sciences, Whitefield, Secretary of Iacts and Organizing Secretary of Iacts Score 2020.
श्री गुरुभ्यो नमः हरि ओम गणानां त्वा गणपतिगुं हवामहे कविं कवीनामुपमश्रवस्तमम् ज्येष्ठराजं ब्रह्मणां ब्रह्मणस्पत आन शृण्वन्नोतिभिः सीदसादनम् प्रणो देवी सरस्वती वाजेभिर्वाजिनीवती धीनामवित्रयवतु गणेशाय नमः सरस्वत्यै नमः श्रीगुरुभ्यो नमः हरिः ओम् यश्छन्दसां वृषभो विश्वरूपः छन्दोभ्योऽध्यमृतात् सम्बभूव समेन्द्रो मेधया स्पृणोतु अमृतस्य देवधारणो भूयासम् शरीरं मे विचर्षणम् जिह्वा मे मधुमत्तमा कर्णाभ्यां भूरिविश्रुवम् ब्रह्मणः कोशोऽसि मेधया पीतः श्रुतं मे गोपाय मेधा देवी जुषमाना न आगात् विश्वाची भद्रा सुमनस्य माना त्वया जुष्टानुदमाना दुरुक्तान् बृहत्पदेव विदति सुवीराः त्वया जुष्ट ऋषिर्भवति देवि त्वया ब्रह्मा गतश्रीरुतत्वया त्वया जुष्टश्चित्रं विन्दते वसुसानो जुषस्व द्रविणो न मेदे मेधां म इन्द्रो दधातु मेधां देवी सरस्वती मेधा मे अश्विना उभावा दत्तां पुष्करस्वजा अप्सरासु चया मेधा गन्धर्वेषु चयन्मनः दैवी मेधा सरस्वती सा मां मेधा सुरभिर्जुषता स्वाहा आमां मेधा सुरभिर्विश्वरूपा हिरण्यवर्णा जगति च गम्या ऊर्जस्वती पयसा पिङ्गमाना सा मां मेधा सुप्रतीका जुषन्ताम् मयि मेधां मयि प्रजां मयि यज्ञस्तेजो ददातु मयि मेधां मयि प्रजां मयीन्द्र इन्द्रियं ददातु मयि मेधां मयि प्रजां मयि सूर्यो भ्राजो ददातु हंसाय विद्महे परमहंसाय धीमहि तन्नो हंसः प्रचोदयात्। ॐ शान्ति शान्ति शान्तिः।
Thank you. Now I request our Club Director Dr. Shekharao to welcome the gathering.
Om Shri Sai Ram. With most loving and grateful pranams to Bhagwan for having provided us this most sacred and beautiful institution and venue. I wish to welcome you all to this significant initiative of Indian Association of Cardiothoracic Surgeons and also from the Department of Chikiৎসা Institute of Biomedical Sciences. I congratulate Dr. Hiramad and his team for having initiated many such programs which are fairly path-breaking and have been proven useful to the specialty of cardiothoracic surgery in our country. I welcome all the residents from all over the country. You are most welcome to this portals of this hospital, not only for this particular function, but just to experience the ambience and the guiding principles that exist as enunciated by Bhagwan and his vision that we provide with no compromise the most contemporary and the most leading technological solutions to people who have otherwise no access to these, so that they may feel a sense of satisfaction and a feeling of being looked after in this country and not deprived. To that extent, I see this as a national contribution and a national mission. So it is very appropriate that our most important and august body of the association should be associated with this program. And I appreciate all the seniors, all the leading teachers of our country who have spent decades in developing the specialty. Many of you are pioneers, and I am very grateful to you that you have agreed to participate in this program, and welcome you all, sir and madam, to this beautiful environment. Past as I am in the role of director of this hospital, and since I am invited to speak on this occasion, I think it's appropriate as usual to say one or two things which probably I don't get a chance to say otherwise. This is primarily directed to the students. I had the chance to study in some of the important institutions of our country, and maybe a few things I can say out of my own personal experience, not so much as a faculty, but as a student. One thing is that, as you know, in our country, we have got this little exam fixation. You can see that the institutes of training for entrance to IIT, the entrance exam is supposed to filter out people who are qualified to undergo that kind of training. So we have an institute to train people for the entrance exam. Then there might be a day which will have an institute to train people for the training for the entrance exam. It can go on ad infinitum. So suffice it to say that the process of training should be more important than the process of examination, particularly at this postdoctoral level. To give you an example, I heard a story from a neighbor of mine just very recently. His son has done a BSc course in India, and it's a 3-year degree program in some scientific field. And he applied to one of the big universities in the United States for a PhD program. And there, as you know, you need 4 years minimum college to go into masters. So he had done only 3 years, which is our BSc program here. But they happened to conduct an interview with him for almost 3 hours, it seems, on the telephone. And not only did they waive off his 1 year of college, they offered him a master's PhD program with some scholarship because they saw some kind of merit. So the flexibility in terms of training and education is more important than the process of exam itself. So if you make this into a kind of tutorial to beat the exam process and then think that therefore you have mastered it, probably you have not actually got there what we intend to do in the first place. Having said that, I think it's most important that you use this forum as a method of education, and then it's a completion of the process. A lot of attention is being paid, I know, to the training program itself. But for the students to understand that do not be so exam fixated, concentrate more on your training rather than the examination. And as a closing example of that, the theses that have to be signed by the head of the institution come to me. Sitting with the candidates and asking them to the extent that I can, what have you learned from this? So I opened the bibliography at random, picked up one paper from there, and I asked that particular candidate, have you actually read this paper? And he honestly said no. So this is, we have instituted so many regiment sort of things, but whether they are actually serving the purpose or not is something that we need to ask ourselves. And we should not be doing something as a mere kind of ritual, which is not taking us forward, in total. So once again, welcome to our institution, and all that you gain from here, I think, in my mind, is by the grace of Bhagwan and by the goodness of all the teachers assembled here to make the most of your opportunities, and welcome you all. Jai Sai Ram.
Thank you, sir. Now I invite Dr. B.B. Bashi, President of ICTS, to address the students.
A very good morning to everybody. At the outset, I must congratulate Dr. Hiramat and his hard-working team for organizing this excellent program, which I call the icing in the cake, because after 5-6 years of hard work, this will really put you how to present in the exam and pass in this exam. But I think that's only a certificate for an eligibility to practice in the future, because a big portion is there ahead for you. And you imagine as the captain of a ship, a smooth sea never makes good mariners, because your sea will be rough. You'll have to face big difficulties in so many places. So unless you have a really good training, which starts, I would say, from the discipline. I will address you a few things which I have learned over the last 4 decades. Most important thing is the discipline. You have to be disciplined, because all of you are going to be team leaders at some stage of your life. For that, you have to come, first of all, on time. I was noticing that we were the first one to come in this hall. 8 o'clock means you should be the first one in the department, and you should be the last one in the department, because you have to practice what you preach. If you are indisciplined, all your assistants, your nurses, the perfusionists, everybody will follow what you do. So that is number one quality of a good cardiac surgeon. And then communication is another important part. You have to, that starts from the outpatients department. Even though you have so much of artificial intelligence, so many monitoring techniques, so many things are coming up day by day, the anatomy and the physiology of the human beings are not changed over millions of years. Evolution has made us into a human being. So the human touch should always be there. When a patient comes to the outpatient department, I realize the students, most of them first take the ECG, X-ray, all those things, but you have to listen to the patient. Believe me, at least 2 to 3 minutes to listen to what he is telling. Doctor, the patient is telling you the diagnosis. We are too busy to listen to him, but he said by Hippocrates, not me, the father of medicine. It is still true. When a patient comes with an ischemic heart disease, you take some history. When the disease starts, when the pain starts, what was the treatment, where did you go, diabetes, talk a little bit about the family. So that the first attachment you have with the patient at that time. And from that, you will learn a lot of things in the management of the patient. Then, when you get high sounding cases, sometimes when you become senior, you will get a lot of difficult cases. Always discuss with your colleagues. Never underestimate the opinion of your colleague, junior colleague, however junior they are, because you should never have a tubular mind. I always say your knowledge should be like a bottle which is half or three-fourths full. If you think your bottle is always full, there is no point you can accept anything. You think I know everything. In a difficult situation, sometimes the junior most assistant might be able to help to tide over a case. I remember when I did the first aortic arch aneurysm in 1992 in one of the hospitals in Chennai. We are doing a total circulatory arrest. 60 minutes is already just nearing. So I was about to anastomosis both the arch vessels. It would have taken another 15 minutes. Some of my assistant junior assistant told me, "Sorry, please just do only the left carotid." Temperature was only 20 degrees. So if I have not listened to that assistant, that patient would have been brain dead. Believe me, that was the first successful elephant trunk procedure we did in the country. The patient became alive. 7 o'clock, the patient was awake. So it's a small instance. I'm just telling you how to listen to somebody also and discuss. Number 3, the operation does not start in the morning at 8 o'clock. Operation starts 24 hours before. You have to, when a difficult case comes, you analyze, discuss. Suppose in a difficult case, when I am doing a difficult operation, I admit the patient about 3 days before. Why? Because your house surgeon may be able to pick up something, your other assistant may be able to pick up something. And discuss with everybody, discuss with the anesthetist, discuss with your perfusionist, discuss with your nurse, because you may not find a particular valve or a graft is not available in the theatre. It is not their fault because of various infrastructural procedures and things not unavailability of things in our country. We may not have what is ideal, may not be available. So you should be able to improvise and make things work. If you look for the perfect place to work, you will never find a place. Because the initial operations of what we did, new cases, we have no facilities to the videos. Nowadays, everything is available for you. We used to, the most senior most person, you would have one of the very eminent cardiothoracic surgeon, John Kirkland, written a book. You all must be reading that, I'm sure. He has mentioned in one of the journals that one of the anesthetists has written that Kirkland used to write the steps of an operation in a difficult case on the previous day and give it to the anesthetist and make sure every step is properly done. Every case you do should be thinking, this is my first operation. If you take any case for granted, believe me, that will be the beginning of a problem. When you are very junior, sometimes you may make mistakes. God will forgive you. But when you have learned a lot of experience and try to do things shortcut, you will be caught on the spot. From my experience, any case I take very light. Okay, it's a simple case. That case give you the biggest problems. Another thing I want to tell you also, you should not be a cardiac surgeon. You have to be an operating cardiologist. You should be able to teach the cardiologist with your experience because you are the person who sees the patient. You see the angiogram, you see the heart, and you operate. You look after the patient post-operatively and see them afterwards. Very, very, very important thing. Follow-up of the patient. Don't operate the patient and send away that to somebody else. I don't know the follow-up. Such and such cardiologist is no excuse for it. You will never learn anything. Because your own experience over the years will teaches you whether bilateral memory is good, radial artery is good, tissue valve is good, mechanical valve is good, or you will learn for yourself. You read a lot of things, and unfortunately, not many articles are not coming from our country. We are following up the guidelines and experience from another part of the world, where the patient's whole anatomy, physiology, and their living conditions, their response to surgery, their longevity, the type of associated problems are much different from our people. It is like comparing apple and oranges. There may be some similarity, but I encourage you See, to be more academic, you should document what you are doing. Very important. That you should start from the day one itself. Make notes and record, because nowadays everything is available, because so many information is available. You can record everything even by dictaphone itself. You can record your data so that in a future day it will be available for all of us, and we will be proud that you are publishing something, because the front of the annals of thoracic surgery, when I was the junior registrar, there is a two sentences always remember: publish or perish. So this is one advice I have to tell you. Then another thing is work 1 or 2 hours extra. See, when the famous tennis player Bjorn Borg, I don't know whether I've read about it. He won French Open the 5th time. He was when he won the Wimbledon, the French Open the 5th time. He was asked a question by the British BBC. Mr. Borg, out of the 5 billion people, how you could do that? It was so he looked at the BBC commentator and said, when the whole world was sleeping, I was awake playing tennis. So when the world wakes up, they will see a champion. So if you want to be champions, be awake when others are sleeping. Thank you very much.
Thank you, sir, for sharing your experience and giving us a vision to serve better for the patients. To be successful in DNB practical examination, all it requires is a rigorous training, an unwavering focus on a goal, a well-guided path, and a mental strength to face challenges. Tamsuma Jyotirgamaya, the mind once enlightened cannot become dark again. I hope this program will enlighten us to not only be successful DNB candidates, but also be successful practicing surgeons. Now I request Dr. C.S. Siriman, Secretary of ICTS, DNB Examiner, to give us all an orientation of Iacts Score 2020 program and an overview of DNB practical examination.
Morning. Offering my humble pronouns of the divine logos, feet of Bhagwan Sri Satya Sai Baba, I stand in front of you to bring to the students the 5th edition of Iacts Score 2020. This was the initiative taken by Sri Satya Sai Institute way back 2016. We, the teachers from Satya Sai and the local faculty from Bangalore, dedicated teachers who started up the program, we had made a presentation in the ICTS, and ICTS was kind enough to look into this initiative for the residents, which was designed by the residents, for the residents, and by the residents. And it's a part of training program for the residents itself, for their leadership programs. Tomorrow at the end of 48 hours, you'll come to know how the residents have worked hard to make this program a success. It's been happening for the last 5 years. In fact, last year we happened to conduct 2 programs, and the ICTS was kind enough to consider for those students, exam-going students in the month of December, or those unfortunately who were not cleared in the first attempt. For them, a second attempt, because number of students had written down. And this time, ICTS and the general body has taken a call to conduct another program of the same kind in northern part of India, that's in New Delhi, where RML Institute has been considered to conduct ICTS Score 2, which will be conducted in the month of August. That's how the decision is taken by our President, Dr. V. Bashi, I think most of the students here know him. He is a surgeon par excellence, and his field of excellence is in aortic surgeries. We have hardly to count on the tips of the hands who are the best aortic surgeons across the globe, and he stands top among the country and among Asia also. We thank you, sir, for being here amongst us. Scheduling this time, even yesterday he had 4 major surgeries operating today, and by night 11 o'clock he was here with us, and today spends time. His passion for teaching, under his guidance, the association is going far ahead. Recently, we happened to introduce the journals for the students and for the members also. Not only this, many more to come. As and when time comes, I will be letting you know what all the ventures we are undertaking. I also would like to thank Dr. Shekhar Rao, Senior Pediatric Cardiac Surgeon, Chairman of Cardiac Sciences, Director of our institute, for spending his valuable time with us. He had other prior commitments and the request for the love of the residents. He is here amongst us. I thank you, sir, for being here. I thank my other senior faculty teachers who visit here regularly. And one of the faculty who comes down first time for Satsai Whitefield, a senior teacher, ex-head of the Department of All Indian Medical Sciences. Some of his students are here. Dr. Balram Bhairan has come all the way from Delhi. Apart from that, we have a regular faculty, Tendulkar sir, who requires no introduction. He's a master batsman, what I call him, who leads the show many times. And Dr. Sitaram Bhatt, who is a senior teacher, and always never thinks twice to be here. He kept catching all his schedules. They all come down on their own. I just provide the local hospital, and apart from that, it's right for them to teach the students and see that what they have learned never goes to waste, and see that they do find some more young budding cardiac surgeons who can utilize this. As Dr. Basi mentioned, we never had the technology, neither such teaching programs earlier when we were students. It was totally a different era those days. Now, in the present of technology, where IACS is also taking the lead, and institutes like Satyasai or other institutes are coming forward to take it ahead. We have this time 167 registrations. The hall is almost full. Still, some more students are on the way because of their commitments. On this day, the Indian Association wants to make a declaration that this program of Sri Satyasai Institute of Biomedical Sciences, in collaboration with the IACTS, is going live across the globe. Today, your teaching program is going live. This is what recorded. It is available on the IACTS website. It is available by separate YouTube link. So, teachers and students, I would request your communication between the examiner and the examinee is being observed across the globe. So, see that we do well. No doubt we do mistakes here because no mistakes elsewhere. This is part of the training program for you as a preliminary examination, as a mock examination for the students. And first time the IACTS has taken initiative of making it live for those students who are unable to attend. We have more than 300 plus cardiac students across the country. Most of the institutes, all are not able to come. That's not possible. And those students who cannot come, for them, they can see live, number one, or even the recorded images will be there on the IACTS website also. There are suggestions how to improve. This is the first time we have taken initiative under the leadership of Dr. V. Basi. We have taken this initiative for the benefit of the students. And as last time in general body I mentioned, looking into the aspects of various aspects of teaching, we have students across the country. Different institutes have different ways of teaching. How about conducting an Iacts score for the teachers? This was well taken, and let me see how I can go ahead with that. It's just a thought process initially, but wherein all teachers come together and what best we can inculcate to the student. Apart from this, is not we teachers take two interests at the same time as Dr. Basi commented. All of you have to take equal interest from your end also. Whether time and, as he told, safety and discipline has no holidays. Discipline, 8 o'clock we have to start, we have to start. We have to wait for a few of the students who are not here. But that's why but see that such things are implemented into your day-to-day activities. It doesn't come overnight. We need to go a long way. With this brief introduction, I do welcome Dr. Prasanna Simha, Dr. Pradimala Prasanna. Dr. Prasanna Simha is a teacher. He is unstoppable. As you spend more time, I always keep telling them, Dr. Prasanna Simha, student of Dr. Anil Tendulkar, who is unstoppable. And to be fortunate enough, I am their student. I am student of Dr. Prasanna Simha, proud to tell that. And the legacy continues. I am yet to find a student who will continue the legacy. Definitely I will find. I do not deny that. So that, and I do thank Dr. Iacts Score, who comes all the way from CMS Vellore. He was ex-head of the department of CMS Vellore. He is here with us. And not only this, Dr. Vinayakula and Dr. Pransim are constantly on the Iacts Score group, where more than 350 members are there. Constantly, every day, the teaching program continues. Some people get scared to ask questions. They ask questions on the group. I request you to continue actively participate. Not only there, because WhatsApp group is just a way of teaching program what we are trying to utilize. That's not the end of it. It's here because in the examination you got to speak, you got to express yourselves. For simple example, I'll tell you one example how students get text. They will tell that I'm very good at pediatric cases. I present a tough case. I happen to take examination for all the students. I just asked one question: what are the different positions to break a spell? Of course, everybody knows neatest position. The other positions are carrying the child, the mother carrying the child, and the hip joint with the arms and knees next, legs and arms, hip joint next. Another is a namaz position. In the examination tension, or I call it examination tension, the student instead of telling namaz position, he told salam position. So this is how it goes. Unless you speak, he knows, but speaking something different. And the examiner, it's a big, you'll be laughing starting the exam. He doesn't know how you are attached, blah, blah, what is this, he doesn't know your background. That's where you need to express yourself, present yourself, and don't wait to the last month for the score programs. Start presenting at your own institute for each and every teacher. Every teacher is good enough. All 5 fingers are not same. You need to present one year prior. I still remember those days, 20 years back, when Prasanna sir was my teacher. We used to go in the car in this bad Bangalore traffic, even worse now. We used to go back down on the home. While driving, I used to present a case, he used to listen. In fact, sometimes he used to get tested. He focus on the present, driving or on the presentation. I don't both, but I used to do like this. That was the way where we learned, and there's so much there, treasure of knowledge. And he loves to share that treasure. And it's our mistake that he or she, not only Dr. Prasanna, all of the teachers sitting here, they come with thought of dedication, sincerity, and see that they are here for 2 days. Dr. Anil Tandulkar, I keep telling him, before he reaches his graveyard, he has to share all his knowledge to all the students. I'm very clear on these things. And outright he comes. In fact, this time he was a little refusal to come down. I keep teaching still students are the same. So please, I request you to come for my sake for the continue the passion of teaching for the students. Because we don't know, you're all like our children. That's how we look at it. When a child goes wrong again, you try to correct them. That's where I look at it. And I see that all of you do utilize this resource. And you should be thankful always to the ICTS who are there, all your seniors, your mentors, and who are taking a lead for the benefit of the students. We as one of the institutes, we have taken a lead. Similarly, other institutes are coming up. And see that the legacy continues. Encourage your youngsters, your students, your colleagues, friends to come down for this program. Coming to a few slides, what is the student-teacher relationship? Students are like a rope. You can't push a rope, you can only pull it along with you. You can't push students into learning, you can only bring them along with you. Beyond this, I think a student and teacher relationship, we need to go along. Cardiac surgery is a vast field and one of the toughest specialties in the world. Remember, only the toughest people only take cardiac surgery. And I keep telling them, when the going gets tough, the tough gets going. Only the tough people only take cardiac surgery. Nobody else takes. And always remember, 30% of the cardiac surgeons in the world are assistants. You decide among yourselves whether I'm going to be independent cardiac surgeon or an assistant. And that will help you to go ahead. And becoming an independent cardiac surgeon is tough. And you have to slog. It doesn't come overnight. All people who are sitting here have 30, 40 years experience. Their experience teaches us a lot. It cannot be learned or gaps in the short span, it's learned over a lifespan. Examiner wants to know whether the examinee will be capable of taking decisions for patient benefit. You can't take a wrong decision because here the margin of safety, as you all know, is very less. It's either death or patient goes home alive. There's only 2 of them, no in betweens. Common things about the subject will be understood clearly if you work sincerely throughout your 6 years course or 3 years course. Patient care teaches you the subject. Don't aim for a correct diagnosis, always aim for a reasonable diagnosis. When you aim for a correct diagnosis in the examination, you will come to know that the examiner will come to know that you know the diagnosis. So do not rely on that. Give a differential diagnosis, rare diagnoses are rarely correct. Before answering any question, think for a few seconds and then answer. As I told you, just example I gave you, that's just a small example. There are a number of examples to give on how students can make mistakes. If you don't know, just say you don't know, but don't bluff. Ignorance is not a crime, but negligence is a crime. Why score? uniqueness of this program. It's a simulation of examinations, as I told you. It's one-to-one interaction among teachers and students, and it's very precisely depicted for the exam student. How to implement these 2 days? Active interaction among students and teachers, taking part in discussions and case presentations, clarify all doubts, make mistakes here and none elsewhere. If you happen to go to JIPMER, JIPMER is one of the pioneer institutions in the country. If you go there and enter the wards in JIPMER, then it's written, make 1,000 mistakes here, none elsewhere. Mistakes in the sense you can't keep killing patients there. No. You've got a mentor. Days are gone, 40 years back, 50 years back, when all were learning, my professors, their professors were learning, killing and learning. Killing in the sense, not with the intention of killing, but we had to get cardiac surgery in India. That was how it is. If you look back, cardiac surgery is just 60 years old. Beyond 60 years, if other students, if you know, the dictum was, anybody who touches the heart will lose the respect of his colleagues. You understand? Anybody who touches the heart will lose the respect of his colleagues. Nobody used to talk to him, he was sure of it. That was cardiac surgery 65 years back. But it's not now. Today, anybody touches heart is loved by everybody, provided do a proper job. Okay, otherwise other things will happen. That's how the things are progressing. India is very fast progressing country. People tell that the cardiac surgery, there is no much progress, blah blah blah. That's all wrong. When you can't perform, you start talking like that. Sky is the limit for cardiac surgeries. We have one of the master classes today. Among all the teaching programs from basics, the basic masters are Dr. all this thoracic, about Dr. Sri Krishna is there. They're all pioneers in thoracic surgeries and cardiac surgeries. They will handle the basics. There are certain masters upcoming, the recent advances. We have few faculty here today. Dr. Satyaki Nambala will join us in the afternoon, who will focus on minimal access. Sky is the limit. Iotic surgery, sky is the limit. So many things are coming up. Technology advancing, heart transplantations. VADs, we have kept a VAD class also today. And one of the biomedical universities is coming now. This is some initiative which we have taken, and we have introduced that to brief what exactly it is, where the field is so vast, wherein you can just look into all those aspects. Clinical case presentations, we have 5 cases to be discussed today and tomorrow. Students will be presenting in small groups. We have made groups of 2 or 3 volunteers and come down and give the names to Dr. Anaga, who is cleared the examination in the first attempt, who is a student from here. Questions not answered by the presenter will go to the exam going students. And do not hesitate to answer, stand up and answer. What's going to happen? It's going to go wrong. So what? If your wrong answer, so what? You're doing live telecast, you'll be accepted, so what? Nothing is going to happen. Nothing is going to happen. But you are going to learn in that process so much. Look into that. Because we have mistakes, small mistake here will kill somebody's life. A life destroyed is a family destroyed. Always remember this, cardiac surgeries like that. That's where you look into it. Make mistakes, teacher may shout, so what? Be happy somebody shouting at you for your improvement. No personal agenda. Outside the hall, he is a close friend of yours. How close you will come to know by yourself. Keep more mistakes. I was Dr. Sudhanshu Bhattacharya for 2 years. He's, I think all the master sitting here know him. It so happened he used to fire me left and right. It was a tough master. So it so happened that the way firing went on so much, I learned so much. The day he doesn't fire, I felt it was something abnormal. I used to make mistakes deliberately. I started enjoying it. So always enjoy your work. Don't mislead. No, you can't kill patients deliberately, I'm telling you. I'm just telling you how to look in a positive way, the way the teacher tells you. That's the only thing, the message I want to convey. No teacher harms you unless there's something wrong with you. Okay? He is not going to be a teacher, I'm telling you very clearly. You can choose. You have choice of yours. You can choose. All teachers who have been selected is by the feedback given for the last 5 years. For a kind information. I do that much groundwork and get those teachers again and again. There are some more people adding on. That's not a problem. But there are teachers who have no passion of teaching and they are here because of your feedback, what has been given for the last few years. In these teaching sessions, we have few master classes in iotic surgery, as I told, MSc program, crash courses with cardiac and thoracic imaging, cardiac bypass, quick lessons on reading ECG courses, etc. Remember, cardiac surgery can't be taught in 2 days. Many of the feedbacks were there, keep it for 1 week, keep it for 3 days. No, it doesn't happen. It's just a mock examination for you to revise. That's all. We can't teach cardiac surgery in 2 days. No. Your concepts to make clear, you have been learning at your own institutes and you will plan. Apart from that, we have got evaluating the thoracic case by panels and feedback from the residents. We have made a Google form to be shared shortly. I need your feedback for further improvement of this training program. No, anything, whether it is food, stay, accommodation, hospitals, including the toilets, you can give me a feedback. Because to that extent, we go for inspection and see that it has been conducted to the best. In what's new in 2020, every year we add new things. Emphasis on knowing the past in cardiac surgery, evolution of heart valves. More emphasis on thoracic case presentation this time and imaging for diagnosis. Talk on mechanical circuit support, as I told you, to support and instigate minds. And the live telecast, which is already ongoing of ISIS 2020. And as usual, the Karnataka Medical Council has allotted 4 CME credit hours. Remember this for all of you. I'm telling Karnataka Medical Council, if they have got a separate and you call him an observer who comes down to Satyasai or any other institute, goes there, he collects his fees and he sees and he checks and he signs. For Satyasai, the examiner doesn't come down. He tells that we know what kind of programs to conduct and they refuse to come down. We just send certificates. That's the level of training what they have failed in this institute and the Iacts program, which have been conducted for the last 5 years. The first 2 programs they came, and after that they stopped coming. I have to give a feedback after the program, and that's how it is. Apart from this, we have come out with Satyasai version notes. That's Iacts where we started way back 6-7 years back, and that has been getting updated. And today we stand at version 7, where in instruments and history update what we have been updating in these. And this is good for the exam going students. We are modifying it again every year so that it's easily available. Initially, I was giving in a pen drive or in a CD stepwise. I'm going it more paperless. The association itself has taken a decision of going more paperless. If you see your file, I have gone plastic free. I have made a jute file this time. So not only this, we are looking into the environmental aspects also. Why a pen drive? The link is available. Use it wherever you are on a mobile. You can click and start utilizing it. That's where we are looking at. And each time we go and went on adding. Last time with the help of Dr. Prasanna Simha and others, we happened to add recent trials, which are very important, which most of the students neglect. Trials we happened to add. We added classifications and steps of lung resection surgeries from Dr. Sri Krishna sir. And this time we have the further updated on the instruments and the history updated all this stuff. We go on adding as and when case comes or as and when the student requests based on the feedback, we go on updating these notes. The end is nearer than you think, and it is already written. All that we have left is to choose the correct moment to begin. So let's begin our Iacts Score 2020. The hall is full, but time we begin. Thank you so much. And just brief about how the examinations are conducted for the students who are exam going students. All who are seated here are examiners, including me. We are the examiners for just. For the students who are exam going, total marks in the practical examination is 300 marks. Case presentation is 250 for each case. Table viva is 40 marks. ICU rounds is 40 marks. Biostatistics and result advances are 20 marks. For passing, you require 50%, 150. And mind you, the center where you are sitting is one of the DNB examination centers. Okay. So we conduct examinations every year, both formative assessments and practical assessments. Examinations are conducted regularly by the national board. Time allotted is 2 hours for taking cases, 4 long cases. There is no short case as such, nothing. Each case you are allotted 30 minutes. This is what I am telling DNB and examinations. This is taking examination, coming to a diagnosis, summary, justification, writing it on paper, 30 minutes. Out of the 4 cases, they will ask you about the surgical steps in one case. If the examiner, if you answer well, he may ask you about some additional cases also. But normally, because of time limit, per day, 4 candidates are examined. 4, sometimes 5. This is how national board allows examination so that the examiner doesn't fail to assess the candidate properly. So plan yourself well, be well dressed, well eaten, see that all those things are taken care. All of long cases, I told you, there are a variety of cases. What are the common cases kept in the examinations? There is also conduct heart disease, DSDs, PDAs, coarctations, ESD, MRs, and cyanotic invariant rate of physiology. And valvular heart disease, either single or double. Double if it comes to a long case most of the time. So redo cases is part of the examinations. We have redo case in our discussions also. And thoracic case, in thoracic, we have thoracic or a post-TB disorder like post-pneumonectomy. Mass in the thorax, we have got a very interesting case with the help of Dr. Sosley, who works as a cardiac surgeon, as a thoracic surgeon at the Sanatorium, was kind enough to share us with the case. And consider pericarditis is another thing. ICU rounds, what they ask in ICU rounds? Management of hypokalemia. ICU rounds are mainly taken to make an assessment whether you really work in the ICU. Today you have intensivists in your hospitals. We cardiac surgeons are intensivists first. Cardiac surgeons next. You should know how you to manage your patients. Otherwise, you'll be taken for a ride by an intensivist. You should know what you're doing. When we were students, and even now, my students or other institutes where cardiac excellence stands first in the ICU to take care of the patients. Then they'll ask you about the pacing modes if somebody is on pacemaker and all, respiratory disease management, several protection strategies. I know those calculations are very important. Normal sugar and change the doses and all will be known. If IV machine is there, they'll ask about the rise of machines and all this stuff will be asked in the rounds. Table however is mainly instruments. Instruments can be surgical instruments or CPP related instruments. And apart from that, we'll have chest X-rays, CT, MRI. You should be knowing CT, MRI. Today, if you tell us that you don't know how to read a CT or MRI, is not accepted. So we do have a MRI session in our this session also, but at your institute, see that you are aware of CT, MRI, pictures, images, reading angiograms, no mistakes have to be done. They have to be clear concepts. CPP cameras, we have master class, but people who attended last time, you know how it takes classes. Try to attend them, have active interactive sessions, that's where it matters. You'll be asked to draw CVP tracings, a PA tracing. These are things which you need to know correctly, the type of wave you have, which wave corresponds to what part of the cardiac cycles. Cardiac solutions for the different type of solutions you have. These are things which they are asked in the and also apart from that, if you are doing well and all, then definitely recent ones in the biostatistics are asked, which carries marks for all these things. So this is a brief overview pattern of the examinations. I wish you all best of luck. I think we'll start our sessions right now. Thank you.
Thank you, sir, for showing us plan to follow. So now we move on to the first session of clinical case presentation. In this round, there will be two presenters for a case. One will present the case history and examination, and one will discuss about the investigation surgery part. The questions not answered by them will be directed to the examining students in the audience. The first bell will run with 30 minutes, so the discussion of history and examination should be moved further to the investigation surgery part. For the first case, I'll call upon Dr. Arif from Arjigar Kolkata and Dr. Teji from Sri Sathya Sai Institute of Biomedical Sciences, Vaiti, to present the first case. The examiners for this session are Dr. Sitaram Bhatt, Dr. Anil Tendulkar, Dr. Shekhar Rao. Kindly chair the session. Dr. Shekhar Rao sir is not here, so I call upon Dr. Balram to chair the session. There is a candidate assessment sheet given for evaluation. The time limit is 45 minutes and the morning bell will run at 30 minutes.
In fact, they should be sitting on the first row and the teacher should be sitting on the last. But you have that permission of secretary. Secretary is and proposes and H discloses. Apology, we will sit on the last row and doors.
Sitting these people running don't stop
Very good morning to all the faculty and my colleagues. I'm Dr. Sheikh Arif, Article Medical College, Kolkata. My patient is Master Iqbal Hassan, 12 years old male.
You are not supposed to tell you are from which institute. Okay? Even a question of who is your teacher, you are not supposed to answer. And the examiner is not supposed to ask you, this is your which attempt. Understand? So by telling me your name and your institute, you are making me bias. Okay? So please don't do it.
Master Iqbal Hassan, 12 years old male from Mujibnagar, rural Bangladesh. His father is Rabi Hassan, who is a furniture maker by profession. His chief complaints are bluish discoloration of lips and nail beds since 3 years of age, squatting episodes since 5 years of age, and easy fatigability since 5 years of age. History of presenting complaints: the baby was a normal vaginal delivery at home. Post-birth, patient was apparently normal until the age of 3 years, when parents started noticing bluish discoloration of lips and mucous membrane and nail bed, which was insidious in onset, gradually progressive, and apparently aggravated sometimes while playing in hot days or on summer seasons. Patient during these episodes fell and went limp and was non-responsive and spontaneously regaining consciousness. Baby now can anticipate these episodes and squats to prevent distress. The last such episode happened in February 2020. Patient's father also complains of easy fatigability. The baby is not able to play with his peers, which insidious onset, aggravated on exertion, functional class 2, and relieved on resting. Patient's father there is no history of any convulsions, no history of hemoptysis, other features of thromboembolic episodes, no features history of infective endocarditis, no features history of heart failure. Antenatal history: patient's mother was a booked pregnancy and proper antenatal care was taken as per Bangladeshi rules. Birth history: patient was a normal vaginal term delivery at home. Developmental history, there is no history of any delayed developmental milestones. A family history, the baby is the second child out of a non-consanguineous marriage. The elder sibling is healthy. Treatment history, patient was on medication in Dhaka, Bangladesh. Patients cannot specify what drug they were taking. Past history, there is no history of any previous surgeries or other interventions.
Oh, can the patient tell about the number of tablets?
It assesses a single tablet.
Once a day?
Once a day.
At least he knows the milligram written
No,
on
sir.
that? No, nothing. OD tablet.
Yes.
So what are the tablets OD that can be taken?
Patient with this present history.
No. OD tablets, cardiac patient.
Cardiac patients, beta blockers or OD blockers.
Which kind of beta blockers?
Cardioselective beta blockers like propranolol.
Long-acting
Long
beta
acting.
blockers. Not propranolol. Metoprolol. Number 2, diuretic. Number 3, digoxin. Number 4, iron. Understand? See, you have put this into trouble. So now you should be ready with the answers. Okay? You have finished history?
Yes, sir.
Yes. Diagnosis. On history.
Can you summarize yours?
Patient is a 12-year-old male boy with bluish central cyanosis, brief discoloration of lips and mucous membrane. With episodes of cyanotic spells and
Summarize. Now, central cyanosis, you already used adjective. So what is the point in saying mucous membrane, membrane? He's saying summarize. So central cyanosis. 12-year-old boy, central cyanosis. Third word.
squatting, cyanotic spells and squatting episodes.
Okay. Four word, 1 minus 1. Since 3 years old. That is most important.
Yes.
So 12-year-old boy, important. Since 3 years of age, important. Central cyanosis, important. All will lead to a diagnosis. Okay?
So based on your history, whatever Tendulkar was asking, which are the diseases which you can say that patient does not? Obviously, your case is a case of cyanotic, right? So which are the diseases which you can say that most likely this patient doesn't have those?
At the age of 12 years, you will not see a patient of this or diseases.
And also take into consideration that he started his symptoms from the age of 3 years.
Since the patient is cyanotic, he will not be having cyanotic
12 years cyanotic, not possible.
Not possible. Cyanotic unheart disease like ASD.
Cyanotic 12 years.
Cyanotic.
This disease is not possible.
Cyanotic.
You have deleted them just because he's 12 years.
Cyanotic diseases presenting late or not presenting late after.
Here, patient living, surviving for 12 years, cyanotic. This disease is just not possible.
Transposition of great arteries, truncus arteriosus.
Transposition of great arteries, just not possible. Number 2, all complex truncus, hypoplastic left heart syndrome. So all complexes, heart diseases gets ruled out. Infracardial PAPs, optical type of PAPs. Out. So this word I keep on telling all of you. Every word you speak must have some relevance. From etiology to your diagnosis, to your complication, to your management, to your prognosis. You started telling father is furniture maker. How does it matter? Diagnosis changes. Is painter, the diagnosis changes? No. But don't mention that.
Okay, let's see. Father is a furniture maker. Can it be relevant to the patient's diagnosis?
Patient comes from poor socioeconomic background and treated care might not be properly taken and maternal infections.
Anybody else? You must always get a answer.
If he is a furniture maker by profession, then he might be using some kind of techniques. Might include his techniques like ideal
So do not restrict yourself to say that it's only cardiac case. You said think beyond that also. That why can't the patient have that some physical and or some environmental disease affecting his lungs? Okay. So your questions can be taken into any direction. Your case is a cardiac case. But because of the occupation of his father, the questions may be completely now going to the lung case. That which are the diseases which can occur in the patient because of the environment pollution. Answer that question.
For my patient, 12-year-old patient,
Yes.
Other thing I want to tell you, practical exam, don't try to give 25 answers. Try to give the common 2-3 answers and answer quick. Nobody is expecting you to give them 25. Practical exam is performance. Practical exam is to show your practical knowledge. Theory exam is 25 others of occupational lung diseases. Here you tell quickly. You don't know, say don't know quickly. But that also you say quickly.
I don't know. So anybody from audience?
Everybody.
Occupational lung disease.
Occupational lung disease. Asbestosis. Okay. Then silicosis. Then in the older days, cotton mill workers, sugar cane farmers, tobacco. So quickly start telling, rather than trying to think of 25 answers. Give quick, common 2-3 answers. Okay?
Yes. So what Dr. said that is that it. So you must think about these things that if you are saying something, okay, if the question comes, whether you can answer that question or not. You can lead. There are two things: either examiner will lead you, or you can lead the examiner in whichever direction you want. Okay. Now comes the third question. At the age of 3 years, why the late cyanosis appears and which are the again diseases which can rule out because of the late presentation.
this is common in physiology, that is pathology of fallow, DO, VSDPS, TGA, VSDPS, single ventricle PS, these are the delay onset of cyanosis.
Why single ventricle tricuspid atresia should at all have cyanosis late?
Like I said,
These are situations of total mixing right from day one. So tricuspid atresia, single ventricle is total mixing from day one. They will have cyanosis from day one. Etiology of fallow is a differential cyanosis depending upon the shunting of right to left. So right to left shunting more cyanosis, less no cyanosis.
So with EGPSTPS can present at the age of 1.
Simple VSDPS
Can simple VSDPS present cyanosis at birth?
present at 3 years. Why?
Why? They are late presenters with cyanosis.
the baby grows at that age, so it increases metabolic demand. The fetal hemoglobin changes into adult hemoglobin.
One. Second,
The primary pulmonary hypertension reduces.
Why pulmonary hypertension?
Pulmonary hypertension of the
no. See, there are three causes. One is the patient's metabolic activity increases, so demand supply. Second, PDA starts closing. Okay, PDA is open up to at what age the PDA closes usually?
anatomical closure occurs after 3 weeks, physiological closure 10 to 15 hours.
Okay, so that's why the PDA may close. Third, as the child grows, he plays around, so this infundibular obstruction that increases. Okay, so these are the three causes for the late presentation of the cyanosis in clear physiology.
Because of exercise, SVR falls. Exercise results in fall in SVR. Another reason for exercise results in right to left.
So these four answers should be on your page because if you wobble around here and there everywhere, discussion will prolong. You will be spending all of your half an hour with case discussion up to history only. That means that you are being given marks out of the 25 only. Because you are not reached the stage of the examination, investigation, and treatment part. So your answers got to be precise. Okay?
What is the abnormal finding in the history for a diagnosis of tetralogy fellow in this boy?
Cyanotic spell or squatting.
Very good. And
Squatting episodes.
that is abnormal. Cyanotic spell is abnormal. What age? You just not told me.
Delayed at 4 years. Last February 2009.
Correct. So at the age of 11 years, to get cyanotic spell is unusual for a tetralogy. Why?
The infundibular stenosis becomes fixed at 2 years.
Because fibrotic.
Fibrotic.
Number two,
Patients start
you only told
anticipating
the patient anticipates
the cyanotic spell and
adopts a
squats.
squatting position.
Prevented issues.
That is also uncommon. So what could have happened by which at the age of 11 years, 7 months, he develops cyanotic spell like condition? What could have happened?
I don't know.
I must ask you. Suddenly, only in the month of February, March again, because of Holi and so Holi mein kya? That is the cause. Respiratory tract infection. Respiratory tract infection is a very common cause of cyanotic spell-like situation. The only way to distinguish is fever, lung auscultation, with a RAS, and WBC count, etc. will be raised. Remember, respiratory tract infection anytime can push the child into a bad situation. Another complaint you mentioned was early tiredness. Suggest what?
At the age of 12 years, the patient will that like why is he fatigability at the age of 12 years?
There is no adequate oxygenation of the blood.
So muscles
Don't get enough oxygen.
see, not the absolute target. More important, muscles don't get adequate oxygen. The baby feels tired, exhausted. That's all.
What else could have happened?
Get back to the track. Summarize your history, your history, past history, the developmental history, and you summarize that. One
12-year-old male.
12-year-old
Male boy.
boy, male boy, what? There is the female boy there. Don't you brilliant boys. 12-year-old boy, okay. Then
Central cyanosis.
central, what is the meaning of central cyanosis?
Central cyanosis is presence of cyanosis in the lips, mucous membrane, bulbar conjunctiva, also along with male bedside.
What is the basic physiology of central cyanosis? Where does the oxygen saturation go?
The release hemoglobin should be more than 5% or oxygen saturation.
Okay, where is the
Where the
oxygen?
problem takes place? Which part of the
Central
body?
organ.
Heart, sir.
Aorta, not the heart. Aortic saturation is low. That is central cyanosis. Okay. Next, what did you say?
Cyanotic spells, squatting.
Spell. What is a spell?
Paroxysmal deepening of cyanosis along with presence tachypnea characterized by limpness.
What precipitates?
So reduction in SVR or increase in heart rate.
Any condition which reduces the SVR. What reduces the SVR? In this patient, you specifically said that an episode which reduces the SVR.
Hot
What was that?
warm summer, hot
Summer, you said. And exposure to sun, you said. And especially in India, after a hot bath and on exercise. Okay, patient develops what?
Patient develops a hypoxic stimuli, the immatures as well vulnerable respiratory center.
There is a increase in the rate and depth of respiration, starting one, resulting in limpiness, then
Culminating to seizures,
deepening cyanosis, then
she culminating seizures,
sometimes syncope and unconsciousness,
sometimes death.
infrequently convulsions, rarely death. That completes the definition of spell. So he had spells, episode of spells. when there is a spell, what are the possibilities? What are the diseases you think of the patient has got?
Tetralogy of Fallot,
Tetralogy of Fallot,
USDPS, and the tricuspid
tetralogy of Fallot,
Physiology.
Physiology, two,
tricuspid,
tricuspid atresia, three, PSCPS, okay, three, pulmonary atresia. So it boils down to those three. What is tetraphysiology? What's the meaning of
a
tetraphysiology?
group of a spectrum of diseases with reduced pulmonary blood flow and avenue for the right ventricular deoxygenated blood to enter the system circulation.
There is an obstruction from the right ventricle to the lung, from the ventricle to the lung. There is an obstruction. Then that's one component of tetraphysiology. Two,
And then there should be
there is a big CST which allows adduction of the blood, and this blood finds a way to get into the systemic circulation. This is tetraphysiology. Definition of tetraphysiology. So what are the diseases which conforms to this definition, fit into this definition?
tetralogy of Fallot,
Okay,
VSDPS,
okay,
VSDPS, and TGA VSDPS, single ventricle pulmonary disease.
okay, and CCTGB,
TGA VSDPS, TGA
PSD, corrected transposition, PSD, PS. Okay. So don't tell in the examination triology of Fallot. ASDPS is not a tetraphysiology. Don't say tricuspid atresia because they are all the conditions with reduced pulmonary blood flow. They are not tetraphysiology. Understand? Tetraphysiology only these 5, 6 what you said. Is it not? Okay. Then so you had the patient with spell. The examiners are, they're interested in this one question: how do you treat the spell? Though we are not treating at present. So how do you? Because you know that you have to know the answer to go faster.
First, I put the patient in knee chest position, give moist oxygen inhalation.
Knee chest position, why?
Knee chest position gives the major femoral artery and popliteal artery and increases the SCR.
Physiology behind why the patient in knee chest position. Patient assuming that why is it
Increased system of respiratory, reduced deoxygenated blood from the venous circulation going to the heart. Reduced
why is increased venous circulation to the heart? Second, it means why you want to increase
so that the right to left shunt reduces and more blood is pushed into the lungs.
right. So what is the
Anything else, knee chest position does.
Compresses the abdomen and the oxygenated.
It's an increased plasmic circulation.
The-
Compresses the strengthening veins.
Relatively oxygenated blood
As a result,
oxygenated blood
relatively more oxygenated venous blood
reaches the heart.
and the heart. So relative oxygenation is better. Okay? Knee chest
So this type of spell was relieved by
treatment of aortic stroke. What?
Knee chest position,
Oxygen.
oxygenation, IV fluids, reduce
As it recover,
to reduce the viscosity of the blood, increase the
start reducing viscosity.
dehydration precipitates cyanotic spell sometimes. So IV fluids,
Immediately it will be reduced.
not
I think more important that you give some more.
self morphine,
Inhalation.
0.1 1 microgram per kg body weight.
Of
Kg body weight.
what?
Morphine.
Injection morphine.
Yes.
0.1 microgram.
1
1 mg per kg. What else?
Then the patient comes with this injection phenylephrine,
Beta blocker.
Injection
Not relieving.
beta blocker,
Not relieving.
then phenylephrine infusion, sodium
Not
bicarbonate,
relieving. Not relieving.
intubate the patient, mechanical ventilation, intubate.
How mechanical ventilation helps?
It increases the oxygenation of the and
Increase the oxygenation. For mechanical ventilation, you have to paralyze the patient.
injection.
So takes away all the efforts required. Number 2, positive pressure ventilation reduces the systemic venous draining. And of course, the last is improvement in oxygen. Okay? So mechanical ventilation. And last is
If none of this done, then we are looking for emergency physician. modified system.
Why petition? And you have to investigate the petition, get the equal. If the facilities are available, so the petition you can go for intermediate pay.
Okay, or it has to as a paper
The
of
option has to be.
emergency intermediate paper, same modality as. But if at your center, let me,
I said if the facilities are available.
no, more than facility, confidence. So at your center, if you are doing emergency petition, please stick to emergency petition. This is practical answer. You tell what you do. Okay?
After the decision, the patient can understand.
No, sir.
No. Joe said yes.
If it is blocked,
Yeah. Okay. So recurrence of spell is an indication that your test blocked. Okay.
only another is not recurrence of spell, recurrence of cyanosis is after petition in nerve collapse.
Let's go for examination.
So examination of the patient, not the student.
The patient is moderately nourished, alert, conscious, cooperative, vapor dry, height is 27 kgs, weight is 138 centimeters.
Humming.
Sound.
Going in the pocket. Social times.
There is central cyanosis, grade 2 clubbing, no pallor, lymphadenopathy, pedal edema.
You are expected to say severity of symptoms. No book has mentioned how to classify severity of cyanosis. You are expected to tell the severity of cyanosis. Okay? Which are the cases notorious for very severe cyanosis?
Tetralogy of Fallot.
Notorious for severity of cyanosis. Very severe cyanosis. DGA. Very severe cyanosis. And which are the diseases well known for hardly any cyanosis?
Total pulmonary vein
Cardiac, these two extremes. Pulmonary atresia, restricted PDA, notorious for very severe cyanosis. So, every word, see all these add what sir was telling in the morning. Every word you describe changes your diagnosis from one place to another. At the age of 12 years, if you say cyanosis is mild, different diagnosis. If you say cyanosis is severe. And another thing, let me tell all the students, don't be scared of opining. Change of difference of opinion is just difference of perception, difference of experience. But not opining, that means not knowing. So please opine. Don't be afraid that I feel the cyanosis is whatever it might be severe. Okay?
BP is 110-70 millimeters mercury in the left upper limb supine. Pulse rate is 60 beats per minute, regular, normal volume, no special character, equal in all four limbs, and the vessel wall is normal. Saturation is 78% at room air, the neck veins are normal. So, normal volume, no special character.
What are the 6 characters of the pulse? 6 things when you are mentioning the pulse. One is the rate,
Rates, rhythm, volumes, character, any radial or radial delay, and vessel wall characteristics. Equal in all the four.
Value pulses. That's all value pulses. Okay. So that also, that's something what they are. The value pulses are not that is that's synchronous. Okay.
Technology with excellent pulse rate. Humping. This upstroke, good volume.
Patient has multiple atypical collaterals, shunted,
Out of pulmonary collaterals, excellent.
shunted,
Shunted and shunt pattern.
PDA.
See, he was very much worried. Shunt block. So shunt pattern. And
last PDA, aortic regurgitation.
last is 12-year-old, don't forget. Aortic regurgitation. Arif, I am very happy you told in the correct order. Maybe my mistake, but I'm happy. This is the way it should be answered. Aorta pulmonary collateral should be the first answer to be given.
Non-cardiac disease, high volume pulse.
Technology.
AV fistula, pulmonary AV fistula,
Non-cardiovascular disease.
thyrotoxicosis, thyrotoxicosis,
Thyrotoxicosis.
Anemia.
anemia, very, very
Technology fellow is not the technology fellow is known for anemia.
non-cardiac disease.
Anemia.
Anemia is common.
But technology is well known for anemia.
Yes.
Okay? Okay, chalo. Excellent.
So cardiovascular examination, on inspection, the precordium is normal in shape and movement. The apex beat is not visible. There are no visible scars on the precordium.
So what is one word for that?
No previous beat.
On inspection, there is one word in technology. Quiet. Silent is here. Quiet is here. You are all quiet. You may not be silent. Already talking to your friends.
On
Quiet
palpation,
recording.
on palpation, the inspectory findings were confirmed. The apex beat was felt in the fifth intercostal space, 1 inch lateral to the midclavicular line, diffuse RV type of apex. Parasternal grade 2 impulse.
What is the meaning of RV?
The diffuse apex. Probably RV. Diffuse apex and
Think again. Anybody else? Anybody wants to differ with me? What is RV type of the apex? What is LV type of?
just tapping. It's just tapping.
Pardon?
Just tapping apex. Microstomasis.
Rather than using adjective, use descriptive words.
Non-forceful.
Non-forceful.
Incest.
Non-forceful.
LV.
LV type can be divided into forceful ill sustain or forceful bell sustain. Forceful ill sustain will be in volume overload and forceful bell sustain will be in pressure overload.
EV. Sustain. LV type of. EV and well sustain. LV type of.
In this
EV
case,
type.
in this case,
Not in this case. I'm saying what is LV type of the apex, what is RV type of the apex. Okay. So in a cyanotic patient, where will you get the LV type of the apex and where will you get the RV type of the apex?
What is arbitrary?
That is tapping type. Tapping, but you were saying that it just touches and goes.
One small evidence to say, which is given in Jones constant is RV apex is characterless with regard to the
So in cyanotic patients, where will you get the RV type of the apex and in which condition you get the LV type of the apex?
in tetralogy of fallow and phallophysiology with RV type of defects, if tetralogy is associated with aseptic defects or shunted top, large minimapcas,
See, it is very clear. Where will you get the LV type of the apex? Where will you get the RV type of the apex? Cyanotic patient.
Conditional cyanosis where there is cardiomegaly. You are already saying the apex field is landed in the midclavicular line. So what is the experience from this you are saying?
medials. What is medial?
Okay, then it's okay. So answer first question then. LV type of apex is cyanosis.
LV type of defects.
Pardon?
Tetralogy is associated with aseptic defects and
Where will you get the LV and large? LV. Pardon? No. We are going on. Huh? Tricuspid, what type of defects you have? LV type, not the RV type. RV is not in those patients. That is the most significant differential diagnosis of the that was fellow. That was fellow disease tricuspid.
I will prefer not to label apex, just say describe the apex. That is say. Okay.
diffuse characteristic.
Yes.
On auscultation, I've ausculted all the 4 areas. In my
Why no percussion? DNP syllabus says don't percuss. Hiraman, DNP syllabus says don't percuss the patient. Nothing like that. So you have to percuss.
The percussion, the hard borders are not.
What is the first sentence of percussion? upper border of liver dullness in fifth space. That is the first statement of percussion. Statement number 2.
Tympanic note on the left side with a fundal gap.
Okay. Third.
All the heart borders are with nothing but
Right heart border, retrosternal, outside the rib. Left heart border from sternum to apex, is it maintaining the same line? Okay? What does it, what is the first 10 sentence tells you? Liver dullness is right fifth intercostal space.
status solgus.
Anything else? It shows there is no ptosis. Liver has not shifted down. Liver shifts down, whole heart orientation will change. Number 2 is side.
One more thing is second space percussion, left second space. Yeah.
Resonant.
That no, he didn't mention that.
Okay?
If it is dull, what is the
If it is done, what is that?
in a tetraphysiology?
Left second intercostal.
You expect it to be resonate, but if it is dull, then it can be.
Left second
Suggest
space is
what?
which organ?
Pulmonary.
Pulmonary.
So iota is there.
Aorta.
Where do you get iota on the left intercostal space? What is LTG? Tenderly corrected transposition and your tetraphysiology to be tenderly corrected transposition VSDPS. So in the case of tetraphysiology, if you hear a dullness on the left
Second intercostal
intercostal
space.
space, likely that it is a CCT. VSDPS. Sure.
S1 is normal, S2 is single and loud A2 component heard. And a loud, the harsh 3/6 ejection systolic murmur is heard best in the left third intercostal space, left parasternal region, with the diaphragm on stethoscope, best in knee chest position and hand grip, and no change in pulse.
Without knee chest position, you can't hear the murmur?
Best heard in knee chest position.
No. Without knee chest, can you hear or not?
Yes, sir, we can.
So if you can hear it without knee chest, why want to give knee chest?
It's increasing.
You can hear it, no? You can see something with your eyes. Now you want to use what lens and microscope to see what is the time. All these things are done when the murmurs are not heard. Microstenosis, even in left lateral position, murmur not heard. Or aortic vegetation, even in stooping forward, not heard. But aortic murmur heard in prone, supine position, 3/6. Why you want to give? Bending forward. Am I right, sir?
Only when you don't hear that you do that sentence. Otherwise, you don't hear it, it's left-sided or right.
Or you say murmur increases in knee chest position. No, you did not say.
Now, why there is single second heart sound?
So the aorta is anterior.
Okay.
The pulmonary
Metrology fellow, cause of single second heart sound.
single heart sound, don't
Are only one person creating sound? Pulmonary component not creating sound.
It's not close.
It is because of the vein obstruction that the fundibular gland. Okay. Of course, partly what you said is right that the aorta is anterior in this case. Okay. But the infundibular stenosis, that is the main component of the obstruction in this case. Okay. Any other marks?
It is so soft that it is not conducted anterior. Number 2, aorta anterior, pulmonary artery posterior. That is more in transposition.
You can say it is permanently domed. The damming of blood in the infundibular chamber causes the pulmonary valve to be permanently domed. That will finish the.
But Sama, if we say that, some of the examiners will be puzzled also. Okay. Now, any other murmur?
No other murmur in
So,
the.
what is the relation of systolic murmur and severity of tetanus?
As it's inversely proportional. As the intensity increases, the severity is reduced.
SVR.
The severity is less severe of obstruction.
Yeah. So, looking at this long, you said long duration of murmur, and plus what grade murmur?
3/6.
3/6. So, what do you think the severity of tetanus?
Less severe.
Less severe form of tetanus. By severity of tetanus, what really severe you suggest? out of the tetra,
RVOT obstruction.
RVOT obstruction. Anything else the murmur tells you about RVOT obstruction?
The level will tell us the level of obstruction.
Level of obstruction. From where the murmur is starting and where it is getting conducted. More to the left, more to the right. So don't just say in a, all the Purohits tell the mantras in a fast forward manner. So all these things tell you to arrive at a clinical diagnosis of one, severity of RVOT obstruction, level of RVOT obstruction, and way it is conducted. All tell you the anatomy of RVOT obstruction.
So, any other murmur?
Any other murmur?
There are no other murmurs in the axilla.
Which are the murmurs you are looking for?
I'm looking for aortopulmonary pulmonary.
Major
Major aortopulmonary collapse.
Where will you hear it?
The interscapular region.
Pardon?
Interscapular region.
How did you hear them?
There will be continuous murmur.
How will you make it more obvious?
Now here that special postures we are asking you. That in spite of that, you could not hear those murmurs. So what is the posture you give?
Niche position.
No.
Now please stop prompting. Prompting will result in only working of temporal lobe, ear, temporal lobe, tongue out, without using any parietal part of the brain.
You are trying to answer, yes. How?
How we
Suppose this is the fellow. Do the position.
Are back? No. So what prevents you from hearing back murmurs? Thick muscle. Thick muscle. Latissimus dorsi. Trapezius. So you make them flat by bringing the arm forward and
that is scapula out. Okay. Now, what else? One is the aortopulmonary collapse. What other murmur you are looking for?
Any PDA.
PDA. Okay. What else?
Any shunt murmur. Shunt.
Come on, man. You are saying there is no incision, so are you looking for it? Okay. Then
diastolic murmur for aortic regurgitation.
Okay. Aortic regurgitation. What else?
If the BSD becomes restrictive.
Far more common.
Does the BSD become restrictive in technology fellow?
No. If it becomes restrictive, patient will go into
very uncommon here. Far more common cause of early diastolic.
Any other murmur? Okay. Anything else?
Continuous murmur in axilla, if it is present, what does that suggest?
LPS
what? From there is a murmur in the axilla.
Peripheral pulmonary artery. Okay. Any other murmur you are looking for?
Can you hear PR murmur?
Yes, sir.
Because of
absent pulmonary valve.
12 years old. Easy case of absent pulmonary valve. 12-year-old. Correct? Pulmonary valve getting calcified, infective endocarditis, destroyed, all will result in pulmonary regurgitated murmur.
Can they get TR murmur?
If it collapses, the tricuspid reflex collapses. The tricuspid reflex collapses, then
10 minutes.
Okay.
So now, what's your diagnosis?
Cyanotic congenital heart disease, phallophysiology, probably tetralogy of fallow, no features of thromboembolic episodes, infective endocarditis, in sinus rhythm, functional class 2 on medication.
So what do you want to offer to the patient?
After the routine investigations, I let go chest X-ray, ECG, echo to confirm it.
All that is second. What do you want to tell the patient? You want to manage medically, you want to manage surgically. If it is surgery, would you like to tell shunts or would you like to take intracardiac repair?
I like to do an intracardiac repair based on the age.
Why do you want to do that?
Diagnosis of tetralogy of fallow itself is indication of surgery.
Why do you want to do that? Diagnosis like I want to do it. Why you want to do it?
Because it has the best survival. Tetralogy of fallow on cyanotic congenital disease.
Is it a cure for the patient or you are altering the natural history?
You're altering the natural history. Survival.
Why do you say that it is altering the natural history?
The 1 year, 5 year, 10 year survival are above 90%.
It does not match the population. It is near normal lifespan, but not a cure for the patient. So you offer total correction to this patient. what is the chance of survival of the TOF at 12 years?
What is the average lifespan of a TOF unoperated?
At 1 year, at 3 years, at 10 years.
Two-thirds of patients are alive at 1 year. Half the patients are alive at 3 years.
75, 60, 30. Distinction, first class, class class. Okay, it is always asked in the examination, it is always found. Okay, at 1 year, 75%. At 3 years, 60%. At 10 years, 30%.
So average life is less than 20 years of a tetrad unoperated.
90% patients die belong to that.
So your decision to do intracardiac repair will depend on 1, 2, 3, 4, 10.
Confluence of the pulmonary arteries and branchopulmonary arteries.
Confluence of the pulmonary arteries. 2.
LV,
No, the pulmonary artery, finish pulmonary artery.
distal arborization of the pulmonary arteries.
Are
The entire outflow. Distal arborization of the pulmonary wall.
is there any investigation to tell the distal arborization? We are in India, that too in Karnataka. Yeah, sorry. Simple thing. Size of the pulmonary artery. Yeah.
Magun's ratio.
So, confluence and size of pulmonary artery. 1, 2. LV function. In cardiac surgery, if you don't remember anything, always say LV function. Second factor, LV-ESV. Fourth factor, LV-ESV divided by LV-EDV. Like that. But all LV function.
LV
Third,
LV size and function.
that's not something which we discuss.
Mitral annulus
Mitral annulus, etiology of failure.
should be adequately sized.
Oh,
Mitral annulus.
You take it, tell me why you want the money. Why you want the money?
You take that question answer back. If the mitral annulus is less than 2 standard deviations and the LV volume is less than 30 ml per month.
The LV function we have studied and it is normal. Now why you want to mitral annulus? Status of all the 4 valves. Aortic valve, pulmonary valve, tricuspid valve. As the sir was asking you, can you get here? We get it. Okay. 20-year-old failure of RV, we can have here.
I thought you are going to tell me because I want to see for any associated any that answer. Are you kidding? What are the commonest congenital or associated anomalies with TOF?
That is next fifth searching for
Yeah. You have to say 3. 1 is multiple TSC, 2 to 3%, aortic canal defect, 2%, PDA, 4%. All the rest are less than 1. Only these 3. Okay. So how do you confirm your diagnosis? Now you say that you have got a tetra. Yes, X-ray.
X-ray. So ECG, where will you look for? With this in idea, these things in idea, where will you look for? ECG's voltage. So out of these 5 things we discussed, which generates voltage? Ventricle.
Ventricles.
So look at the ventricle.
So there is
Which ventricle?
right ventricle is
Right ventricle to confirm diagnosis. Okay. Next, another ventricle.
Left ventricle.
Left ventricle to see whether it is well developed or not. Okay. So what do you think? Left ventricle well developed or not? D5, D6. What has happened to D5, D6?
QRS complex are small.
QRS complex. Which complex?
LV forces are small.
Which complex in D5, D6?
R complex.
R wave. Why? I'm so surprised.
Why do you want the ECG in soft? Why do you want the ECG? I want to know. That's all. How does it help you in your diagnosis, in your management, in your progress?
The axis, right axis deviation probably correlative to
Tetralogy.
No, but see, when you say right axis deviation, it always means right ventricle hypertrophy. It implies there's no second thought about it.
The left axis deviation.
Anything about right axis deviation and tetralogy?
If suppose there was left axis deviation, then
AV cannot detect.
okay, fine. Then what does the ECG?
Suppose right axis at 179, 179.
Deviation is the when you straight away think of the AV canal. In the differential diagnosis, first patient has got right axis deviation. That was more in favor of the tetralogy fellow. If there is left axis deviation, then what the first diagnosis come to your mind?
Right axis deviation.
Yes. Don't jump out to AV canal.
Axis 179.
Tetralogy fellow is not more than 135 degrees.
Because of balance RV and LV hypertrophy. You must think of something which unusually pushes the axis to the right. So that again goes against the axis of tetralogy. Okay? Dr. Suresh Rao will commonly ask this question. What are the points in your favor in the pediatric case in this ECG? It's basically LV forces. Okay? Chalo. Excellent.
One more thing. Can you say this is DORP on the ECG?
Axis is 150.
No, nothing to do with the axis.
Don't loop around the answer.
The inverted loops counterclockwise moving
No.
viewers.
You have to find out the answer by this afternoon. How does the ECG help you to decide DORP, PSCPS or a TOF? That is why the ECG helps you in your diagnosis. Each thing will give you a little bit.
LV forces. In this case, right ventricle hypertrophy.
Early transition of the RV, R complexes in V1 is the hypertrophy, sorry, RV hypertrophy, and V2 there is transition which suggests a large malaligned VSD acts as an electrical window that captures the RV portion.
So that is the most commonly asked question in tetralogy.
Sudden transition.
Is there a sudden transition in this?
Yes, sir.
There isn't a sudden.
If after the surgery, if you do the ECG, whether the sudden transition still
Remains.
why does it?
Pericardium is electrically not.
Thank you. You heard this answer.
You understand.
And another in pediatric, always remember congenital conduction defects. Okay? Chalo. X-ray.
Yeah.
X-ray is the science of shadow. So now we all talk about shadows. Does it fit into tetralogy?
No, it's not.
No.
The pulmonary way is not accentuated, the lung fields are
So
normal.
the pulmonary segment is not being. What is this?
The pulmonary
Are
is
being well developed?
developed.
Suggesting in this case,
The infantibular stenosis is not severe or there are multiple.
other particular not severe, as per your murmur. Any other cause? Collaterals are well developed. That's why he is alive till the age of 12 years. And cyanosis is not very severe.
What are the features of a classical
The CT ratio will not be enlarged. CT ratio will not be large. Not
What is
Large means what? 99%?
more than
no cardiac? Second,
RP type of effects. Pulmonary be accentuated, aortic knuckle prominent.
Accentuated means being present.
Baying is present. Bay means
Nowadays you don't see gay watch. Otherwise we used to see gay watch.
Aortic knuckle is prominent.
pulmonary artery segment is bayed.
You can do online DDT.
why you say only aortic knuckle? What is an aortic pedicle of the heart? That will be large. Really large aorta is present there. What else?
Then the oligemic lung fields.
Pulmonary oligemia. So if you use these standard words, nobody will ask any further question. Otherwise, I told you, you utter one word, there will be 10 questions to that word.
And you have to tell about the origin.
Pulmonary oligemia.
Origin.
Okay.
Or opine. Say I don't feel origin.
Origin.
Maybe because of well developed collaterals. But opine.
You can always say that. And in adult patient like this, if you are looking for the collaterals, then you have to tell something else also.
Okay. Third is echo. What you want to see? Don't show it.
That confirm my diagnosis, situs solitus, ABVA concordance,
Okay. Pathology, surgeon. Number of PhD sites.
And I think let us go systematically. Sequential analysis of the pathology of fellow, that's okay. That's okay. Let me learn it. Of a case of pathology of fellow on 2D echocardiography. 2D echocardiography, systemic sequential analysis of echocardiography. Situs solidus, VA,
ABVA, VA
concordance, okay.
Systemic cancer training to RA, pulmonary cancer training to LA. And
There is normal systemic and pulmonary venous drainage.
What will you look for in systemic drainage?
Yes. How do you look for the left side SBC on
large
the
corners is greater than 22.
How do you look for the presence or absence of the LSBC on the 2D echo?
Absence of innominate artery, coronation is large, greater than 20.
Can you see the innominate artery on the echo?
Innominate artery.
Innominate veins.
Innominate vein, can you see?
Enlarged coronary sinus.
Enlarged coronary sinus, yes. What else how do you confirm it? Somebody was saying, agitated saline inject where? Yes, left cubital vein.
Left cubital vein, don't say left side.
Okay.
Not.
Okay, then normal systemic and pulmonary venous drainage, right? Then
Intrathecal septum, intrathecal septum.
intrathecal septum is intact or not. So if you are going from the right side, go on from the right side. If you are intrathecal septum, after that you will come what? Tricuspid valve. Then
RV morphology,
here you come the number, size of the VSPs, location of the VSPs. Okay. Then RV size and function. Then come to the RV overflow. What level is the obstruction?
Tell the levels
How
of
severe is the obstruction?
tell the levels of obstruction in pathology.
infundibular, valvular.
Infundibular, there are 3 types of infundibular obstructions. Currently, who Lydia have classified 3 types of infundibular. Infundibular,
Diffuse,
atretic
membranous.
infundibular, and diffusely narrow infundibular.
Okay.
Next level of obstruction, which
Valvular.
all students
No.
forget.
Not valvular.
Annulus.
Annulus.
All surgical students forget annulus.
So you see the pulmonary annulus size and correlate with the your
Body surface.
body surface area. What is the chart called? What is the chart called? Yes, somebody else say? Not cutting on.
Everything is actually
Rolex chart. Okay. Then after that comes the pulmonary valve. Then comes the pulmonary artery, main pulmonary artery. Sometimes you will have the hypoplastic main pulmonary artery. Then comes your pulmonary bifurcation. Okay, whether there is an LPA, RQ, or insignificant or not. And side of the pulmonary artery, you can see up to the hilum on both the sides on the 2D. Once you have finished the right side, then come with the pulmonary venous return. How it is? Okay, LA, where it is draining. Usually, how many veins you can see on the 2D echo draining on
3.
3. Okay.
which one not see?
Right superior.
Right superior. See, by God's grace, only 4 weeks. So 25% will say right superior, 25% will say right inferior, left superior. One of them will be correct. Left inferior. Sure. Next. Don't forget any size.
Then comes your mitral valve annular size, what you are saying, that will tell you about the LV size. Then LV function. Okay, then you come to the aorta. How much the override of the aorta? Okay, whether there is the AR present or not.
One more.
What is the ascending aorta size?
Anything more in the order? Origin of right or the
You can see the proximal main pulmonary artery orifices. Okay, then you go to the whether it is double aortic arch or not, because sometimes these patients may have double aortic arch. Then you see whether it is right arch, left arch. Okay, you have to think that if you are doing a surgery, what all is important to you as a surgeon. You have to analyze your echocardiography accordingly. Okay?
Angio has been done. CAT has been done. Angio has been done. No.
What is the indication for catheterization in this case?
Gray zones in the diagnosis.
This case, technology of fellow, echo shows technology of
multiple abdominal collapses and such.
So in this case, what findings will force you to do that?
If the echo is inconclusive, you will be working in a place where the echo cannot be giving you the full information. So it's an instinctive indication of the surgeon's indication where echo is inconclusive. When is the echo inconclusive? You ask, these are additional ways. They say, I'm not able to tell that. Okay, you have a and okay. If your echo technicians are not very sure about the course of the coronary artery, you ask them this patient, you see big murmurs on the backside. You may or may not, because the alternative is
So clinical echo not correlating. You are hearing a lot of murmur and echo says nothing, or vice versa. A very severe sinuses and echo shows very mild obstruction in the infundibulum.
okay.
Anything disparity you ask for.
Now the echo is done. Echo says that the patient has got cytosolitis, tetralogy of Fallot, large symbiotic BSD, low infundibular stenosis, pulmonary annulus, normal. What will you do?
Avoid yawning.
Patient cytosolitis, tetralogy of Fallot, large symbiotic mala-like BSD, low infundibular obstruction. With what plan you go to the theatre? What are you going to do?
Adequate relief of the artery obstruction and
How do you relieve the obstruction?
division of all the muscular bands obstructing the artery.
You cut the obstructing muscle bands, not all the bands. Especially you leave the septal bands, parietal bands, you cut it. So that adequate size finger enters into the PA. Okay, then what will you do about the BS?
Patch closure of the BSD continuous or interrupted.
The odd.
What will you do?
We use in our institute posterior inferior margin, interrupted structure, partial thickness, 5 mm away from the margin. For the rest of the margin, rolling.
What?
Dacron side.
080.
Adjectives.
What you write down and what you do at your center. He grows, he has been, as he said, first name of the patch. Number 2, posterior margin, anterior margin. Separately, differently, or same. And you stand by what you say. And tell what you do at your center. Future material. Plagiated, non-plagiated. The examiners keep on asking you this one.
Dr. Sitaram Bhatt gave you the scenario of the technology of Fallot. Which approach will we use? What are the different approaches for the repair of the technology of Fallot?
I would like to do RA approach.
What are the different approaches?
RA approach, RV approach, RA
It's not RA, RV, it's trans RV. Trans RV. What else is the third approach? Trans PA. What else?
RV again longitudinal or transverse.
You said transsexual, we can move in like what else the approach? Pardon? It is okay, but I don't think you should mention technology of Fallot. Honestly, you will be carrying the discussion in some other direction. Okay. Any other approach? Pardon? See, what are the classical approaches of this type? Trans-RA, trans-RV, trans-PA,
And stop at that.
then trans-RA, trans-PA, trans-RA, trans-PA. These four. Okay, these are the four approaches. Which approach will you use?
RA approach.
Again, trans-RA. Why you don't want to use trans-RV approach?
The location of the ESD is
Problem is, RV approach is, no RV approach, location of BSD.
if on RA approach I am not able to identify all the margins of the BSD.
Listen, man, again you are going to be vague discussion. Question is specific. Why you prefer trans-RA approach over the trans-RV approach?
RV approach less higher chance of low cardiac output in the post operative.
Pardon?
Higher low cardiac output in the post operative.
Why?
Because
Why? Why you don't want to use trans-RV approach? Why the people are more and more going to the trans-RV
preserve
approach?
pulmonary, normal pulmonary.
That you can preserve from there also.
RV dysfunction.
One is the RV dysfunction. Second is long-term chances of the ventricular arrhythmias. Okay, because you are producing a scar. Okay, you want to describe in our circular time?
No, but already exceeded by 50. Anyway,
Yeah. What's the name, doctor? Sheikh. Okay. Okay, Sheikh. For your history, taking the communications, I would give you 7 out of 10 because you were able to get that history of late cyanosis, spells, and squatting, relieving the spell. This makes the diagnosis of tetra straighter, no other diagnosis. Tetra physiology. In the examination, don't talk about ASDPS, triology, don't talk about BSDPS, nonsense. Tetra physiology. When there is late presentation of the cyanosis, 2, patient has got spells, 3, squatting. And your examination case will be always a typical case, not a complicated case. So these things you bring in, you will get that good marks in the history. Clinical and physical examination, I would again give 7 out of 10 because he has not told a physical sign which is contrary to the tetra. When you know the diagnosis of tetra, better tell those things. Is it not? Even if it's a big LV, you say it is an RV impulse. That is a safe way. Otherwise, you have to do a lot of explanation, like how Dr. Iron was telling. If there is an LV volume overload in a cyanotic patient, you say strike the spit atresia. So that is good. So now differential diagnosis.
sir, I request you to tell why you are giving him 3 marks less for what mistakes of this.
I cannot give 10 out of 10. Only I get 10. Okay. The third one.
So why not 9 out of 10? Why not 8 out of 10?
Okay.
Maybe I can answer that question. See, your marks are not according to what you are telling examiner. How you have taken the history. What are the examination findings? Discussion which follows on that. How you are able to answer those questions. Your marks are decided on that also. In fact, I will say Dr. Sitaram Bhatt is very generous in giving 7 out of 10, 7 out of 10. I would have given him 5 to 6 marks. 5.5 marks he needs for clinical history as well as examination.
Okay. Now for the differential diagnosis, you had a perfect idea about what we are talking about, the tetraphysiology. I gave again 7 out of 10. Clinical. Yes. Clinical, because this is how the examiners will be, they will put it like this. Because once they decide the first, your history taking and communication, the right is 7. Then the tendency is to give 7, 7, 7 only, not 5. You can come back to 5. Then The management and communication skills, I have given to 5 because somewhere the VSD course that we're talking about through IOTA, either use at IOTA, okay, yeah, that was very bad. We in the examination see for 2 things. Have you got common sense? Have you got homicidal tendency? And with IOTA closure of the VSD and June, you have a homicidal tendency. Because this VSD of tetra shall be closed through right atrium or through pulmonary artery or through RUOT. Never through IOTA. You are trying to do it close to IOTA. Okay. I mean, you don't do it. Your teachers might have done after an experience of so many VSD closures, they may do it, but not you. When I ask what you do, you say I do the way your teachers, you have seen it. You say you do that way. Okay. Otherwise, I have a feeling that if you say IOTA, you have a homicidal tendency. Then observation of the procedures, fine, I have given 5 out of 10, and 38 out of 50. That's a pass mark.
By the way, who described the trans-EA approach? Who described this approach? Because I think one more thing you should include in the assessment is literature part of it. Okay. Literature. That should be included.
This is practical exam.
You have to know the results and the
There is a one heading in DLB for
results.
orals. There you are.
So,
Over here,
who decided trans-EA approach? What? Trans-EA approach. Isolated trans-EA approach. Who described? Isolated trans-EA approach for technology of fellow. Anybody from the back?
From Thailand.
He's from Thailand. Huh? Okay.
Pan piece.
What is your first name?
Pan piece.
Pan piece.
But only he does it. So any surgery which is done only by one fellow is useless to the community. A procedure which can be done by a person with an average skill, a reproducible, that is the technique we talked about.
It is nicely said that it is the good technique only in business. The way of saying that.
I said it more expensive.
More students who have not seen a technology of paddles, we have a video.
Yes.
Any question you people want to ask on technology of fellow? Any question from anybody?
No, I'm putting it.
One small question. There is a surgeon here who has done extensive work on technology and described a particular method of IVF research. Are you aware of the surgeon here? Indian contribution to technology. Dr. Badram Iyer has described the method of RVOT going in right in front of you. Any other famous contribution which has altered the management of technology post-operatively? Indian contribution to technology which has changed the management of technology post-operatively.
Regarding the PRPL, dynamic obstruction.
Dynamic obstruction.
We did not come to that.
We did not discuss that. But at
And
least we should
another
aware.
contribution from an Indian regarding the coronary artery crossing the LV, RVO, management of that.
in April.
Dr. Iyer's paper, you have to read it. Indian mathematics, they ask.
See, as I was saying, some part of the literature which will tell you the results. What are the early results, mid-term results, long-term results of pathology of fellow. Okay. What are the post-operative complications in the long run? Who is described the paper? Read about Dr. Lilly's paper himself. Okay. Almost 40 years old follow-up.
Was there any randomized control trial between RV versus RVPA or RAPA approach? Who did that? Randomized control trial between RV and RAPA approach? It is there done by whom? Indian subject, Indian group. Teacher of the questions is right here. Dr. Rajesh Sharma had done comparative trials between RV and RAPA approach. Dr. Stanley got largest series of
Passed away. I have been witness to more than about 600 nephrologists in the 14 years I stayed there. And he always used to do the right thing.
Yes,
I always put a patch.
He pioneered the approach.
And then he never used to do pericardium, which is preserved in glutathione, fresh pericardium. And I had the opportunity to reoperate at least 6 or 7 patients for pulmonary incompetence. I replaced the pulmonary valve. And I was quite surprised to see the pericardium as fresh as ever. So nowadays, I mean, at least
I never use the treated pericardium.
Yeah.
I always use fresh pericardium.
Because for suturing technique easier, a lot of people have seen putting this, treating pericardium with the glutathione on the table is the worst thing. Even for augmentation of the mitral posterior leaflet, I still use fresh pericardium. And there was one patient whom I reoperated, was operated in a Great Vermont Street 25 years ago, one Omani fellow. Same fresh pericardium they have used, fresh as ever. Absolutely. Even though it is difficult to suture, I think it's fresh pericardium is a very good thing.
Teaching them something which is not very common. So just decide what are you teaching, what we should be teaching.
What can you do here?
Thank you for chairing the session. Now, on behalf of Iacts Score, I request President of IAS, Dr. V. Dashi, sir, to present a token of gratitude to the examiners. Dr. Ram Iris, Dr. Anil Taluka, Dr. Sitaram Garu. Students coming up with the secondaries are Dr. Charanjit Apollo Hospital, Chennai, Dr. Girivar from Maulana Azad Medical College, Delhi. The examiners for the session are Dr. Sitaram Bhatt, Dr. Vinayak Shukla, Dr. Neelam Desai. Kindly chair the session, please.
उनको बोलो ऊपर खड़े रहे, चिरंजीव को बोलो ऊपर खड़ा रहे।
Good morning, everyone. So my patient is Mr. Paritosh Pal. He is 47 years aged male from Kolkata. He is an adult with a biopsy patient. He presented us with the history of palpitation on and off for last 12 years, DC on exertion for last 3 years. Patient was apparently already 12 years of age, SCCT 12 years before, but then he started developing palpitations, which was initially exertional, but slowly it increased in the severity, intensity, and now even in test he has palpitations.
What's the age of the patient?
47. 47.
47.
Good English you say slowly only once. English translation धीरे-धीरे बढ़ते गया. Good you say slowly. Good English only once.
Patient gives history that his mother was there, who gives history that even during his childhood age, like around 1 or 2 years of age, he had frequent episodes of fever, cough, and cold, for which he required medical attention. And there was many difficulties, which subsided over the period of time. But again, from last 12 years, these problems have started occurring. He also gives history of dyspnea on exertion, NOAHA grade 2 for initially 1 year, and which has further increased to NOAHA grade 2 for the last 2 years. No orthopnea, no PMT.
What is NYH2 and what is NYH3?
NOAHA2 is dyspnea on exertion, which occurs on accustomed work. And 3 is less than accustomed work. Even like walking small distance, going to the toilet.
Anybody is accustomed. What did you say?
NOAHA 1 is when the patient of cardiac arrest has the problems with unaccustomed activities. Like it is more than normal activities. Like suppose you have to run unaccustomed. So accustomed is what you do regularly, like going to the toilet, going to the suppose is going to his work, toilet, going to the kitchen, eating, normal activities. Marathon runner, or even marathon running is normal, so that's normal. So you have to define the
You just told the reverse. This one and this one should work in coordination. The brain is thinking yes one and you are telling yes, something like that happened.
Number two, the complaints are not invited. Complaints are 1, 2, 3, 4. Patient status is invited. Complaints are dyspnea grade 2 or 1 or 3 or 4. That's all. Dyspnea is not invited. The patient is invited. Don't confuse this is invited and this is invited.
Okay, next.
There is no history of angina on exertion, no history of hemoptysis. Past history is non-diabetic, non-hypertensive, no
See, just 1 minute. If you are saying no history of hemoptysis, no, this negative history has got a very important bearing on your thinking. So whenever you open your mouth, if you say no history of hemoptysis, so what did you have in mind? Why did you take history of hemoptysis? Why are you telling me no history of hemoptysis? What are you trying to convey to me?
because you might
If you have to give me a negative history, there has to be a reason. Positive history also important, negative history also important. So in a case, you have got to be very sure what you are telling me. No history of hemoptysis meaning what are you trying to tell me?
no episodes of infected endocarditis, no tuberculosis, and the patient is non-exertion. So we try to find out the history of cough along with the exertion and
So if there is exertion, they have hemoptysis.
Which cardiac condition give us hemoptysis? There are 3, 4 conditions.
mitral stenosis.
Mitral, very early apoplexy, mitral apoplexy, it is in the first stage of the disease. So you okay, fine. Then one mitral stenosis, second, then see suddenly you have taken your topic to the other side now by giving a negative history.
Okay, go on.
Yes, next.
No significant past histories. There is no anterior history wise. It was a normal vaginal delivery, and we cried right after birth, and all information was complete. Family history. There are
Answers, but maybe you still answer that as a part of the completion. Because you would like to know a lot of other things like tendency. So just as a part of
What is meaning? When you say something, you must know you are saying it for what.
Yeah. So, but as a part of completion, sir,
Perfect. But
we can say
what
that.
disease? Heart disease, you must know at least 1 or 2 conditions which give rise to hemoptysis.
Yeah.
That's all.
So in turn, when you ask the cardiac causes, you should be able to answer. But you can still always end up saying in this there may be no relation. But as it is part of completion, I will tell you that.
So we are trying to find out how much you understand, not how much you know. If you say something, we have to be clear in your mind that you have understood. That is always the basic aim of this exercise.
Okay, now summarize the history.
Did you mention history of syndrome?
yeah, no history of syndrome.
See, palpitations and it is not talk of syndrome.
Told no history of
So history is not complete. Would you like to say something more on history? How your his palpitations are getting relieved, aggravating
Even
factors?
the rest time is
You told all that?
Yeah.
Any medications they took for that? Did they recur or they have any regular pattern? And palpitation history is very important, so to come to some diagnosis. So did you give all those things in your history?
The patient was alright earlier. The patient was apparently alright 12 years back, but he gives the history of palpitation on and off with the exertion since 12 years and dyspnea on exertion since last 3 years. The palpitation was initially associated with the exertion, but it used to get relieved by the rest, but it is now present even at the rest. Dyspnea on exertion since 3 years gradually in onset, now progressed to NYHA from NYHA class to NYHA class 3. This dyspnea is not associated with any kind of posture, diabetic variation or seasonal variation. There is no history of PND or orthopnea. There is no history of CVA or EIA. No history of cough associated with dyspnea on exertion or hemoptysis. There is no history of angina, no history of pedal edema. In past history, he also gives a history of LRTI around 1.5 years back, for which he was hospitalized for 1.5 months. But there are no records available. No history of
to diabetes mellitus, hypertension, tuberculosis. Is there no history of any thyroid disorder? No history of any previous surgery in the past?
You tell the summary of your history. So there was something interesting there to ask you. Yeah.
You say he started having respiratory
Every time. Yeah.
So what happened between birth and 12 years ago? Right? So in between there was no episode of respiratory infection. Why are you asking me to see my one? You're trying to lead us to one side, other side you're if it's a congenital heart disease, then something just does not stop like that. You know, unless there is a onset of health, respiratory tract infection, weight loss, and some other symptoms may develop. So, your history is not taking us educated.
You said
Suddenly, you started with respiratory tract infection, and now you are just going concentrating on palpitations. So, what happened to respiratory tract infection?
in last episode, in here after the increase period, during school week time.
Okay, I will ask you. I will ask you.
Absolutely.
Okay, I will ask you. A patient who has had a recurrent respiratory tract infection in infancy at the age of 1 year, the symptoms of recurrent respiratory tract infection disappears. What are the possibilities?
1 year, right?
At 1 year. I mean, we can go for this patient also. Patient had a recurrent respiratory tract infection, it all of a sudden disappear over a period of time. What are the possibilities?
One thing is that the
Recurrent respiratory tract infection is left to right side. So what are the left to right sides we know of?
ASD,
ASD, VSD, PDA. Okay. ASD, VSD, PDA. Okay. So left to right side.
So development of pulmonary hypertension.
One, development of pulmonary hypertension, recurrent respiratory tract infection disappears. Two,
Then aortic valve collapse of the valve.
so spontaneous closure of the VSD, symptoms disappear. Three,
Then the tricuspid valve.
Yeah, just what
if the patient, okay, two, if the patient had a VSD, I'm telling the patient had a VSD, now the symptoms have disappeared. One is PH, two is spontaneous closure, three is PS. PS, acquired infundibular obstruction. Okay.
Positive.
Okay. What is the definition of what do you define respiration? What is mandatory for respiration? Just PSC case is not respiration. Cyanosis must be there. Okay. Then reversal option. A patient who has got a known case of BSD over a period of time develops acquired infundibular obstruction with reversal of the shunt. If it is not BSD, where else? If it is not BSD, where else can happen?
You find a small BSD personalization there.
So this patient, I have got my diagnosis, even without seeing the patient, I have got some diagnosis. So this patient had recurrent respiratory tract infection. His symptoms disappeared over a period of time. He was perfectly all right. Okay. Unlikely that he had a PH. He has lived to this age of 47 years. Now, since 3 years, he has palpitation. What does the palpitation is a symptom of what disease? One is arrhythmias. Two is volume overload. Okay. Patient has a volume overload, and that is a symptom of an MR or an AR. What are the symptoms of MR? Palpitation and the features of left atrial hypertension, pulmonary venous hypertension. What are the symptoms of AR? Palpitation because of the volume overload. Okay. What is symptom of AS? Classical. Angina, syncodyspnea. What is symptom of mild stenosis? First one is dyspnea. Okay. All the things, pulmonary venous hypertension, left atrial hypertension. Clear about this area. So this patient,
very categorically said palpitation.
palpitation.
And that was lasting for some much longer period than the appearance of dyspnea. So this suggests what?
Overload condition.
Pulmonary condition what? Pulmonary.
Which one?
Aortic valve.
Aortic valve. Both.
So now I would say with your history only I could come to a conclusion of a diagnosis. This patient had a VSD and now he has developed an AR. Without seeing the patient I can tell. But I don't know whether that's the right diagnosis. But that's it. That's thought process. This is how you analyze your history. This is how you have to take it, not just this thing, that thing, this thing.
Same story was dyspnea first and then palpitation. I would have thought of this developing AR. Your story is for long periods of 4 or 5 years, patient had palpitation, and now he has developed this. Goes much favor the patient of either MR or AR. Okay?
So if you had told to question, very intelligent, sir, I wanted to rule out the patient developing pulmonary hypertension. He had, so what are the diseases which has got congenital heart disease which manifests in adult? Which can reach to this age. All the symptoms left to right side in pH. So I wanted that history of hemoptysis. We are told me. Mark, but at that time, Mark will be 10 out of 10. Sir, Mark out of 10 out of 10. Okay, come on, next.
Examination now. Patient is conscious, cooperative, well nourished, is lying comfortably in bed, and well timeless in person. No anemia, salivation, jaundice, clubbing, lymphadenopathy, or any endoscopic needles. Pulse is 82 beats per minute, which is.
This no. After knowing the story narrated by the examiners, which no history, you will take very categorically. Silence. Okay, so you are telling as a full speed. No. You stress on that. Constantly try to show examiner that you mean what you see. You understand what you are saying. Please try to emphasize on.
Is there no history of suggestion of endocarditis? Say that. In this patient, you say that. A small BSD, now AR, you are suspecting 47-year-old. Your patient can have an AR caused by infected endocarditis. Yeah. What are the features suggesting of infected endocarditis? Ask.
There will be fever, then hydrates.
Any other adjective of fever? You want to make it wrong? Which fever? Fever lasts for 1 day, half day, 1 hour, long time. And infected endocarditis was by yourself? No, requires antibiotic. Oral, IV. So requires admission, no admission. Now can you tell all this in one breath? Take a deep breath and answer all this.
Parenteral IV antibiotics and
Very long, lasting, high fever, isolate fever,
requiring admission and IV antibiotics. Okay, that is the history suggestive of infected. Others can have fever. Okay. It could be an infected admission had 1.5 years. You said that. Okay. So that was very relevant. In the examination, that becomes very relevant. That if you score over others, if you bring in that. Okay. Okay, go on. Pulse. He will be pressing now. How many minutes for this?
Pulse 82 beats per minute, it is regular, normal in volume and character.
Now, which one you stress?
the character.
Normal volume. So what has been ruled out? What Dr. Siddharth, what has been trying to establish just for history?
The AR.
AR. Understand? So please now try to stress.
And
You dramatize your history.
So if it is AR, what
it will be high volume ones. High volume.
Upstroke, downstroke, and height. So describe three things: upstroke, downstroke, and height. How is upstroke? Please, please, downstroke, and height. One, large. Okay.
So brisk describes upstroke, collapsing describes downstroke, and water hammer describes both.
It is symmetrical on both sides and filled in all accessible areas. BP is 130 by 70 mmHg at right medium spine level.
When do you say that the pulse pressure is wide?
When the
So you said 130 by 70. At what number you say it is wide?
on the 26.
Correct.
120. 120. 40. To be systolic plus 1/3 of test.
What is that?
120 by 80.
40.
Tell us the B. Okay. Yeah.
Okay, now inspection. Trachea is normal position. Chest is bilaterally symmetrical. Nose comma. Position of are seen in the left side of the precordium. Yes, yes. It is seen in the left precordial area. In during palpation, I confirmed that apex is in the left 6 intervertebral space.
Just be a little smart and just say to me.
6 intervertebral space. It is 170
Inspection and palpation.
Trachea also, I don't know what it was there in your mind, telling the position of the trachea and the apex. So what is your understanding?
Trachea is in normal position.
No, isn't what is your understanding? What do you understand by telling me that the trachea is normal, apex is here? What are you understanding by these two findings? Yes, that is why we always take the trachea and the apex. So your mind has to be very clear that it doesn't shift. It may be a large or small. This is what you have to understand.
Then apex is spread at left intervertebral space, 1 cm lateral to the midclavicular line. It is of lateral to the midclavicular. It is of hyperdynamic type. Personal PV is present. Pulmonary dynamics. That means AR or volume.
So just one. Okay. Clinical position, very important. You can have a hyperdynamic apex and not the volume force. Can you have which condition?
Classic. Which case?
Anemia severe.
Why not in hyperdynamic? Hyperdynamic affects hyperdilatation. Okay. We are discussing a cardiac case. Yeah,
Palpable feet is also present. Auscultation reveals
so palpable feet suggests what?
pulmonary hypertension. PH, pulmonary hypertension.
You also said RD, exercise ventricle edema.
Yeah, personal PV is also present.
Great.
Grade 4 by 6.
4 by 6.
4 by 6. 4 by 6. So what do you support them?
Nobody. Everybody say Yavan.
Demonstrate parasitism. One of the things is EMA exam. Hey, no.
That's why I said, asking, how can you show bias?
Okay, if you don't know, tell us, don't waste our time. You don't know, or you know.
So you can see.
You can see and you are touching. You can't touch the patient and say, I can see. Unless your fingers are visible.
No. And no.
One
chance.
Yes, what is grade 1 paracetamol? You can feel only with the tip of the finger. Okay, grade 2 side and your force can suppress the hand movement. And grade 3, in spite of efforts, of course, mounted effort, this was your hand still moves. Okay, 1/3, 2/3, and 100% each. This is what renewed classification.
Any identical.
Okay. And what are the how do you assess the severity of pH? When you say the pH is severe.
When the patient is present, we can say pH is severe.
You said B2 is low, and PSH grade 3. Severe pH.
Any other cause of paracetamol other than the RD? What is between the sternum and the spine? Structure in a case of thing.
Anybody can answer. What are the other causes of paracetamol apart from RV hypertrophy?
What is that called? This is called anastosis. Right? Anastosis. Correct German pronunciation. As means heart, osis. As touches the vertebra with each pulsation, it pulsates the whole heart, not just paracetamol, the whole record here pulsates. Your inspection will tell you only paracetamol or entire record. So what it is?
Only personally,
Only paracetamol.
Auscultation. S1 is to harden the margin and
Percussion I did, but I want to.
Auscultation S1 is to harden margin and decuspal areas. Sensitive murmur of grade 4/6 heart.
What is the medication in this case?
S1 is normal in all that.
Yes, what? Is it markable between?
No, you can say
speaking also now.
You take 1 minute break and then you say, see, you have to formulate all your findings. We will make all efforts to confuse you. So you have to hold your and tell us exactly your physical findings, keeping the diagnosis in mind. What are your inspection palpations and outcomes? 6V2 is now stressed.
S2 should be
each component of S2. See, this is how 10 questions are being asked. S2 is only component.
A to B2.
And which will be loud?
B2 will be loud.
Why can't you just say that? You want 5 questions. Now 10 questions are asked for one.
Okay, second. Next step.
A pensistric marrow grade 4/6 hard along the left sternal border.
What is the meaning of that 4/6?
That means it is a 3.
Okay.
So after examining the case, I come to the diagnosis of congenital.
There is only one.
Only one.
Only one. That's what specifically you do is what?
AR for AR1.
Cross MR. This is cross MR. Any other marker will be only cross MR. This is what MR or ESG.
So BSD.
ESG.
If it was VSD, again, what would
You are saying the apex.
With the end cap. Yes, sir.
It's not at the apex.
No, at the left sternal border. Left sternal.
If the VSD member, what did you auscultate for?
Pensistric murmur of grade 4/6 hard along the left sternal border.
Left sternal border.
So
Which space?
4th and 5th interfacial space.
Fourth and fifth space. Not in the apex.
Not in the
Not in the apex.
In the apex, I looked for witness like murmur myself, but I could not.
Okay.
I could not.
Okay, you did not hear that. Now, what is your diagnosis?
For AR, I checked, but I murmur.
Okay.
So I came with the diagnosis
Diagnosis
of congenital asthmatic heart disease
Okay.
with left direction at the ventricular level with pulmonary hypertension, no congestive cardiac failure or infective pancreatitis, and no pathognomonic episode, probably ventricular syndrome.
Probably ventricular syndrome. What are the causes of PSN? Ancestral income. Is it ancestral income? What is the
One of the
cause
causes are BSD,
What is
MS, MS, sorry, MR, and TR.
TR. Only three causes. Okay. And this murmur, does it change with the respiration?
It doesn't change. In TR number, it changes.
It changes. So you are thinking that it is BSD because you had a PSN in the left sternal border. Fine. You expected it. Does it explain your patient's symptoms?
I expected AR.
Okay. So what next? You think that it's a BSD. Small, big. Small BSD. Okay. Next.
Next, I want to ask, why you think left direction?
Patient is not cyanosis. This is
Because LLD is still present. You are not told in the complaints.
Now
But any
the-
palpitation, breathlessness, Nadia was age of 1 year. Okay, yeah.
Right. The patient has a murmur, right? Patient has a
When you say pan system,
There has to be left to right.
any other murmur, you have to hear is a left to right shut.
With this, you said this small, small.
That is
So he's not a good clinician. He's not a good clinician. Not able to pick up those
No,
findings.
he should be aware that these are the discrepancies. You have to hear low murmur across mitral valve. That is the diagnosis of left direction across mitral valve. That's why madam asked you, did you hear the left lateral position? With the bell of the stethoscope. All this should be done. Tell that this murmur, I tried, I could not hear.
Okay. One of our examiners else her finding. Okay. So the examiner thinks that it is a, if there is a diastolic murmur, so if the findings were to be a murmur of aortic regurgitation, the collapsing with a VSD. Okay. What is the diagnosis? What is your diagnosis? VSD. Small VSD. No pH. So there are so many things which are contradictory. Examiner says that there is actually there is a collapsing pulse. How do you modify your diagnosis?
AR,
VSD
plus AR.
VSD AR.
For left to do echo and
How does the VSD produce an AR?
one thing, like once the VSD, the AR, the cups collapse, NCC and the RCC, the cups collapse, and the test goes the VSD as a natural history, and then patient develops AR.
How does the AR develop in the case of VSD? First, the chance is yours. Why does it prolapse? Does it prolapse in a big VSD like in a TOF, the earlier case, or in a small VSD? It is in okay. The examiners would like to hear that word big VSD. Okay. Okay. Okay.
Then our coronary cause NCC, RCC, CC, you say that we all confused. You say NCC, we hear RCC. Non-coronary cause prolapses or right coronary cause prolapses. Be very clear in what you say.
Okay. Right.
Dr. Balaram wants to know any other cause.
Any other? With the
Other
patient.
cause of
Yeah.
AR in the VSP.
And in this patient was admitted for pneumonia for 15 days. 6 weeks. Infected hepatitis, the perforation. Okay. Right. Now what next?
We have to go for investigations.
Why do you want to investigate?
To to confirm our diagnosis because here to confirm, so we need to do an ECG, echo, X-ray, and he's a 47-year resident, so we'll do a coronary angiogram. So, and,
Okay. In the ECG, except what do you expect in the ECG and ECG?
What do you expect in these investigations to support your diagnosis? Or to come to a conclusion, how do you want to proceed?
Just tell the
Yes, sir. In ECG, I found the normal sinus rhythm with left axis deviation and signs of left ventricular hypertrophy.
LV
No, sir, not LV.
Why left axis deviation is severe PH?
Is it volume overload or not? What's the difference between
In volume overload, we mostly get the Q waves in the lateral leads. V3, V4, V5, V6.
Why left axis deviation in the presence of severe PH? What is the
features
axis?
of pH on
What is the actual axis?
what are the features?
Did you measure the axis?
So I didn't measure it, but I. Yes.
Without measuring, you are diagnosing left axis. Fantastic. Professor,
Yes, sir. Lead 1 and lead AVF. Lead 1 and AVF. Reaching and yes, sir.
so F is positive, F is negative, and one is positive. What is the axis?
Right.
Left upper quadrant axis. Why are saying equal? It's a minus 45.
Yes, sir.
You said there is pH, there is R where
How do you get the LVH criteria?
S in V1.
S in V1, okay? Right?
R in V5 or V6.
So R there is plus how much
What is your
Total
total?
35. In males.
35.
In males.
So is it 35? Then who said LVH?
I see.
This is how you will lose track of what we are supposed to do, teach and understand and progress.
Is this compatible, easily compatible with your
I
diagnosis?
guess.
Is it compatible?
No, sir.
The first thing I asked you is this patient's ECG. They're all heading towards VSDAR, but there is nothing on the ECG which says anything about VSDAR. No R waves, absolute R waves in V1. It suggests pulmonary hypertension according to you. No left ventricular hypertrophy.
Check for any ventricular volume or
He said, but it is not there. He said,
all goes in favor of a very small pH.
It goes in favor of the small waves.
No pH,
Yeah.
pH, no LPH.
If this ECG is given to you and we don't tell you anything, this will appear like a normal ECG. Nothing wrong.
there is no said left axis.
Right, left upper quadrant axis. Minus 45 axis.
Yeah.
F is minus.
F is the one.
Let me tell you one thing at this stage.
Get the X-ray.
Let me tell you one thing you have to remember. If there is left axis deviation, it doesn't imply left ventricular hypertrophy. Right axis deviation always means right ventricular hypertrophy.
Tell us.
Large ascending goes in favor of
Yeah.
The question now we ask is that the patient's ECG?
What she asked, what did she ask?
That is patient CC. That was
This X-ray, I think you have given us.
You are correct. That is patient CCG, but not this patient CCG.
This is patient sex.
This X-ray is going in favor of whatever we are very close, not the X-ray. So tell us, something is favoring our diagnosis. Something is favoring
CT ratio is 0.55. There is every type of effects. Pulmonary plexus present. Pulmonary is good. It is second one. They will be good.
So what is the X-ray diagnosis?
Of what? This X-ray you say what? Classical diagnosis of what?
Yeah. Yeah. Or small VSD with air. Or small VSD and patient 47-year-old systemic hypertension. What is the blood pressure you said?
130/70.
Okay, next. Food eco.
Situs solitus, levocardia, normal venous drainage, normally rated great arteries, perimembranous HD, 5 mm size with left to right shunt, gradient is 98 mm, vertical line with responded AR.
Tell me the pulmonary pressure of this case.
Which is related pulmonary artery. What other information do we use?
You have already all the information.
Echo plus one of the number.
35 mm.
Sorry, one is 35. Any other method of calculating pulmonary pressure in this case? They are telling you 130 minus and the A. Why? What is 130?
Systemic pressure.
That is every pressure.
Every pressure.
Gradient across the VSD 98. Okay, just keep on using. What is unusual? Something grossly unusual. For a moderate area, every dimension 73.
Can you explain why?
73 and 15 is what?
Every area 73. Gross air.
Gross air and another problem for you now.
Why this air is diagnosed as moderate?
Because
Any other
every
reason? Every EDP has gone up. That the amount of jet that is entering the
Not big. If you find that, then what should you do? Tell the echocardiogram. I see large and big. Not air, not well seen. If you look for something else. This should be as well in the echocardiogram. What is the important one to be coming up echocardiogram is saying on the severe area. Actually severe area.
that's little
mechanically done the echo. Without any chemical.
With the selfie dimensions, the CT has to show something. So that thing, something is either fixed or not.
This is 100%.
Something.
Okay, now what will you do?
The rice patient is of 47 years old. Okay, so I would like to do coronary angiogram.
No, are you suggesting we surgery or not? First thing that,
What is your plan?
surgery, why do you advise surgery? He is symptomatic. Any other problem, When you say what is the indication for surgery, you say
Symptomatic.
what? The indication for surgery is symptoms, because your surgery may offer symptomatic relief. Though may not prolong the life, it may be symptomatic relief. So it will definitely offer a symptomatic relief. So then, for a symptomatic relief, you do the surgery. What surgery? Alternatively, you can repair if you are good at it.
I don't think they get symptomatic relief from the main symptom of palpitation, right? The ECG was normal settings.
Okay. So next, you plan for surgery. So before surgery, you want an angiogram. Why?
Sir, one thing. They are not mentioned about the group. Should they mention? Should not mention?
Yes.
Not mentioned. Not worried, not worried. In this case,
Not in this case.
not worried, because
Case of AR.
plus on X-ray, we have seen
Larger.
a uniformly dilated X-ray. Goes in favor of uniform.
Okay, so you do a coronary angiogram. Why do you want to do a coronary angiogram? So what? Why do you want to do a bypass? No, for a better preservation through this surgery. If there is a significant block, say, of a RCA, and when you give the cardiac to that, it will not go to that segment of myocardium, and your mortality of the surgery is higher if you do not address the associated coronary artery problem. That's why you address the coronary arteries, is it not? So during surgery, what is your plan? How do you, if this patient has got an RCA block, how do you plan the surgery? Okay. Okay, what do you do first? What do you do next?
In the case of
1 minute.
If you want to give an antigrade ratio to its whole, take 1 second before you say something.
As the right side is blocked, so I have to make sure that my perfusion is, myocardial protection strategy is good. So, and even if he's having AR, so we have to give a retrovert
Right coronary block will very quickly tell you whether patient has got perfusion problems. Quickly tell you. Oh. The patient's electrical activity comes to a total standstill very quickly. Obviously, your cardiac is being very. Can you tell me bypass related cannulation in this case? Normally, ABI to do with two stage. Can you do this? Surgeon is doing through aorta. ESP closure also through aorta, and ABI also through aorta.
How do you get on pump? That's what sir is asking. Pump is perfusion. How do you want to get on pump? Or what is your plan?
Don't keep on looking at the echo, okay? Oxygen load is saturated.
We are at surgery now. We are at surgery.
So,
Shall we go for bicameral cannulation or two-stage single cannulation?
bicameral
Bicameral.
So, because
Patient is poor. Economic consideration.
You have to basically go.
Because there is a VSG, we will have a problem of air mobility. You have to go bicameral.
But if the surgeon says, I will do all the job to aorta, still, patient has to be on with snugging of
complete cardiopulmonary bypass.
What cardiac is
Custodial.
Osteal cardiac. Okay. So what cardiac? What solution?
Custodial. Custodial.
What is
Name of the valve.
HT.
Name of the valve.
Valve.
Valve. Valve.
I'll try to repair. If not, we can go.
Age of this age.
They put the right of fire exam.
47. You're not asking.
You got
HT.
What type of study?
That is interest rate. Better preservation. Like,
Okay.
I don't want to interrupt.
That is what you are used to, is it? Okay.
I have seen that, so I'll.
Okay. This is how the examiners. You are leading the examiners to ask questions. Saint Thomas. You say, I mean, if that is being used, you say Saint Thomas. If it is Del Nido, you say Del Nido. And if you are very well versed in the Del Nido and Saint Thomas, you will get questions on that. Be prepared for that. And definitely, custodian, you know the composition.
Some of the
Some of the cases. So what is the major cases you use?
Because it is very rare for subjects like that in your
custodial only.
Custodial only. Sometimes custodial only. So just be firm. Tell them, sir, I am training. See only custodial credits. Perfect. But be firm. From sometimes you have come to always.
Okay, right. Is that over?
Sir, what?
हम सबसे इशारा कर रहे हैं खत्म करो खत्म करो Yeah.
Let us not go into it.
If he said right side aortic valve, yes. If he said right side aortic valve, size of the ascending aorta does not determine anything. Okay. It is the volume of the blood that is distending there. What the volume comes from that shape.
Heart arrested next.
So after I go on.
See, that has been asked for aortic angular size also. Is it flank or one?
Angular size shape of the
After the heart is arrested, we are on 30 bypass. We'll give an RA incision and we'll look for the BSD. We'll close the BSD. Electron or we'll get to close the BSD. After that, we'll give an transverse epidomy and look for the aortic valve.
Just one. This is 5 millimeter base. How do you like to close? Directly to the
Patch. Because it's always better to close with the patch. Directly, we give and it will be the valve with the cast will be if we put direct basically closer, the aortic cast will be affected, the alignment. So it may again
the
be
aortic first will go at here. It's not in this case. 5 millimeters, very membranous BSD.
The function of the bundle medium.
Very careful. It's very close. Very membranous BSD.
Where is the bundle?
And of course, the aortic valve.
Bundle, the bundle is central fibrous.
Say posterior, inferior, and by her, even if you don't understand, it's okay. Say posterior, inferior, angle of the BLC. Okay, that's it. That's it. Even if in the night somebody wakes you up and asks you where is the bundle, posterior, inferior, angle. Okay.
If that ECG is of this patient, what after you do? If that ECG
The LB is not, the ECG there is no LBH.
axis or left upper quadrant axis, which goes against the likelihood of any.
You don't see the vein, you try to open the eye and don't see the vein.
Then we'll try to see the area opposite the jet. That is one thing you can do, and then you can look it from the aorta side. And stop left advent and see from here. Or to fill up the heartbeats.
Take a history. So history was because okay, so
No, to make it right.
it's possible.
Yeah, that.
But they require a lot of
Sorry?
Then the examination, I think I got a collapsing process instead of so that is, I felt it was a finding. And then you talk about Aristotle, but the case is not at all going in favor. So clinical findings are not going in favor.
उसके बाद
Heartbeat does need to be verified. There is no features of heartbeat anywhere on the MCG, on the X-ray, and you are getting a clinical finding. So suppose you get an X-ray during the exam, please correlate your findings with the findings so that you do not make such gross mistakes.
Michael Region does that.
Gross, I don't make such gross mistakes in the final exam. So you have to take it. And then 2D echo correlation, dimensions are very high. So these kind of things you should be able to read out and tell the examiner that these are the grossly moderate AR and echo dimensions are very high. So you have to be worried about the diagnosis. Then as one or two people said, you should ask for the aortic node. The echo is not complete, you can tell them. Then I'm not happy, I would like to ask for some more details of the echo and things like that. So okay. So overall, I think you have to improve on the things. See more cases and try to present more cases.
Discuss them. When you are
Thank you.
Thank you for chairing the session. Now I request Dr. Shekhar sir to present the token of gratitude to Dr. Vinayak Shukla sir and Dr. So now we'll have a short tea break after that.
After this,
Just mementos will give and yeah. Wait.
भैया भैया
Tea break is only for 15 minutes. Please assemble back within 15 minutes at 11:45.
You need to do is buy one equipment like this. See, there is a camera. Okay. The output is coming here. He has a mixer. He has a PPT. So which he keeps switching. And there is a streaming data. It's from Latin. Just to know what it is. Your camera is working. Yes. So once we have this equipment, what is our I just want to know the model. Just take the front and back. Once I get the model itself. Display. So it's a converter. Now take this much. See what's it doing is it's taking one input, going there. Second input from the camera. See here, whoever wants he can keep switching. And this will send it out to the web stream. You can convert from full HD to depending on the speed, you can reduce this even further. This is the device for us. Yeah, this Aditya only is know the model which take this one. Black magic represents. If you buy this one, this will take it. But if you put multiple cameras, now one there, one here, one usually goes to podium, one goes to the chairs. That's what we do. Just remember this. We're sending it at 35 to 40%. क्या हो गया this thing has become full. I forward you this. This is a big business now because people cannot travel. Yeah. What is it? Just so I have the hospital stay, not the place.
Traffic jam with this board. Where did you get banana today? You're carrying long banana. Oh, yeah. That's severe case. Last time. You are the same man. What is the third case? You are presenting. You are presenting. Not presenting. Example. Because just try to address. Total how many students registered?
He started asking me, much outside, program. কি সমস্যা কি কষ্ট
Yeah, the seventh edition of will be sending it's not coming yet. It's on. When it comes, it is not coming yet. We just had a two grade. No, it's not coming. It's not coming. Oh, it's coming. It's coming. It's coming. It's okay. It's coming.
Next. The next students who bring the challenges are Dr. Prasoda, from Yashoda Hospital, and Dr. Shobhit. The examiner for this session are Dr. Anil Tendulkar, Dr. Balram and Dr. Prasanna Singh.
Actually, three patients use one.
This time we are going to do it a little different. We are now going to give you a short tell your history in 5 lines. Finding history. Yeah. Simple this thing. Your relevant clinical findings, and then we will go. See, the examiner may. See, there are different types of examiners. For example, there will be some who will ask a lot of clinical features. We should be ready for that. There are some examiners, like Dr. Sharad Pandey had asked me, see, patient is on the table. What is your diagnosis? Now start, what are you going to do? You have to be ready for that examiner also. So, you need to be ready for everybody.
You will give us your clinical diagnosis. How to support your clinical diagnosis with history of this patient, short history, short examination findings, and what investigations you like to do to confirm your diagnosis. Okay, so what is your diagnosis? Provisional diagnosis.
Diagnosis is a 50-year-old male with severe aortic stenosis, with no features of congestive cardiac failure, infected endocarditis or thrombin. Of degeneration.
You can say, I can't determine the etiology, but first is etiology.
Probably of degenerative origin.
What age of the patient?
50 years.
Okay.
Etiology, what you said?
Degenerative. Okay. So degenerative aortic stenosis without history of infective endocarditis. NYHA class.
Okay, presently in NYHA class 3.
What is NYHA class 3?
Gives symptoms with ordinary physical activity, less than ordinary physical activity. Is NYHA class 3. Ordinary is
Anybody?
walking.
Anybody? Daily routine activities. Routine activities for maintaining self, like visiting toilet, taking bath, going to kitchen. Of course, many of us have what? Kitchen corner, bedroom corner, but expect that indoor, inside the house activity for daily maintenance. That is
What is the surgical implication as a surgeon? You said NYHA class 3. What does it immediately mean as a surgeon?
Indicate to operate.
You have a strong indication, probably a strong indication. Okay.
Yeah. What's your diagnosis? History-wise, short history, short examination.
So from history, he gives symptoms of chest pain associated with sweatings and palpitations occasionally, and one episode of syncope with loss of consciousness and on and off episodes of giddiness, and recent onset of shortness of breath.
Okay. Examination findings.
On physical examination,
supporting.
Supporting. Don't tell it. 5 lines.
pulse is low volume pulse, and BP is 100/60, and on auscultation, I could hear on palpation, the apex beat was heaving type, and there was a thrill felt in the second intercostal space on the right side. And on auscultation, I could hear a 5/6 ejection systolic murmur.
Before you go to the systolic murmurs, what are the heart sounds like in this patient?
S1 was normal, sir.
Okay.
S2 was soft.
What is the reverse split? And how do that clinically differentiate between the normal split and the reverse split?
Normal split is A2 followed by P2, and the split is heard in inspiration and not heard in expiration. And the reverse split is first is P2 and then followed by A2.
So how do you differentiate between the two? Pardon? And during expiration, what will happen? The split will be wider in case it is reverse split. Okay. So ejection systolic murmur is there, no failure. Now from your history and examination, suppose we do not operate upon this patient. What is the prognosis of this patient?
So because he has dyspnea, so his life expectancy will be 2 years.
Is it really that at 2 years all of them drop down dead?
The patient is just like, so if we don't operate, then the pulmonary embolism after 2 years, case might become inoperable.
No. See, prognosis or diagnosis SAD, SAD, syncope, angina, dyspnea. Okay. As these symptoms appear, your life expectancy becomes less. 5 years, 3 years, 2 years.
What is it? 50%, LD 50. That is your health liability. 50% of the patients are dead by
2 years.
With each symptom. So it's not that they live to 2 years and drop down dead.
That is the prognosis, means the probability. Okay? So now how will you investigate?
So typically nobody heard AR.
That is it. Clinically, was there an AR murmur? Even a short murmur?
There was a short early diastolic murmur was.
You have to mention what is the surgical implication. You thought EDM. Now, how will it change my management? You think it is important?
Suppose a case of only AS, one case of AS is grade 1 plus A.
Yeah.
Management difference.
Does it have surgical implication for you?
Mild AR, cardiac of delivery should
Only
be
strategies.
changed.
Yeah.
With AR, the protection, narcotic protection might not be adequate.
Prognosis, pure AS versus ASAR. Liquid oxygen में दबा दो. Oxygen इसको मरने नहीं देते.
Who will have better annulus, ASAR or AS? ASAR. In which case, LV dimension will not be a criterion for deciding AS. Understood? It's not just semantics. It changes your power of thinking. Okay? So, investigation. What is the aim of the investigations?
To confirm my diagnosis and to know if there are any associated lesions.
Associated lesions like hypospadias.
Cardiac.
So, Sunday Mother asked this question very regularly. So, don't just say associated. Then, specific. Whole idea of making fun is to tell you how nonsensical you are talking. Then, exactly. What are associated lesions? In India, Bangladesh, 47-year-old with aortic valve disease.
Coronary artery disease.
Aortic valve disease.
What is it?
Coronary artery disease.
Could be rheumatic disease, degenerative.
Why do you not think it is rheumatic?
He didn't give any history, sir. So
50% don't give arthralgia. Understood? In India, just you cannot say no. What is the percent? 10%. In cardiac surgery, anything confusing? 10%.
For investigation.
do a chest X-ray, ECG, and neck
Before this is an exercise all of you must do. Predict the X-ray of the you examine the patient clinically. Predict the X-ray findings.
Going by clinical picture, tell the X-ray
finding.
Don't tell us X-ray finding of AS. Going by the clinical picture, tell your X-ray finding. X-ray finding starts with CT ratio.
CT ratio will be normal.
Because you found apex inside the 2. The molar best heard along the
second intercostal space.
Right left side.
Right second intercostal
Right
space.
second costal. So ascending aorta will be
dilated.
Will it look like post-tenary dilatation or uniform dilatation?
Post-tenary
dilatation. The murmur was getting conducted to
Carotid. And what do you expect for the MPA segment to be?
This patient having dyspnea.
It has recent onset.
Yes, developing dyspnea. Means what?
Pulmonary hypertension.
EDP has gone up. Air pressure goes up. Pulmonary congestion. Pulmonary venous congestion. Pulmonary artery segment. Okay? 50-year-old. What additional QC?
Calcification of the
Calcification of
ascending aorta or the
aortic valve and
ascending aorta and aortic buckle. Okay? Thank you for saying, not saying for me.
Do you expect the LA to be dilated in this case? This case, dyspnea. You have to check for it. Dyspnea. You say dyspnea. Sir is telling upper lower view. X-ray.
Excellent. So you are wearing that mask for what? Ebola, coronavirus. Airport से अभी तक understood now? Because examiner may ask you what is something unusual in this case. Understand? Okay. So is there anything unusual so far? You revise what you have said already.
You thought in your mind, no? Is that matching what you are seeing there?
CT ratio is not much more than
what you thought. Dyspnea, maybe. It is compatible with dyspnea? Larger CT ratio? Yes. Aortic knuckle prominent?
Yes.
Ascending aorta prominent?
Yes. Is an X-ray of a patient with dyspnea?
Pulmonary venous.
Is this an X-ray of patient with
Dyspnea.
pulmonary congestion?
Congestion.
Can you see this peribronchial?
Okay.
Yes.
I can see many places.
Yes. Can you point where peribronchial cuff is?
You can use that.
Laser.
Ah,
Yeah. So there is peribronchial cuff.
classic peribronchial. That shows bronchial mucosal edema.
Can you see something in the right heart corner?
Is the LA
Is the LA enlarged?
Is the LA enlarged? See from there. What's your name? What's your name?
Pramoda.
Huh?
Pramoda.
Pramoda. Stand here. Look at this. Stand here. Is there any left atrial enlargement in this case?
Where will you look for?
Is there a left atrial enlargement?
Very good. First is appendix. Next is body. So, have you seen? Don't try to correlate with the examiner. But you say where you look for, and you say it is absent. Perfect. Not there. Agreed. But you must know where to.
What is there? What is there here?
See, there is double density.
Okay. All the examiners are seeing little denser. See this part, showing the lower part. See this part, density in this part. See this part,
that line.
and see this part.
One small piece of advice: if you cannot see a X-ray properly, go one step back, not closer. Many times you can see things better when you move back.
One step back, literally one step.
Okay.
Chalo. See what you expect. LV hypertrophy. Anything more about LV hypertrophy? In this case, it's such a cardiomegaly. LV going down. Huh?
What's it called?
LV strain. Strain pattern.
Left ventricular volume overload are you going to see?
Sure.
Dyspnea you are going to see.
ECG.
With a dyspnea.
ECG of this patient.
ECG with dyspnea. What do you check for? Inlay enlargement. See.
No, sir, there.
She wants us to go.
Now, do you have left atrial enlargement?
Left atrial, where are you looking? Amma. Ramada.
Where do you look
Left
for?
atrial enlargement. Where do you look?
P-wave in.
Pardon?
P-wave is what? V1.
V1. Look at V1.
See biphasic P-wave. Can you see?
Can you see that? What is it called as? Something written or rather negative
Deflection.
terminal deflection of the P-wave in V1 more than 1 millimeter.
Square.
Can you see that?
Yes.
Is there a negative terminal deflection? Yes.
Suggesting.
LA enlargement.
Suggesting.
Suggesting as a surgeon nothing.
This case.
You have to
Increase LV.
which is your hometown? Just say. Which is your hometown?
Ongol. Andhra.
Andhra, Ongol. What's the name of the place?
Ongol.
Ongol. You're going to go to you're the new cardiac surgeon in the new institute, and you see this again. Would you be happy to do it as your first case?
No.
Why? Why are you having trepidation? LV.
Any other possibility in this case?
I'll tell you, LVDP CAT is done, LVDP is 7. Now, and I see this atrial enlargement, what should I check for?
Mitral.
Mitral
valve control.
More likely to be stenosis. Okay? Chalo. Next. Not next investigation. Next feature.
LV hypertrophy with average.
But we are more interested in what?
Strain.
Strain. See, hypertrophy is accepted. We are more interested to get more information than. Is there strain?
We are not putting strain on you. Where are you going to check for strain?
P586, Q2, P586.
You can see there. What is that? Yeah. Your exam going or you finished that? Right there. Okay, she's giving an answer. What did you say? And something else is happening. ST depression. So it is compatible with the diagnosis of
Yes.
of
Strain.
strain pattern and straining. So elevated strain pattern is compatible with the diagnosis of
AS.
AS. Okay.
Now, echo will be really for what?
To confirm the diagnosis and annular size of aortic annular size and LV ejection fraction.
Forgot one thing, we are constantly talking why not romantic?
So you want
Cancer was affected and not. Will this patient require this?
chances of the patient having person.
Why?
Why?
Because you are doing something.
What makes you think that I have to arrange for a pacemaker? You are going
This
to
case, 100%.
It's a calcified aortic valve and
Then, correct. Then,
what will be there on the
the aortic annular.
on
ECG?
One thing.
But the
PR prolongation. What is the PR interval?
Not
You're constantly looking at lead 2. PR, why don't you see lead upper lids?
rhythm.
reasons.
So what is the PR interval? 1-6.
It's normal.
It's upper limit of 1-6 is upper limit of normal. At what heart rate? 100. At a heart rate of 100. See, heart rate is 100. Heart rate of 100, 1-6 is the upper limit of normal. It is like saying my blood sugar is normal, 120. See, it's upper limit of normal. So your edema, handling, removing calcium, cardioplegia, hypoxia, anoxia, everything is going to worsen that situation. Just be mentally prepared. You have to warn the patient in advance. Okay? Echo. Always make this habit of asking yourself what you are expecting to see. Then you will be able to answer what is unusual in this, what is lacking in this.
See, we have got a case of severe AS. You are going to your hometown to start a cardiac center. What is the one number that you will see in the entire echo, apart from the ventricular function? One number you will look to think whether I should do this case myself, yourself, or you want to call your mentors to help you.
Annular size.
Okay, the
annular
annular size. Now see this.
Annulus is 25 millimeters.
Anything else? Do you need to do surgery in this patient?
Yes.
Why?
Because it's symptomatic.
And
Calcified aortic valve.
Now we are in echo.
It's a calcified aortic valve with severe aortic stenosis.
Anything on echo?
Gradient is 100 by 50.
I want to know the student. How many of you? What is 100 and what is 50? 100, what is it?
Peak pressure.
50 is
Peak pressure.
Thank you, because I forgot an answer of systolic and diastolic. Okay. So you
Why they are written down SOB, STJ?
Posttraumatic
Suddenly,
growth.
suddenly what is wrong for SOB and STJ?
Aortic stenosis will have an SNA. Sinus of Valsalva.
Why they are interested?
The root is dilated or not being
And STJ?
Sinutubular junction.
Why they are interested?
If we have to do a root replacement or an aortic valve replacement only.
You see, cardiologists want to help you. What? Suddenly now they are all here for. So is this a good case for that? Patient is rich, Ambani's brother.
No, sir.
Money no problem.
No, sir. I prefer a surgical.
Because
What is?
can you draw the aortic root? You knowing by this shape of aortic root with your acting talents? Can you show? It is like this. It is like this, like this, or or like this. Like this.
It's wide
This is
and
synovial junction. Normal synovial junction is 1.1 times bigger than the aneurysm. This is far bigger than that. I wonder whether Tavi all will fit.
Advanced one will not.
All
50 years.
Normal coronary artery in angio, what else we will see?
EP angio will be done.
No, coronary angio.
Calcification of the ostium.
Okay, you see ostial.
Ostium calcification
Anything
of
else? I said there is getting normal coronary angio. What do you see?
Else you will see.
What else will you see?
IT cannulus calcification.
We are telling coronary angio in I do the angiogram and I see a normal coronary. But as a surgeon, what will you see in the normal coronary angiogram of severe aortic stenosis?
If the category is normal, don't report.
They don't report it. You see.
Room size. If they have done a room injection. If they have done anything else.
Anything important. Dominant. Right. Length of the left main. You have a short left main. Are you worried or not worried as a surgeon? You are not going to do CABG, you are not going to do anything. A short left main.
CP tendon.
So it can cause selective perfusion of.
That too, if you are passing a balloon tip catheter, if you are passing a additional cannula, ostial cannula, usually this is not. And also report basic calcification of the aorta.
You may enter one
Selective perfusion.
If you see your corner channel for longer, only one corner is in there. Not the other one. So you can have
You are going to, what is your plan for this patient? Let's assume coronaries are normal.
More investigation.
Anything else you want?
Words.
EAG
What do you want? What is your plan for this patient?
I'll do an aortic valve replacement.
Aortic valve replacement with what valve?
The mechanical valve.
You want to do the mechanical valve. Mechanical valve.
We use Onyx.
You want to use Onyx.
Few descriptive words about
Onyx.
Bireflate valve.
reflex made up of
Pilot carbon.
magnetic carbon.
Whoever wants to speak from you people, stand up and then speak.
And always backside driving is easy. You have to come here.
Bireflate mechanical valve with reflex made of pyrolytic carbon. It's a low profile valve.
Anything? Any peculiarities of this valve? This one particular
This
valve.
particular of this
This
reflex.
leaflet
Company
The opening angle is
is
85 degrees.
no. The onyx is the only valve with a particular opening angle of 90 degrees. Why all others are not 90 degrees, but this can be 90 degrees?
The hinge.
The hinge, something peculiar about the hinge.
All these questions have been asked in the group.
All have been asked. I have put all this in the. What is it? You are in the group. What is so special about the onyx valve, which all other valves, why they are not made to 90 degrees?
So at the hinge there is
They will not close.
They will not close. But in the onyx, what is the peculiarity? How does it allow a 90-degree opened valve to close? What about the pivot joint? There is a local flow inside the whole valve, which allows the leaflet to tilt back as the flow starts diminishing. It causes a micro vortex at the pivot which allows it to rotate back. It's a peculiar design. It does two things. It washes the pivot area, and that is the reason why they claim that this pivot washing allows it to have lower anticoagulation. That's the claim. Okay.
Okay, now your patient is in the operation theatre.
Want to ask
The patient is in the atrium and the disease process is not integrated. Every moment tissue will not get reduction. Disease from other countries. So follow the
You have to give your pros and cons for it.
officially advised for issue officially advised for life expectancy lesser than the life expectancy of the patient.
Okay, now your patient is on the table. You are the primary surgeon. Patient anesthetized, pericarditis is done. Now proceed.
What is you are in that village center, new cardiac center, new perfusion. Before starting the care, what is the perfusion prescription that you will get to the surgeon? What are the things that you are in Dubratalaya and you are going there as first cardiac surgeon and new perfusionist. Deadly combination, new surgeon, new perfusionist, new nurse. That's the new center. Nothing is ready. What are the things that you need to keep it?
It's a development center.
No, but tell me, what are the things? What will you tell the perfusionist? What will you tell the nurse? And what will you tell? What are the things that you keep? What will you tell the
cannula, IRB cannula, two-stage RA cannula to be available.
What is the weight of the patient?
60 kgs.
What size of the cannula you use?
22.
21 or 22 which are size?
Okay, IoT cannula and two-stage. Something else about prescription. Precautions that the perfusionist must keep to prepare when he keeps the pump ready.
Pump to be ready before the induction.
It should be there before induction. Two,
What are they prone to these days during induction? What can happen?
Severe aortic stenosis is equivalent to a, you can have a myocardial infarction.
These patients may
fibrillate. And the only way of resuscitation is to go quickly and cardiac pump they cannot be stoppable. And two,
Cardiac.
before the cardiac closure, pump, something else he keeps ready. What does he do with the pump? What does the circulator do? What? Every pump they circulate and keep ready. Particularly in AS, the pump should be, what should be done to the prime? Every pump is primed and ready. What about the prime? The prime must be warm, and what is the potassium in that? So prime chemistry, prime physical
Biochemistry should be done.
prime biochemistry must be done, and you should see that the potassium is normal. Now you should have warm
And then tell the not to empty the patient. And to go on okay, not to cool down the patient till the time you are
ready to plant.
Okay. Okay, now. Pericardium is open.
Why you are doing all these instructions? You understand?
You know why you don't? Why the prime must be warm? A gush of cold blood, cold fluid will fibrillate the heart again. Potassium low, fibrillate. See, everything is going around.
What is prime is cold? Just general knowledge. No, why it becomes cold? Sorry? Ambient temperature. It is 18 to 24.
So the
18 to 22.
fluid will be
So the entire oxygenator, reservoir, everything is 18 to 22. So perfusionists have to actively be warm. If you tell them to keep the patient warm.
Okay, go to the operating steps. Pericardium is open.
The person.
One of
Take
the
the
speak.
person.
Who wants to speak? You speak? Okay. Tell us the operating steps.
So bypass always aortic cannula, venous cannula, third is cardioplegia, fourth is left heart rate. How do you do left heart
Okay, now
rate?
start.
That is very, if you want to see the card, then you want to see the.
Okay, okay.
Let us take your credit card and it's open and you proceed. So firstly, you will take questions. That is where you fail.
You have to do something wrong.
You must do the examination
Inspection.
Okay. What would you like to observe before you went?
So firstly, the IOTA,
What do you want to see the
whether it is validated or not.
Okay, one is validation.
Validated, classified.
Okay, third. The site where you want to candidate specifically you look for the classification. Okay.
What are the methods of looking for calcification?
My boss used to say, department will calcification. Calcification is never there because it has already gone to break.
If you have got the facility, if they have the chance, you should really focus.
Aortic scanning is the thing for candidate.
And look for this fellows you expect to happen.
Really?
While candidate the order, what the process will be, what you expect in this patient severe areas. So the renal calcium. So the tissue might be degenerated.
Not degenerated, no, severe calcific layers. What are the challenges you in candidate? Aorta.
In him now, so you had very high scale there, the other one comes you discuss maybe in this case, so cannulation of the organ. Second, venous cannulation. Usually the RA in this case is small, is not big. And you are trying to put the two-stage cannula. So to be careful that also cannula. Okay, where will you put your particle line? You want to put the particle cannula. You prefer it's lower area. You want root particle, you want the postal particle. Why? You are right. Why?
Firstly, some component of yours can be removed in this thing. Secondly, it is
Yeah,
also
you can make out in your participation and all.
But why? I say you are right. Give yourself right. Why? This person has got no mind representation. Okay. You feel positive is root part of India, the heart will scan because your LV is not going to empty. The hypertrophic heart. You do not want distension of the heart. Okay, even if you have the LA the heart may still stand. LV will get extended. That is to be the observed part of the heart, just so that you can relieve the intestinal. Okay. Still, people who use the root part of this.
Then was the first cardiac failure, but then you have to see that the ventricle is
not distant.
Not distant.
It's not easy to diagnose distended ventricle in the presence of
Muscle bound ventricle.
Very high IBS thickness, LVPW thickness. That will give you an idea. Okay?
Okay, now you're given the button. Yes, I think.
You know,
at what stage it would be elevated?
Precautions for
elevating.
Which part of the heart? Which part of the heart will elevate? इन्हें बॉडी ऐसा फुल हो गया ऐसा.
This is an important question which was discussed, no?
अरे AS muscle bound ventricle doesn't distend. You cannot see. Something reflection of left heart.
Right.
Anesthetic is used regularly. Pulmonary artery full.
Deep.
Pulmonary artery full. Remember your line.
Okay. So you have to vent the LA. Some people, this is different from certain to certain. Some people will like to vent the LA after the process. Okay. Some people will like to vent the LA even before
going after.
But there, you have to ask the anesthetist to hold the breath in this place.
Why?
Ask the pathologist to fill up the heart.
Why? Why? Fill the heart and make the area pressure positive.
And third thing, if you are using a fan which is got a side arm for the air, that arm must be clamped.
before you put the action. And ask your assistant not to suck, because you have to have some blood over the stab site. So these 4 precautions you must take if you want to vent the heart with the aortic process. Okay, right. Now you open the aorta. Okay.
Incision described.
What sort of incision you will take? What sort of incision you will take in this case? What sort of incision you will take if the another size was say 19 or 77?
Where do you start? Where do you start? Where do you end?
You are doing a transfer sir.
All incision.
Where do you, what are they?
Where do you end? This side, that side, away from what? Every incision.
You just take a knife and slice on the aorta. No, no. You have to
Where
decide.
do you start? Where do you end? Start with what instrument?
See, 1 centimeter above the arch, so maybe 2. Okay.
What is the classical description? If you say horizontal diaphragm, the classical description. People may do it different, but
With respect to what structure?
what is the classical description given in Kirkland? What lower border will be?
Right.
Pyloric,
Right.
pulmonary artery. That is the classical description. People
Where
may
do you
take
start? Anterior. Block position.
and then
We extend the incision with what? Neo scissor? No. Beds and bombs.
and then what do? You look it, you extend a little bit, you look inside, and then extend it further.
First cardiac delivery to why?
What is the ratio of the cardiac pressure between the left and right? Suppose I have to give 1200 ml of cardiac pressure. How much will be to the left? How much to the right? It is right boundary system. Pardon? 75%.
So which one? 70%?
Right. You said right.
You said right.
Now you are left with no choice but to say.
Like you said 70% right, you were hearing it. And people tell me that recording it is there.
So you have given the cardiac pressure.
So why left? Why left first? Sorry.
This is the fasting area of the myocardium.
No, sir is saying super right dominance.
Super dominant.
Super.
I didn't say
PLV, 2 PLVs.
Yeah. But what is there right in front of you or something? Which is seen right in front of you?
left corner you also just
Just
see.
down right in front of you.
This is the right corner, left corner, the ostium cannula is straight. While right is R.
You put the cannula in. How do I know that I am actually delivering cardiac? No. You put the cardiac and you say cardioplegia on. But heart is not arresting. Now I want to know whether the cardiac, as soon as you put the cannula, heart would arrest, but it will be beating a little bit. Now I want to know that the cardiac is going properly. What
The
is
concept of cardiac surgery is constant counterage.
The pulmonaries get full and they come.
Coronaries are easy to see first.
Which coronary is easy to say?
Left side you want.
You won't see right, it is hypertrophic.
If at all, LAD. If at all, LAD. Number 2, blood coming from right ostium will start coming from right.
Related to the opposite ostium.
Color black in color. Slowly it will start improving.
And then what happens to the cannula? Your
It will become cold. The metal part of the cannula will
cold, and what happens? There will be steam, not steam, condensation on the cannula, metal cannula.
At the same time you ask the
So this is
whether
what
he is able to flow and what pressure.
pressure and flow. So he must be able to give pressure, he must be good. Heart does not stop.
But by the way, normal pressure does not mean cardiac
It is going.
You hold it to the air, but
It
he will
is
say,
it
I
is
have
going.
no problem, no obstruction. You hold it to air.
Heart not stopping at this stage. I have given 600, 700 ml. Heart not stopping. 450 ml. Heart not stopping. What thing?
What will you do next? Give it into
Right.
right. Give it into
right.
And heart immediately stops because
Why?
dominance.
Dominance and dominance from the right side.
Why does the right for the rapid
Cellular.
AV nodal ads.
How do you
But we are
measure
doing surgery.
part size?
You say something? For the total case or for surgery?
One measurement per eye.
Okay.
One
Now,
measurement.
how do you measure the valve? You excite the valve. How do you size the valve? What are the
How do you size the one?
size the valve?
Sorry, size pushing a pellet.
Where do you plunge the knife? Where do you plunge your knife? You are going to have a knife, you are going to have the this thing, and you want to plunge the knife. Where are you going to plunge the knife?
Plunge to go.
Or whatever you want. Cut. Where are you starting?
You start sizing the valve from where? Which science, which
How many seconds delay is there?
Right? Why?
33% of coming current. Because there are only three.
Why do you plunge your knife there? Or you start your excision there? If I plunge the knife in the non-coronary, what suction can we get? What is below that I can plunge? See, everywhere when we say plunge, we have to plunge into a safe area. So obviously this is not safe. If I plunge it like this, what can I get? Bundle up. What is there below?
Proof of the
If I plunge it in LCC posteriorly, I plunge. What can I damage?
is going to be defined.
If you go outside into the transfer sinus, you will have a big problem.
So right in line in front of you.
Start the superficial most part of the hand. Annulus is oblique, not given in any book. All surgeons will compare with it. Annulus is name of the annulus is oblique. Highest point is RCC, NCC, junction. And then the annulus starts
Going down and
the center of NCC is the deepest.
And there, what if you plunge there? What are you, where is the knife going to plunge to?
No.
LVOT. If you plunge this way, the knife is directed towards the LVOT. That is why they say. Okay, continue.
Okay, so you excite the valve. Now, how do you size the valve? That was the question of control.
Anybody?
Why for 20 minutes?
All measurement.
5 minutes only.
Black ink, black ink, black ink. Sir, with the permission of Dr. Balaram and Dr.
I want to eat.
Dr. Sitaram Bhatt, both. नहीं सर उनके लिए आपके लिए पूछ रहा हूँ कि आपका क्वेश्चन में खाली उनको
Switch to that. You switch to that.
Now, how do you place?
my drovers in more it's a entire training for to avoid shouting. He said slap. Help yourself.
Which value is it? Huh?
I'm going to say one measure she gives you all.
Onyx is which value size? Onyx actually comes with how many sizes?
There's no 125 that actually confirm as only one size.
Oh really? Onyx is what? What's the peculiarity of Onyx size? You said Onyx. Onyx, what you said Onyx? I'm asking you this question. What is the peculiarity of Onyx sizes?
The regular one, don't say that one.
There's only one size, 25 by 33.
That is a mitral position, Amma. But we are not talking about mitral position. I am telling Onyx sizes. What is the peculiarity of Onyx sizes? They have actually if you see the tray, there is a black colored sizer, what I call greyish colored sizer, and a yellowish colored sizer. What is it? Why they have two sizes?
Supraannular and the annular.
What is the supraannular placement and this? Okay, then. How do you do the sizing? You, which one do you do?
Number 2. Second.
And how do you place the size?
First, we have to start with number 1. That is called barrel or cylinder. It tells you the diameter of the aortic annulus on table. Ideally, should be done after passing all the interrupted sutures. Because you convert a circle into a polygon. Okay? Number 2 is called supraannular mechanical valve measurer. It tells you whether after passing the valve, coronary ostia will get obstructed or not. It is also called mechanical valve replica. What is replica? Exactly same size and shape as against model. And 3 is a biological valve replica. It not only tells you the supraannular placement, it also tells you whether the stent post will obstruct the closure of aorta.
And also where is the orientation of coronaries in a bicuspid valve?
Understood? So, in the mechanical valve, first 1 and then 2, then biological valve, first 1 and then 3. We wrongly call all as valve measurer. Some of the companies have got cylinder at one end and the supraannular measurer
Which is
at
what
the other.
Iacts has got. Yes, that is why I asked you.
So you first is that we tell you that annulus is indeed 25, and now you go for 25 size supraannular measurer. Whether is it obstructing the annulus? Will it fit supraannular? If no, you go one size bigger.
Okay, now the last question addresses. If suppose your annulus was 17 millimeter, just enumerate the various enlargement procedures for your.
Next, management cell.
Pardon?
For root enlargement. For root enlargement disease. Next procedure, management procedure.
What is this procedure?
The incision is extended at the middle of the non-coronary vessel.
That's why sir was asking you what will be your incision for 35 size annulus and for 16 size annulus.
And how much can you enlarge this procedure? Usually about one size. Okay? Then manual procedure. What is it? Where do you put the incision? Where do you enlarge that procedure?
Towards the right side of the midpoint of non-coronary vessel.
No. That again is next procedure.
Where do you enlarge it?
Where did you go to? Manoj here.
Where do you enlarge it?
You want
diagram of the root and show us there.
draw the diagram for the root. We have posted a picture also for you people, no? Do it twice, good one.
This is called Jaipur Turki style painting. 2 inch by 2 inch painting. 1 Krishna Kanhaiya, 5 Gopi, 6 Hiran, 8 Pala. Can you use the whole?
Make a big circle
The
up.
whole, allow, no extra charge.
Always make a big diagram.
From surgeon's viewpoint, huh?
You are the surgeon.
Really? Really?
So first tell which is right, which is left. Perfect. So your side is right. 6 o'clock is right. Quickly write down. Outside the circle. Right. Left.
Which is left
12 o'clock. 12 o'clock left.
Left.
3 o'clock anterior.
Cephalic.
Anterior, chest wall, sternum. To your right. Shabas. Kone A. Yeah, that is good. And then P, posterior. So people are oriented. Very good. Listen.
Now,
This is for writing for whom? For us or you? Writing for everybody now. So right now, font 96, 104. Understand? Don't write as a font level. Okay, chalo. Draw 3 cuts quickly. Aorta. 1 anterior, 2 posterior. Perfect, perfect, perfect. 1 anterior, 2 posterior. Make it up.
wow.
This every day you must draw. Every day.
There are 5 diagrams as called.
Every
No?
day you must draw. Arey, make a Mercedes Benz yaar. The only time a cardiac surgeon enjoys is that unequal.
What is this? This is some.
Just draw one Mercedes Benz.
Which is
Okay? Very good. Chalo.
My God. There are 3 coronary arteries.
Yes. Perfect. Now, sir is asking you.
Is that the coronary arteries there? Can you make it better? The diagram.
Okay, what's your name?
Right.
What's your name?
Dr. Shobit.
Don't draw coronaries inside the circle. Thank you. Don't draw inside the circle.
There is a surgical implication of a coronary being within the sinotubular junction. That's how you enter the trouble.
So where are your incisions now? Going down in the root.
Can you slightly turn and stand? What is that? Show me, sir.
Subaortic structures can you draw? Subaortic structures. The different color you can show. Quickly.
All of you know the diagram by Anup, no? That famous diagram by Anup.
So, anyway, where is AML? AML. What discussion is AML?
Where is AML?
Sir, see, by God's grace, only 360 degrees. Go on moving. Middle of left and middle of non-coronary is AML.
You go in and it is like a tube, no? If someone else can draw.
This is right. This is non-coronary. This is left coronary.
Left coronary.
This is center of this is the AML. Over a junction of this, under this is bundle. And next to that will be perimembranous septum. So this is the free area. This is the free area. Okay? This diagram every day you must draw. But
So,
nice large big.
next first day to say, details of the non-coronary and okay. And what was managed?
What is here? Where does it go?
That is every
Junction of
part left and the non-coronary.
left and non-coronary. Ali.
And that one you can use to enlarge the multiple elements of the required. What about the mono? Very depending sequence.
Yeah, but how do you say? I don't see all those. Initiation, what landmark?
So right corner we draw like a right corner we
Big.
Shabbas. Thank you.
So it has
To
to be.
left of that.
So can you do a corner transfer as a oh I find I cannot put it. Can I just do okay? I put a transfer cell pattern and I say oh now I can't put a well and now shall I start doing a corner? Can you do that? As an afterthought?
Answer is no.
Why?
What will you require?
Calibration, if the higher quaternion has to be vertical. Okay, you are extending it this way. You can't suddenly veer around and make a jigsaw puzzle of the high. Septum and aorta. It is not done as an afterthought, it is a planned operation.
Okay.
So every operation you must know hard, not fun.
Now I request Dr. Anil to tell us regarding the candidate performance. Candidate performance.
All the students are not understanding the relation between their findings and its implication with respect to the diagnosis, with respect to management, with respect to health. They are just getting findings for the sake of findings. They are happy that the findings are correlating with the master finding chart. It just come from the ectopic focus for this activation comes from. So they are more interested in planning their finding rather than understanding what it means. The murmur on right side of the sternum, what does it mean? It is an aortoid diameter. So all these implications you must know.
Universal.
If she is saying connects one, she must know details about how to measure. How to measure is the most important part of anyone. And the student after student, except other 4 students, they are constantly finding, they are more interested in telling their findings rather than understanding what it means. With respect to diagnosis, with respect to etiology, with respect to prognosis, with respect to management, procedure, everything. This case in India, aortic valve disease, rheumatic heart disease has to be ruled out. This just goes without saying. And we are seeing enough patients. Just because patients coming at 50, we are declared this is degenerative heart disease. So that's why I'm saying actual mark 4.5 and 5 is just a semantic song. See, examination is personal. I give more importance to student understand. The way you arrive at the diagnosis is more important rather than arriving at the diagnosis. It's taken for granted that you know the case. Supervisor has told you this. It is your intelligence to show how you have used your intelligence and you have arrived at the diagnosis. What does that mean? That is more important. This is everybody's persistent. Year after year, we are more interested in asking those. And supervisor also want to be very nice by telling them this is you are more interested. Just forget about that. Examine. See, we are just keeping our mind open. Why we can ask now? Why we can ask questions? Because our minds are open. If we are also personally agree, we are already great at histological. Now all questions will be technological. But we don't know the diagnosis. So we started thinking quite, asked perfectly that this ECG is not rest, but she was not fixed. If she was told that this is exam, she would have asked this question. Because we are not knowing, so we are free to ask questions. We are thinking in one direction. We look at one track over there. This is degenerative about experiments. Is that right? So you read this first and then start asking.
That is why it is very important to consider the hypothetical equation. What we do is, like, that's reconstruct equation there on the board. Okay, you say LA, 10 lakhs, okay, you say LA, you think this is. So when you fit this way, does that match with my actual finding? Then, does it correlate with my X-ray? Does it correlate with my ECG? Does it correlate with my X? We found lots of things not correlating with the case. Consider given explanation as to why it doesn't happen. It might not happen. Okay, this is the reason. For example, if we saw the patient with AS with the 7 point something. Now, if you go back and BP recording, if the AV is very, very high, if the right study is like, that's not the case with the operating as a first case.
Thank you so for sharing the session. Now I request Dr. Deven Desai ma'am to present a token of gratitude to Dr. Prasanna Sinha. A true master is not one with most wits, but one who creates most masters. Let's move on to the masterclass session. Now, a condition which is diagnostically challenging, deceptive in presentation, and potentially lethal in outcomes. So now we're going to talk about aortic dissection. I invite Dr. V.V. Bashi, President of ICTS, to give us a master's outlook on aortic dissection.
We have to change it.
Thank you. I must admit I'm not a master. Yes, I'm throwing the master there. He is the master of aortic surgery. You must always remember his name. Two names in cardiac surgery is Denton Cooley and Michael DeBakey, who has contributed so much to aortic surgery and cardiac surgery in terms. And then when I was a student, my boss used to ask me, somebody asked you which operation, who has done this operation, or show an instrument. Who is the person who first used it? You either say Nivegi or Kuli. You will be right. Those days only either Kulis, clamp, Nivegi, forceps, so many other things. They innovated so much when cardiac surgery was in infancy. And you all know that he. Okay, thank you. So he died of acute typhoid dissection. I mean, he didn't die of dissection, he developed acute typhoid dissection, and they were debating whether to operate him or not. And he initially refused, but he got operated at a stormy post-operative period, and he survived and lived for another 1.5 years. He died before completing his 100th birthday. So this is a dissection of the aortic and you can see how the dissection spreads in a fraction of a second. And it depends upon the clinical symptoms, and everything depends upon which part of the aorta the dissection goes. You can see in type A dissection, the entry point is always in the ascending aorta. The aorta tears there and creates a false lumen and a true lumen. You can see that. And the presentation of the patients depends upon up to which level it is spread and which are the vessels in the aorta which is involved. It can start from the coronary arteries, malperfusion, from the aortic arch, it can present the neurological symptoms, or the visceral vessels or the lower limbs, which I will come in next. So for you to remember what are the risk factors in acute aortic dissection, you made a tip, backaches, you expand. Even though it is not in the order of frequency, I would say the commonest cause is uncontrolled hypertension, followed by bicuspid aortic valve, existing aneurysms, or patients who had previous cardiac surgery, like sometimes cannulation sites or top end of the grafts in coronary artery bypass surgery, or sometimes you make an injury during cannulation, sometimes aortic cannulation. In fact, I had a case about 6 months ago. We were doing a mitral replacement and then took a stitch. After it came off bypass, they tried to put a stitch on the aortic root on the cardioplegic side. The whole aorta dissected in about 10 seconds. By the time I was in the theater, I could put a cross clamp and we could replace the ascending aorta and save the patient. So it can happen, and you should be prepared. Otherwise, a case where there is no dissection, sometimes accidentally it can occur, especially in older people with thin aorta, which is fragile. And of course, this classification is well known. DeBakey's and Stanford classification, type A and type B. And the another classification is according to the chronicity, acute dissection when the patients present within 1 to 14 days, subacute within 3 months, and chronic if the patient presents after 14 days or more than 90 days. Now, the frequency of primary tear in type A dissection is always in the majority of the tear in the ascending aorta. You can see almost 80%. Distal tears can happen distal to either in the aortic arch or distal to the arch, and it can present retrogradely. Sometimes you may be caught with a surprise when you open patient from the type A dissection with the initial CT aortogram. So it is very important to diagnose this disease very, very accurately. Of course, today with the CT aortogram, which is the most important test, you can diagnose it. Now, the life-threatening complication of type A aortic dissection. If you remember aortic, first is aortic insufficiency, and acute aortic insufficiency, the patient can die because the LV will just dilate in a patient who is otherwise normal aortic valve. Occlusion of the coronary artery, patient may present with angina. Sometimes the acute type A dissection can be misdiagnosed as coronary artery disease, acute myocardial infarction. I had sometimes operated on patients who have been thrombolized with the diagnosis of acute myocardial infarction. So one has to remember that. And rupture of the aorta, patient may not reach the hospital depending upon when it has occurred, because the patient may die immediately unless it happens in the hospital or nearby, they will not survive. Patient can present with tamponade, or ischemia of the viscera, sometimes abdominal pain. Patients, one patient came to me after 3 days. Patient was admitted with abdominal pain. They did ultrasound abdomen to find out. Then they found abnormality in the aorta. Did a abdominal CT scan, and they found a dissection. Then did a CT aortogram, and patient was referred for surgery. So these are the patients who are stable. Sometimes they can present with the patient may be brought unconscious. Patients may have paralysis of the lower limbs or hemiplegia depending upon the involvement. And as I said, the classical symptoms, there are some patients I have seen explaining, saying that something has gone round my back downwards of the back. Because a splitting pain, which is like a knife cutting your chest. So many ways they can present. Sometimes the dissection is so severe, patient may become unconscious if the head vessels are involved. So all depends upon the area of involvement and the extent of involvement of the aorta and the branch vessel involvement. So you need to have a high index of suspicion, because when the patient goes with a chest pain in a nearby hospital, maybe they may not be able to diagnose it. They may go to another place, and then finally only it will come to you. So if untreated, you see what happens. This is one of the reasons for death. You can rupture. 33% of the patients die in 24 hours, and 50% of them die in 48 hours. And the 2-week mortality is almost approaching 75%. So in our country, because of lack of availability of facilities in the remote parts, how many people will come to the hospital after how many days? It is very difficult. So we don't have a real statistical analysis of the incidence of aortic dissection. Now, X-ray chest, of course, may not give much information, but the gold standard is CT aortogram. CT aortogram. You can see now a patient comes with a suspected aortic dissection or a chest pain where you are not able to diagnose. The first investigation, most of the emergency units, the CT is available. They do a plain CT, and if suspicion of aortic problem, you have to do a CT aortogram. So, if investigations you are asked what is the most and one single investigation you do in a type aortic dissection, it is a CT aortogram. CT aortogram can diagnose so many things. Where is the entry point? Where there is multiple entry point, there is occlusion of the vessels, hair in the section of the coronaries, arch vessels. So olden days it was not available. Only thing investigation you have to do a regular aortogram, which will not give any of this information. Now we are very lucky that we can get. Not only that, you need a person to interpret that also. So I would suggest, because I belong to a generation where I know only to interpret an X-ray. Even CT scan was not there in my days. Only when you ask a question, last investigation, computerized CAT because CAT scan. CAT can also be done. That's only in theory we write as the last investigation. We've never seen one. But you should be able to interpret as the next generation, all of you should be able to interpret the CT aortogram. Is very important. Middle of the night, a patient comes, you may have to take a decision by yourself as to how to plan the management. The most important single thing in aortic surgery, or for that matter, any operation you do, is the decision making. As I told in the morning, planning of the operation. If you are prepared for the worst, you will not land up in a problem. Always expect some problems down the line. So if CT is analyzed properly, that can prevent you from landing up a lot of problems. Now the next, another investigation is a transesophageal echo. Suppose you don't have a transesophageal echo, patient comes with a dissection. Middle of the night, nobody is doing a CT aortogram. You can do a CT transesophageal echo, which show you up to the aortic arch and distal aortic arch only you cannot see properly, but ascending aorta and descending aorta you can see properly. You can see the flap moving. Not only that, it will show you the anatomy and morphology of the aortic valve, whether the tricuspid valve, whether the leaflets are bad, whether there's calcium. So that will help you in taking a decision. The most important thing is, I have written the blood pressure control 3 times because that is usually forgotten. A patient comes with chest pain in aortic dissection because I had lost patients waiting in the casualty because nobody bothered to check the pressure, because pressure will be 200 sometimes. And also patient will be having severe pain. It It is very, very important. Always, as I always tell, very important to listen to the patient. When a patient complains to you something, like you're not in this iota also, you should never underestimate the symptom of a patient. Always give effort. Sometimes, 90% of the time, they will have be pointing to you to something because you don't take it seriously and take it very casually. Afterwards, you may live to regret for what you have not done. It's very important. Listen to the patient always, because 90% of the time you will be rewarded for the action you do for the patient. So, analgesics and proper control of blood pressure. That's very important. You can have nitroglycerin, so many good medications are available. Now, the principles of treatment depends upon the tear in the aorta. Suppose it in ascending aortic tear, just replacement of the ascending aorta is enough. But when the aortic root is involved, you have to replace, if the aortic valve is also involved. Either if the valve is good, you can do a valve sparing root operation, which can be done only in very experienced hands. But if you are not experienced in doing that, you can do just a root replacement. You will never regret for doing a Benthal's operation in type aortic disease. I assure you that. Never, even once, you will regret. Because if you don't do that, you will regret. Because you don't remove all the dissected tissues, patient may die of bleeding sometimes. So, when in doubt, do a Benthal. That is the gold standard. Now, the proximal aorta, as I was telling you, if the aorta only is involved, just they replace the ascending aorta, Benthal's procedure, David's procedure. And then, of course, these are all very complex things. Total arch replacement, you have to know only for theory at the moment, because these are all highly complicated and sophisticated operations done only in exclusive centers doing aortic surgery. That is the frozen elephant trunk for hybrid aortic arch repair. Now, management in type A dissection. So the most important, the patient come in chest pain and shock. You remember my previous slide, because 75% of the patients are dead within 2 weeks. So the patient with aortic dissection comes, if you diagnose it, it is referred from somewhere, do not wait. If you have facilities, you try to do the operation as early as possible. Sometimes there will be financial problem, arrangement of blood problem, your perfusionist may not be there, your chief nurse may not be there, grafts may not be there. So in centers where we are doing the procedure, you will have most of the things. But sometimes you will be caught unaware in the night, a patient coming. If facilities are there, you should not wait. You may have to, even today, where a type A dissection comes, whether it is midnight, Sunday or Saturday, I do an operation within 2 hours in the patient that can afford. But of course, when you don't have the enough facilities, at least till everything is arranged, control the blood pressure, keep the patient in the ICU. Most important thing, tell the patient that if you don't operate, patient can even die. Because patient comes in a wheelchair, walking to you, talking to you. Sir, when the patient came, patient was all right. What happened? Suddenly you say the patient is dead. Sometimes it can be a problem. That is why I was talking about communication. It is very important to explain to the relatives. Most importantly, suppose a patient comes, a male patient comes, wife, children, somebody, because when patient dies, about 100 fellows will come who are not there when the patient came. They will all face all this music in the future. So it is important, and also take consent. Maybe possible when you do complex cases, take video consent also. Make sure I have otherwise says, I didn't know that, sir. You didn't tell me anything, sir. So we are trying to do such a complex operation. Or sometimes waiting in the ward itself, patient dies, you should be safe. So it has to be explained by the senior person who is doing the operation. Likewise, if a patient develops complication, you should be the first one to inform the relatives. Very important. These are the things which help you in getting into medical legal problems. That's just I want to mention to you that also, because you are living in an era with so much of allegations against you, especially doing such complex operations. You spend all your day and night with sleepless, and suppose something happened to the patient, they will only find fault with you. They will never say a good thing. The 100 fellows will come. What happened? Patient came to be all right, all this. So all those you should remember. And then the most important will help you is communication. Never don't just send a junior doctor or somebody to talk to the patient. When a patient is having a serious problem for death, if they know that you are there, well, half the problems that the senior doctor has come in spite of his efforts, he could not save. They will only praise you rather than finding fault. So the cannulation site depends upon the condition of the patient, how it comes. Easiest thing is to do a femoral artery cannulation. This is a cannula. Nowadays, I don't use the cannula thing. Sometimes the tip of the thing sometimes can dissect and all. You can use a interposition graft, like 7 millimeter graft or something. Or if you have got the patient can afford with the Seldinger technique, you can use disposable cannulas. And then first thing, easiest thing when a patient is unstable, the best technique of cannulation is the femoral cannulation, femoral artery and possible femoral vein. Put the patient on bypass. Now this is the axillary artery cannulation. It will take more time, but it is the best way of cannulation because nothing will be there when you open the chest, the innominate, the carotid, everything right in front of you. You have enough place to work on. And this is the carotid artery cannulation. It is being done recently in the last 2-3 years. World over, people do carotid artery also, which is very easy. You just make a cut just above on the left side, put an interposition graft. You can see the carotid artery being clamped. Usually, you should be able to make out a circle of Willis. Otherwise, sometimes you can have a stroke, maybe in a small percentage of cases. So that is used as the arterial inflow. And direct aortic cannulation under TE guidance. That way you have to little experience in doing it. Because TE shows that you can put the cannula in the true lumen, either the Seldinger technique, US or they use the Seldinger technique. Puncture the needle into the true lumen and put that cannula which I showed in the femoral artery. So now you cannulate. This is the patient I was just telling you. She was living 3 hours away from the hospital. So patient, I had left at 6 o'clock in the evening. Just 3 months ago, I operated. My assistant told me, sir, patient aortic dissection unstable. As a CT, put to the CT room. On the way, while patient was being prepared, the ICU, she arrested. So I had 2 of my senior assistants were there. They massaged the patient, took her to the theater, put on femoral bypass. By the time I reached the hospital, they are already opened the chest. Because you have a head camera always, you could take that picture. And believe me, she was a 72-year-old mother of a doctor, pediatrician working in our hospital, and she went over to that picture. So, just to show, if your patient is lucky, if they come or near the hospital, if expert treatment is available, you can save a life. Very important. So this is to check the valve. As I told you, if the valve is bad or if the valve is good, you can repair the valve. Repair means you don't have to excise this valve and do a bend on. The proximal part is dissected. It's a fully competent valve. We have done the proximal part under open anastomosis. In this case, we do only just an interposition graft. And this is to show how you protect the brain. See, sometimes dissection, as I told you, it can occur in the aortic arch. Now that clamp is in the aortic arch. You can see the antegrade perfusion. Patient's temperature is about 24 degrees. That is with antegrade perfusion. Suppose another technique which you can write in theory, somebody asks you, is profound hypothermia circulatory arrest. You hold the patient to 16, 17 degrees. Still, some people abroad still do it. But some studies have shown there is not much difference. But of late, majority of the centers you do this antegrade cerebral perfusion under moderate hypothermia. Cool up to 24, 26 is enough because you are perfusing the brain. See, now the aorta is completely dissected. So you have to prepare the aorta. It's very, very important. You take your own time to do that. In aortic surgery, never hurry through because today you have got membrane oxygenator, you have got good myocardial protection. You take every stitch has to be taken with appropriate care because if you don't take this, one stitch leaks, it's cut through, that will be the end of the operation. I can assure you that. So take your own time to prepare it nicely with the Teflon felt and then stitch the graft. Now that is about the proximal part of the aorta. This aorta, the aortic valve was normal in this patient. So this technique is to put a patch in between the adventitia and the media. Then you put a Teflon inside and outside. Make sure it is properly done and take very close by it, fine needle and prepare it very well. There are some people who use some glue also. See, this one, the valve is complicated. So we are not going to anything. So if you prepare like that, your bleeding won't be much. And this is a patient who underwent, just to show some pictures of right dissection, how it looks. First off, see how the aorta is dissected. This patient has just ascending aortic replacement. Aortic sinus was dilated, but we have done only an ascending aortic. This is a dissection. patient who had a coronary bypass surgery, I was mentioning to you, dissection occurring after CABG. He had a radial artery and vein, left hand side, you can say aorta was dissected, that's the post-operative picture. You reimplant all the graft onto the ascending aortic graft. So, if you tackle only the ascending aorta, as I showed in the first slide, the dissection can go right up to the aortic bifurcation. What happens? The distal aorta sometimes keep on enlarging. Not in all cases, but you can tackle it later. Because when the distal aorta is involved, you are not experienced in doing any of the distal thing. Don't. Our priority in any cardiac surgery, remember, not only in aorta, the most important thing today is to send the patient, take the patient out of the theater alive. Because 45 years ago, when I joined cardiac surgery, a patient surviving after an operation was a very big news. Today, we have raised the standard of cardiac surgery to such high level for which we are responsible. The mortality, a patient dying is a very big news. People cannot accept death after heart surgery. It's a fact because they will think something has gone wrong. They have to blame somebody. If the patient has died, they will never think about what condition the patient came. So it is important at any cost. A live dog is better than a dead lion. Even if you leave some residual problem, doesn't matter. Keep the fellow, take the fellow alive out of the theater. So these are the fate of the aortas of some patients who had underwent aortic root and ascending aorta replacement. The distal aorta keeps on enlarging. So that needs a secondary operation later, which you don't have to worry too much about. We are concentrating on type A dissection. This is also another patient who had a coronary bypass surgery done, dissected, again pseudoaneurysm we have repaired, just to show a few pictures. So this is a patient who had this first operation we have done, reported from our country. Patient who had an acute type A dissection with aortic incompetence. We did a frozen elephant trunk, single stage. You can see the right hand picture. We have replaced the ascending aorta arch and descending thoracic aorta. That patient did well because an acute aortic dissection, when the patient's the entry point of the dissection, there's actually a retrograde dissection coming from the distal to the arch, and the aortic valve was not bad, so we preserved the aortic valve. That is just opening. You can see the dissection. Dissection started from the aortic arch downwards. That is called a retrograde type A dissection. It's not a type A. Type A, type B, you can call that, where the entry point is in the arch. In this case, if you just replace only the proximal ascending aorta, the tear will always be there. So after the operation, also the patient will have uncontrollable bleeding. We have lost cases earlier on when this graft was not available. But with this graft, you can really save a patient with a retrograde dissection because when you put that graft, you can see it covers the tear in the descending thoracic aorta. In dissection, always you have to treat the entry point. Exit point will be there somewhere, but entry point is proximal. If you fix that, doesn't matter. Retrograde dissection will be much less. Whereas the entry is coming retrograde this way, then always you can see the condition of the aorta. An acute dissection, it is angry looking. So you can see it's like stitches. It's like you are taking stitch through butter. That's only I can say. So you have to be so careful. Every suture, pulling the suture, the way you pass the needle, you should not push the needle too much. All minute, your skill will be tested when you do an aortic dissection. So it's technically demanding, but once you have the patience, PHEIENCE, you can get away. You hurry through. It's like it's like trying to you press the accelerator when you're trying to learn driving first. Car will go and get somewhere else. It's only aortic surgery is like that. You have to learn all the techniques properly. Speed will automatically pick up. You can say somebody is doing a bent in 60 minutes. I also want to do that. You do a bent you will be at the theater till midnight. You understand? So it's important. Every stitch you take, that's I want to reinforce the point. That's nothing like a meticulous operation. Operation has to be done the best possible way. Every operation you should think that you are doing the first operation. Just want to show that that is called called a hybrid graft. It is just available in the last 6 months only in India. It costs around about 9 lakhs. That is the cost of the graft. It's expensive. Not many people will be able to afford that. See that the distal part is the It's called a hybrid graft because distal part is an endograft. It has metals and everything. There is no stitching level. It lies in the aorta. And arch graft is there. You deploy that and you stitch it. I think I will proceed because it's already getting late. You want to see it or you want to just keep it? So now there is a cuff for the graft. You just stitch it there, and then the arch vessels are individually anastomosed. Now what happens is the heart is ischemic. We connect the proximal part onto the ascending aorta so that the perfusion to the heart will be resumed, so that the cardioplegic time is reduced, ischemic time is less, for better myocardial protection. So we have to stitch. All those stitches are very important. We have to take very close bites so that doesn't bleed. Now malperfusion, I said, I'll just go through just briefly about malperfusion. It can occur due to loss of blood supply and then end organ malfunction. Incidence varies from 10 to 33. I'll just show the frequency of malperfusion in acute type dissection. You can see it can occur in the coronaries, as I said. It can occur in the viscera, renals, and then you can have malperfusion of the lower. Again, the patient present with that is the most common. That is which comes with the renal as well as lower limb. Suppose I had patients who have underwent embolectomy, right? Because lower limb pulse is absent. Patient presented with the claudication. Suddenly pain in the lower limbs, and local hospitals they have tried embolectomy, couldn't get anything in referred cases. So usually it can occur any time during the before the patient comes at the onset of dissection. Sometimes when we have cannulation into the false lumen, it can produce aortic cross clamp after aortic repair also. Static as well as dynamic. So dynamic usually get relieved with correction. Statics is difficult. Static is malperfusion. Sometimes we have to put stent or replacement of that. So should we operate the patient? Should we operate tackle the malperfusion, or what should we do? The rapid restoration of blood into the true lumen. So what you have to know is, if you ask a short note on malperfusion, other than visceral malperfusion or cerebral malperfusion, where the patient is comatose, always do the ascending aortic correction first. Make it very simple. Whereas the patient comes with the visceral malperfusion, patient will be very, very toxic, ischemia of the bowel, acidosis. You go and take the patient to the theater and do an open heart procedure to fix the ascending aorta, 100% mortality. So those situations we should always address the malperfusion of the viscera either by stent, open surgery, or grafting, and then once the patient stabilizes, you should do. This is a patient who had a dissection, so we had the coronary bypass because the coronaries were dissected. Cerebral malperfusion is about 6 to 14%. Clinical implications, if you patient have got in coma, the mortality is almost 100% with medical treatment, and 76% CVA. Now, mesenteric malformation already said. So this is one article I just published in seminars about mesenteric malformation. If you are interested, you can read that article. And these are the things which you don't have to worry. I just talked about already. Now, limb ischemia. Patient may come with pallor, paresthesia. All those cases you can see. Once you do this, see this patient came with a malperfusion lower limb, and after primary correction, the pulse has appeared, and the patient walked home. This is a young fellow who, in his sleep, developed chest pain and paraplegia. When we did a CT angiogram, he was supposed to travel to US. He's a IT professional in the US. Next day was his flight. Sunday afternoon, he was sleeping, developed paraplegia, and brought. We didn't know what to do. So we took the CT. Then below, we can see that the aorta is not filling below. So I did the arch replacement and the root. Then I checked the femoral pulse. I could still didn't feel the femoral pulse. I make it a point when there is still malperfusion. We always expose the femoral, put a line, and check the blood pressure before I take the patient to the theater. So what we did was did an axillary femoral bypass, and he walked home after 3 weeks. Because the importance of getting the patient at the earliest. In aortic dissection, always when the patient comes early, you will get a better result, better survival, even though it is difficult to treat in an acute condition. The renal malperfusion, this is the patient who was dialyzed in another hospital because patient went for renal failure. Then after 1 week of dialysis, he had chest pain. Somebody took a abdominal pain and CT, and we did a corrective surgery. Kidney improved, and he was off dialysis, just to show. So what happens is, this is another entity, Marfan syndrome, one of the reasons of aortic dissection. De novo in Marfan's. These are the cases where patient never had a dissection in the first time. Patient came for Marfan syndrome with aortic root dilatation, aortic valve, root replacement. Coming, one patient, he never had any descending thoracic aorta. So the distal aorta dissects after some time, as early as 3 months, sometimes 4 years, but these are the two cases where the descending aorta is absolutely normal at the time of first operation. So these are the patients who need serial follow-up, so that what is going to happen. This is the progression of disease in Marfan's. This is another Marfan's fellow who had almost like a totally synthetic aorta now. He had two operations. First aortic root. This is the first frozen elephant trunk done in India. Okay, 2011, I have a graph which is imported from Italy. We did that. Then this patient was not willing for the third operation. So we did a penetrated endograft for him. He's still alive. And this is another one, retrograde type A dissection following TIVA, that is thoracic endograft. You can see the struts of this graft can initiate retrograde dissection. It can acute retrograde dissection. Usually mortality is almost 100%, unless it happens in the ICU. Even if it is very difficult. These are all chronic cases who have been successfully treated. All of them we have operated. Now the challenges what we face in our country, as I said, transportation, availability of expertise, lack of awareness. The challenges what we face to have the perfusionist, anesthetist, diagnostic radiologist, all of them available when the patient comes. Lack of air ambulance, not many people can afford. I have occasionally some cases coming from other states. We had a patient last week also from Mumbai. One patient was brought with a patient who got a stent and a coronary bypass type A dissection. We salvaged that patient safe. So lack of awareness, fear about surgery. Now, if you look at the statistics, as per statistics, we should be doing about 700,000 cases of aortic procedures in our country. So you all have a very good scope in the future. So I would encourage you to look into this aspect of aortic surgery, because not many people are interested in aortic surgery. Everybody wants to do only transplant, minimally invasive, and other stuff. So aorta has got a very good future, I feel. Because of course the learning curve is a little steep, but at least if you know the basics of aortic surgery, it will be good for the people of our country. And you see, hardly we are doing about 500 cases of aortic dissection in a year. So we have a lot of scope as the people are getting more educated, our economy is getting improved, affordability will be more, the insurance will be coming. So it is a very challenging field, but it's very gratifying, I would say. So challenges in availability of grafts you may not have. So you have to improvise on all this. Upper one you see is the graft ready-made available. But if we make handmade grafts, we can make penetration on the table. You can make a graft by just stitching with hand. If you wait for all those things, I would never have done an aortic surgery. We started about 30 years ago. I really started active aortic surgery, but none of these were available those days. But then if you hesitate to do, nothing will work. Nothing will happen. The important thing is to concentrate on one and decide what you want to do and persist. Always persist. Then only you have to spend sleepless nights reading, seeing. Nowadays it's easy. You can see a lot of videos. People are willing to teach you. Any questions anybody can ask through, information is in your hand. So it is easy. So make use of all these things. Type A dissection, always remember, is an emergency. Don't sit on a patient with type A dissection. If you have some financial reason you cannot operate the patient, explain to the relatives, I'm not able to operate because you are not prepared, but if the patient dies, for heaven's sake, God blame me. I'm nothing to do, he can die. Then you have to very, very clearly say, like a left main patient who is not willing for surgery, I always get them in writing. I'm not willing for surgery for discharge the patient. Because if they die also, same thing will happen. Because these are the things, the communication I'm just talking. As a leader of the team you are leading, your communication, your tongue can make or break you. Very important. You remember all this. That is very, very important in your career because your colleagues, your patients, all those things. And talking a kind word to your colleague, somebody does a good job, always appreciate them. Always, whether it's a nurse or a technician, find out their colleagues, how are you doing? Ask some questions about their family. These are all very good things which you can keep a lot of people along with you. You have to grow along with the team. A successful cardiac surgeon means he will have a team who is staying with him. Because for so many things you have to help others. Because it's like your hand. If you have 5 thumbs in your hand, the hand has no value. Isn't it? You are the leader, but everybody is important. Even the person who cleans the theater, if he does not do a good job, you are getting an infection. You will be doing a wonderful operation, but he has not cleaned the theater properly. So all those is people. First, you have to be a very good human being before you become a good cardiac surgeon. Thank you very much. Anybody else got any questions or anything?
You said control of blood pressure.
Yes.
What is controlled blood pressure?
Control blood pressure, I will keep the systolic pressure less than 120.
Go back,
No, if there is a severe aortic incompetence, definitely you have to give vasodilators. Normally we give parenteral vasodilators.
systolic pressure
Below 120.
particular drug of choice.
Usually we give nitroglycerin. If it doesn't respond, I give nitroproside. Yeah. But usually it will be, in a brief period only because the patient, this type of patient is having uncontrolled pressure and AR. Usually they die if you don't operate. So within 3-4 hours, for those who are not willing, we start on beta blockers. The AR is very severe. It's very difficult. You may just die because of the LV will going very high. Depends upon I think the survival when the patient comes, when there is no rupture of the aorta, depends upon your aortic valve competence. The aortic valve is moderately competent, they will survive. If the AR is very severe, then we are having a big problem.
Hyper dissection, the tear extremely superior
Yeah.
towards arch.
Yes.
How far you are go and exercise that part?
Yeah, that is a very,
You have to go well beyond the
very, very pertinent question. Because in a type A dissection, if the CT does not show any entry point distally in the arch or any other place, only the ascending aorta up to the innominate continuity. Always we do an open, today type A dissection when you manage, you always do an open arch anastomosis. So you open the arch,
ascending aorta as well as arch.
You make the incision just below the innominate artery and look at you can, even though the CT may not show any entry point, without a clamp, it is much easy to prepare the distal aorta so that you can put nice fluid. The clamp there, sometimes as you know, it does in many cases, the artery just slip upwards. So you cannot approximate the whole thing. So open clamp technique is always followed and you only replace the ascending aorta. There is no distal tear. So many cases come without distal tear. If the distal tear is just a descending thoracic aorta, you don't do anything beyond the subclavian. Whereas if the distal tear is in the subclavian, if you are capable of doing a frozen elephant trunk, if the graft is available, the gold standard today is frozen elephant trunk. Very experienced. It is done only in maybe two centers in Germany and one center in Italy. These are 3 centers who do frozen elephant trunk single stage along with the aortic root. And what they do, because I did a couple of cases like that, because now the technique now is the problem is you take minimum 3 to 3.5 hours to do this operation. So the heart will be ischemic. So the new technique, what we do is, suppose we are doing frozen elephant trunk, what we do with the aortic root, or if the root also is okay, you don't replace. First you prepare the aortic root, put a cross clamp, give blood into the aortic root. So the heart will be perfused with blood. It is an excellent technique, especially people who have got LV dysfunction.
Don't bother about the distal opening of the. Just take care of the
Proximal tear.
Distal is takes care by itself.
Takes by itself. If it expands, let somebody else. We will tackle it.
You have to follow the.
Of course, I am showing Yes, yeah, I saw about 4 cities now where it is keeping on increasing. Maybe at least once in 2 years. Re-entry in penetration only done for malperfusion. Otherwise, nobody does that. That is, when there is visceral malperfusion, somebody comes, you penetrate and then when there is a dynamic malperfusion, you reduce the force during pressure by making put a balloon and then penetrate. Temporarily wet and then do the delivery procedure. And that also it's a technically demand. You need a good introductional person to do that. Yes. No, we don't do it anymore. Because now the cathedral-based people are involved in this. I got a team with excellent diagnostic radiologists and very good interventional radiologists. So we always, whatever is possible, for passing guide wire before work as a team with good understanding. So that's why I was telling you to build up a good team. You should be nice to the people, so they will help you over time. If you say good word, that's enough for that. You understand what that? If you keep on shouting at the table for small things, nobody will like you. So that is very important. So I'm just telling you very important, which I have learned in my life. No point in never find fault with somebody. If something goes wrong in the operation theatre, you know as a surgeon what has gone wrong. Go home and do an introspection. Write everything. Make notes. My professor Stanley John is always used to give me a diary when I joined first. Every day, suppose a new antibiotic, anything is there, make a note in the diary. Next time a patient comes, he will ask, where is your diary? What is the dose you gave? So remember that, very easy. A new drug, another consultant come and see a patient. A nephrologist will come. Sometimes, whether to give laxatives, whether to give fluid. We are the patient who are managing. Nephrology consultant, that fellow will come one day, after 1 week, he may not come. So you had what drug was given. So basic management of nephrology, management of blood sugar, management of a minor cerebrovascular problem, because they are not going to do anything. How to manage blood pressure, all those things you should know. Don't depend on too many people, because nowadays I notice that even in my hospital, in other units, the patient coughs, they call immediately pulmonologist. Patient has a sugar high, immediately diabetologist. Okay, blood pressure goes up, the cardiologist immediately. So the specialist, if a patient is in the ICU, 10 doctors will be seeing the patient, they will put about 25 medicines. And the patient finally, you are responsible. So, especially in a surgical ICU, one person take the decision. Very important. You are the one who, you get opinion from everybody for medical legal reasons. Suppose the patient has acute renal failure, you are not consulted nephrologist, it will be a problem. But decision making you should do. You are consulted nephrologist, that's enough for the judge to say, okay, kidney failure, dialysis done, they are fine. When you look at the chart, everything is complete. But patient management, you have to take the responsibility, make sure, see the patient when the patient is sick, availability in the operation theatre and the bedside ICU is the most important quality, not availability at home, especially when you are junior. When the patient is in the theatre, you should be the first person there. Because the skin incision is it. I had patients who were arrested coronaries by putting a radial. Because I'm there. Even today, of course, I've got a senior assistant, otherwise, I'll be the first person to go to the theatre. Believe me. A sick patient, I will be there. Either I'll be sitting outside when the patient is infused. Don't leave it to you. Should not. I'm not telling that you should not trust anybody, but you have to have full trust on you. Anybody else, the responsibility is you. Any stitch, and also, if you teach your fellow so that he will do the way you like. If you want to have good success, very important. When a problem happens, you have to be around. Don't run away. Do an operation and run away, unless you have enough people to look after. Because I have seen people doing and landing in problem. Unnecessarily. They don't talk to the people. The problem comes, they run away. Send the nurse first to talk to them. Then the junior most house because they don't want to face. You have to face. Facing the patient, after when the patient is doing well, everybody will be happy to go and tell the patient, oh, everything is fine. When the patient dies, see, when we used to registrars, when a complication happens in the ICU, everybody, 6 of the registrars are there, everybody is scared to call the chief because the chief does not want to listen that patient died. Whereas the patient is doing well, 100 will be there. Sir, I know the patient is okay, sir, everything is fine, sir. I have given the opinion, sir, I have given last sir, fine. Whereas the patient dies, first they will say, sir, this patient was doing well, sir, 3 hours ago. Then slowly he developed some hypotension, sir. Then I started adrenaline. Then what happened? This is what happened with it. Sir, I gave adrenaline, BP came, sir. Then his arrhythmia came, sir. Then what happened? Sir, he had the phone just bangs the phone straight away because he does not want to listen to the death of a patient. So it is important that you have to take own responsibility. Do not delegate to somebody else in these important things so that you will be able to do well. Okay? Thank you.
Thank you so much for sharing your vast experience. Now I request Secretary of ICTS, Dr. C.S. Edward, to present a token of gratitude to Dr. V.V. Bashi.
You think I need to make some announcements? Yes. I'll take just 5 minutes. First of all, I would like to welcome Dr. Satyaki Nampala, the senior minimal access surgeon, is here with us among us. His session will be posted after lunch. He has agreed for that. Thank you, sir. Welcome. Please come, friend. And you see that after lunch, within half an hour or 45 minutes, you are back here into the hall to listen to his talk. You will see a master's perspective on minimal access, the way you heard about diabetic surgeries. Another important announcement, what I wanted to make among residents. The last national conference which was held in Ahmedabad, wherein the scientific session was well planned and executed by the senior vice president, who is the current president, Dr. V.V. Bashi. We happened to take an initiative this time to encourage upcoming women cardiac surgeons, lady cardiac surgeons in the country. And it so happened that we took the initiative to do the comparing work on scientific program. Invariably, what was happening is non-medical guy was comparing the work of scientific program and all that. So this time we took the chance and we planned to have our CTS residents across the country. We happened to choose 4 from different institutes, one from Delhi and Dr. Namita, one from Narayan Dr. Shivangi, and one from Hyderabad Institute, Dr. Pramoda, and one from Satya Sai Institute, Dr. Ananda. So the ISTs took initiative to register them for the conference, to take care of their accommodation, travel. Apart from that, as they did such a good job, and on behalf of the association, Dr. V.V. Bashi planned to give them a memento. What is a memento? No, nothing. We plan to give a textbook. So this is a textbook what we initiated, that is textbook of operative cardiac surgery by duty for all 4 of them. This is to encourage cutting cardiac surgery. This is the first time in the history of ICTS we have taken initiative. I request Dr. Bashi to come over the dais. I call on Dr. Pramoda, she is here. Come in. We will be today, tomorrow, nice, good. And I happen to give this memento not in the national conference, but here in front of the ICTS Residents Forum, which will make an impact for the upcoming budding cardiac surgeons, which will show that every year we are trying to continue this. So you need to write to the secretary, who should have little command in English language, and the secretary of the ICTS will train the residents how to do the comparing work. They underwent training for almost a month, and finally they have done a good job. On behalf of the entire, I read what we have written here on the book. On behalf of the entire fraternity of Indian Institute of Cardiac and Vascular Surgeons, we wish to convey our gratitude to you for excellent noteworthy leadership skills at the conduct of a meaningful scientific program at the 66th Annual Conference of the Association held on 6th to 9th February 2020. Your commendable planning and managerial skills are testament to the potential that rests in you to push limits in serving your patients as skillful, hardworking, and successful clinicians. You are among the selected few to be part of the residents' welfare and leadership program that focuses on building character, morale, and integrity in a professional academic cardiac surgery. The growth and prudent practice of specialties of cardiac surgery rests upon the able-bodied shoulders of a capable woman as yourself. We wish you the very best in conquering and untapped frontiers that lie ahead. Duly signed by President Dr. V. Bashi, Secretary Dr. Hiramat. Yeah, today is tomorrow is Women's International. And we are agreeing today because President is here only today, sir. Shivaji, is it?
Sure, next year there will be more contest. We will have an interview.
Dr. Navnita is not here. She just recently passed out NB and will be couriering the book. Thank you, sir. And we will break for lunch for 30 minutes. And we'll assemble within 30 minutes. We need to be ready for the talk of Dr. Natikirapala. And before that, we have a photo session. Hello. Just in front of the door. Outside, it's arranged a photo session. Everybody should assemble there. It will take just 5 minutes.
Yeah, lunch candy. It will be there only at the end. Will come. I don't know if the prepared it. I remember seeing you in the Hyderabad conference. We'll break up.
We are watching. CCTV camera on backside.
No, welcome. No. ಸದ್ಯಕ್ಕೆ ಸರ್
ಪ್ರಸನ್ನ ಕುಮಾರ್ ಗಿರೀಶ್ ನಾನು ಎಡಿಟಿಂಗು ಈಗ ಲೈಟ್ ಹೌಸಲ್ಲಿ ಮಾಡ್ತಾ ಇದ್ದೀನಿ ಯಾವ್ದು ಬೆಟರ್ ಸರ್ ನೀವು ಯಾವುದಾದ್ರು ಮಾಡಿಲ್ಲ ಸರ್ ಟೈಮೇ ಕಳ್ಕೊಂಡು ಈಗ ಮಾಡ್ತಿರೋದು ಪೆನ್ಸಿಲ್ಸ್ ಫಾರ್ ಕಲರಿಂಗ್ ಫಿಲಮ್ ಸರ್ ಅದು ಯಾಕೆ ಸರ್ ಅದು ಬೆಸ್ಟ್ ಅಂದರು ಅದು ಟ್ರೈನಿಂಗು ಕೊಡ್ತಾರೆ ಕಂಪ್ನಿ ಕೊಡ್ತಾರೆ ಟ್ರೈನಿಂಗ್ ಒಂದೇ ಹೋದರೆ ಎಲ್ಲ ಹೇಳ್ಕೊಡ್ತಾರೆ ಟ್ರೈನಿಂಗ್ ಇರುತ್ತೆ ಎಲ್ಲ ಶಾರ್ಟ್ ಕಟ್ ಎರಡು ಸತಿ ಸ್ಲೈಡ್ ಚೆಕ್ ಮಾಡ್ಕೊಂಡು ವಿಡಿಯೋ ಇದ್ರಂತೂ ಒಂದ್ಸತಿ ಚೆಕ್
ಅಲ್ಲ ಅವ್ರ ಲ್ಯಾಪ್ಟಾಪಲ್ಲಿ
ಲ್ಯಾಪ್ಟಾಪಲ್ಲಿ ನಾವು ಲ್ಯಾಪ್ಟಾಪಲ್ಲಿ
ಬೆಟರ್ ಅನ್ಸುತ್ತೆ ಇದು ರನ್ ಆಗಲ್ಲ ಅಂತ ನಾನು ಅದೊಂದು ಮೆಸೇಜ್ ಹಾಕೋಣ ಅಂತ ಸುಮ್ಮನೆ ಬ್ಲ್ಯಾಂಕ್ ಕ್ಯಾಮ್ರಾ to save it. I have never used Mac.
ಎಲ್ಲ ಉಂಟಲ್ಲ
Actually, first time.
Easy. ಸ್ವಲ್ಪ ಶಾರ್ಟ್ you get along with him. Once he knows that you have stuff, he will come to you. Or surgery ನೋಡ್ಬೇಕು ಕಣ್ಣುಗಳ ಹಾಡು ಹೇಳ್ಕೊಟ್ಟು ಮಕ್ಕಳಿಗೆ ಸ್ವಲ್ಪ ಬಡಿ ಬಡಿ ಹೇಳಿದ್ರು ಬರ್ತಾರೆ ಕೆಲಸ ನೋಡೋದು ಡಾಕ್ಟ್ರು ನೀತಿ ಡಾಕ್ಟರ್ ಪುರುಷೋತ್ತಮ ಮಾಡ್ತಾರೆ ಅವ್ರು ನಾವು ಕೇಳಬೇಕು ತಿಳೋದು ರಿಟೈರ್ಡ್ ನಾನು ಫಸ್ಟ್ ಹೋದಲ್ಲಿ ಅಷ್ಟೇ ವಿಡಿಯೋ ಕಾಣಿದ್ದೆ ಏನು ಬರುತ್ತೆ ಅಂದರೆ ಸುಮ್ಮನೆ ಮಾಡೋಕ್ಕೆ ಕೈಯೆಲ್ಲ ಮೇಲೆ ಬರುತ್ತೆ ಕುಯ್ತಾರೆ ಟ್ರೈ ಮಾಡ್ತೀವಿ ಟ್ರೈ ಮಾಡಿ ಎಲ್ಲ ಗೊತ್ತು ಅಂತ ಹೇಳೋದು ನಾವು ಎರಡನೇ ಸಲ ಆಗ್ತದೆ ವಾಲಂಟಿಯರ್ ಇಲ್ಲ ರೈಟ್ ಕಲಿತೀವಿ ಸೊ ಲಕ್ಕಿ ಲೈಕ್ ಕರೆಕ್ಟ್ ಆಗಿ ಜೋಡಿ ಆಗ್ತದೆ
Sorry.
sound system conference ಅದನ್ನೆಲ್ಲ ಖುಷಿಯಾಗುತ್ತೆ
ಇಲ್ಲೂ ನಮಗೆ
Somebody is very, very free today.
Huh?
You had dinner or lunch? Eat, no?
Consent.
Consider your take. Eat and go, no? Eat and go. I'll go.
You have lunch? ಅಲ್ಲ ಹೇಳು 5,000 ಬಂದಿದೆ ಅಷ್ಟೇ. ಅದೇ ಬ್ಯಾಂಕ್ ಹಾಕ್ಬಿಡು HDFCಗೆ. HDFCಗೆನೆ ಹಾಕ್ಬಿಡು ಪರವಾಗಿಲ್ಲ. IMPS HDFCಗೆ ಮಾಡಿದ್ರೆ ಬರುತ್ತೆ. ಹೌದು, ಅದು ಸೇಮ್ ಪ್ರಾಬ್ಲಮ್ ಅವತ್ತಿಂದ. ಸೇಮ್ ಪ್ರಾಬ್ಲಮ್ ಅವತ್ತಿನ ಥರ. ಹಾಂ, ಈಗ ಹೋಗ್ತಾ ಇದ್ದೀನಿ. ಇದು ಎಷ್ಟು ಎಕ್ಸ್ಪೆಂಡ್ ಮಾಡಿದ್ದಾರೆ ಅಂದರೆ ಎಕ್ಸಲೆನ್ಸ್ ಆಗಿ ಕ್ವಶನ್ ಮಾರ್ಕ್ ಅಂತದೇ ಇಲ್ಲ.
View ಆಗ್ತದೆ.
ವಿಡಿಯೋ ಲಿಂಕಲ್ಲಿ
Computer. Skills ಎಲ್ಲ ಬರ್ತದೆ. Unavailable.
ಅಂತ ಲೆಕ್ಕ ಹಾಕೋದು. ಮತ್ತು ಅವ್ರದ್ದೇ ಹಾಕೋದು ಪ್ಲೇ ಆಗುತ್ತೆ.
ಇದು ಮ್ಯಾಕ್ಬುಕ್ ಎನ್ಕೋಡ್ ಇರಬೇಕು. ಸೆಕ್ಯೂರಿಟಿ ರೀಸನ್ಸ್
ಹಂಗಲ್ಲ, ಸ್ವಲ್ಪ ಕ್ಲಿಯರು. ಅದೇನು ಗೊತ್ತಾ, ಒಂದ್ಸತಿ ಕಮ್ಯುನಿಕೇಶನಲ್ಲಿ ಸೆಂಡ್ ವಿಡಿಯೋಗೆ ಇನ್ನೊಂದ್ಸತಿ ಕಮ್ಯುನಿಕೇಟ್ ಸಾಧ್ಯ. ಪಿಕ್ಚರ್ ಯಾಕೆ ಕ್ವಶನ್ ಮಾಡ್ತಾರೆ ಅದೇ ಕಾಪಿರೈಟ್.
I think it's a video.
Project.
Windows will focus it.
ಅವ್ರ ಹತ್ರ ಕನ್ವರ್ಟರ್, ಅದು ನಿಮ್ಮ ಹತ್ರ ವಿಜಯ ಇದಿದೆಯಾ ಕನ್ವರ್ಟರ್?
ನನ್ನ ಹತ್ರ ಯಾವುದೂ ಇಲ್ಲ.
you are alone, I'll be here, you don't have lunch and night. No, you arrange mic, who's stopping you from arranging mic? But you have lunch also. He's for the mic. You could stand like this.
We are not using microphone.
Then?
That's why you put this. No, stand.
Otherwise, without mic, how do you
See, we are so record and everything. Written, they are not written.
They just speak out. But
But if
a lot of people give You are not going for lunch, that means?
No, I'm not taking one side. Just that.
Then you I have a hammer.
Do you know about this? Who will know? They downloaded one program for me, my slides. I want to go to that slides. Dr. Shukla. This morning they downloaded. They copied from my pen drive. Dr. Shukla. This girl will know. Come. Where is my program? My slides that you downloaded. I just got some more information. I want to add some slides. I can sit there and do.
Yes. Let me come to this.
No, let me eat food.
I don't have idea about this system.
Oh, okay.
I'll call him. He has finished almost.
Let him come then. Take his time.
Hardly 5 minutes.
Oh, no problem. Let him finish.
The talk will be, I think it will be late, sir. It'll be like within a 1 hour.
Hello.
Is there?
Rita, how are you, Rita? Tell me what news, Rita.
That is what we need. Next, we'll just have to do presentation.
I'm just sitting in the conference here now.
That don't then do extra.
मैं तेरे को अपनी दुर्गति बताऊं तेरे लिए इस होटल पे इस बताएगा प्लीज ये बेटा एक पेयर को बेटा सो मच बता क्या बताऊं ऐसा फंस गया आपको इतना डिस्टर्ब दिस रूम्स आर सो स्मॉल एंड whatever even that makes me go opens his toilet door we can hear the walls are so they have given us a hotel, one small room, which is smaller than your room, where you're staying. No? In that room, only you forget the toilet. In that, where Ashik, where Chinmay and your bed is, only in that much area they have put toilet, they have put dressing room, they have put your bed. तो रात पे था डिस्टर्ब था दूसरा को शाम को उन लोगों ने सबने बोला they were all having coffee so they gave me a little coffee to drink and that kept me awake all night. Should I actually had only half I threw, but even that half was enough for me. You all right? Mom, tell me that. You has nothing to do with you pretend you don't know. So they'll mark you absent. And no student must have come. So, Utkarsh, better come here. Acha, let him. That's the thing. He's using that one, or he's using his own.
I'm using my own, sir.
Ah, that's very good.
Because mine is not working with this.
I'm not changing it over the print well. I'm changing it here only. Sure. Or do you have any room to sit where I can sit? I have to sit here only.
Yeah, anyway, sir.
No, this will be comfortable.
Yeah.
You give me this much space is enough. Because I need 2 minutes of concentration also. So they're sending me the models also. No? I told you just now.
Yes, sir.
Yes. One slide after this I want to. After 44. Yeah.
Yes, sir. What patterns?
This. I'll put this pattern. I'll just type in this. I want to type in the center only. Don't delete anything because I'll kill you. Okay. No,
Caps lock.
no, I want to take it here. You're using this mouse, that's the problem. I'm used to the other mouse.
You tell me, sir.
No, I'll type. I do touch type.
It comes right.
I learned touch typing when I was in 5th standard. 1971, you were not born.
Yeah.
Big circles in the key. Those circles in solving. These all are trees.
I want one more slide
After this.
please. I'm just inserting two slides in my talk which I have not done.
Sir, students.
Today's.
Other side.
Cast all the stuff with that.
Oh, the problem has happened in the some of the one which is fitting into the Iacts Score.
One chat better than yeah, we type it very
Done. Now you can save it, please.
Save.
Thank you so much. So you do yourself.
Yes.
No, first. Just for the minus tomorrow. So this one. ECJ 2000. That will get projected there. No?
Yes, sir, it will get projected. But I need to copy in this laptop also because online it will be from.
It's there?
Yeah, it's there. ECG for the exam score 2020.
Huh?
Yeah, carry these bars to show the bodies. I thought tomorrow when they have coffee break, tea break, I'll show them the bars because I'm sure they have all of them. I'm not seeing the bars now. So I'll keep it on the table. And after the talk, they can all see.
So just one minute, I'll ask the password.
On the car, and the oxygen, I've got those also. This is the hard one. Yeah, can I not show this in the image also again? That is essentially you should be able to see from the
Sir, one thing on that other laptop. Deepika, he'll need to type. Yeah, I'll type it. Just keep this laptop, this Manpreet's laptop. Just keep it with you once that source is over. सर आपने मेल किया था आपके पास ये पेन ड्राइव पेन ड्राइव दो डिफरेंट कॉपी अटैच ओके नो प्रॉब्लम इसका पासवर्ड नहीं पता है उनको भी नहीं पता वो आदित्य को पता है लगा मैं आपको इसका पासवर्ड पता है ये लैपटॉप का पासवर्ड पता है He's not picking phone. Ask him.
We'll start with the next session of master class. All we have.
Yeah. Tell HM sir also. Students, your attention, if you're interested. How many of you have seen robotics?
Okay. As of now, it is still very early for me to say too much about robotics, but I'll do a video. But for those of you who are already here, and since we have a little bit of time before everybody else comes, what robotics is doing is it's taking minimally invasive to the next level. And unlike minimally invasive, you have to make an incision, you have to put a spreader, you have to spread the ribs, and then sometimes you have to look inside and then operate, or you need a telescope. So you require a videoscope, basically, an endoscope, to show you what you're doing. And each one of these instruments is in the control of another individual. That means either somebody is holding and standing in an endoscope, under endo void over which you don't have control. And then you're sitting and doing this operation, sometimes looking at the monitor, sometimes looking inside. And while you sit and do these operations, minimally invasive, I think in your centers, if you have seen, you realize that there is a certain amount of effort on the physician, on the surgeon, the physician, particularly the neck and back. Now, what robotic aims to do is to eliminate. Now, suddenly the endoscope, it's like driving a car. You have the robotic endoscope, which is three-dimensional, high resolution, at your feet, the control of your feet, and you can move it backwards, forwards, do close-up, magnify 6 times, and at the same time, you have the robotic arms, which work exactly like the minimally invasive instruments. They're single-shafted, they're really long, so actually small patients with small chest walls are not suitable for robotic operations. They require big patients
bulky, obese patients are perfect patients for robotic operations, which do the same, these robotic instruments will do the same function or work as your single shafted instruments. But then you're sitting comfortably at a console and you're not really physically strained that much. But what it adds is a new dimension. It now means that you need two teams. The operating surgeon is actually sitting at the console. You have a bedside surgeon who sits at the bed and keeps handing over needles and sutures and whatever you need to do this operation, or putting in a valve. So you require a very competent bedside surgeon. You require a very competent surgeon who's using the robot. You require a very competent team that's alert, needs to understand mechanics and software and so many other things much better than what they would earlier, with minimally invasive, compared to minimally invasive. It also means that the margin for error becomes even smaller, because if somebody has a problem and you need to convert, it's actually problematic. So it's better that you make sure that there are no problems as far as possible. But like I said, vision is phenomenally. I'll just show you a video. Can you switch off the light if possible? Yeah. Until this hall fills up, we do this. See the clarity. So the rest of the operation is done exactly like you do with minimally invasive. So that's a chipwood, that's side clamping. And here the whole thing is integrated into your robotic console. You can see that snowstorm that you saw here. Did you see the snowstorm? So you gave quadriplegia and your TE Pro will actually show you the quadriplegia coming in there. And then take out the needle and take out everything else. You use it then in a single shot. You open the LA. This patient is actually planned for a repair. And that's a robotic LA retractor.
In this system,
and see that vision.
So
it's perfect for even redos because it's the same kind of vision that you get. Only thing that is not good Dan is that the tag is calcified. Your scissors are extremely poor with the robot, and their leaves will not cut well. This became a mitral replacement. The rest of the operation is exactly how you would do it. Open surgery. Let me just take a little forward. Everything is methodical. So if you saw this step here, see that the needle comes in, the needle is being handed over, you take a bite, pull out the needle, and assistant will put in a instrument inside and take the needle back and pass the next needle. Most of the things are still not suited for us. Like if you look at that sizer, it's not perfectly made for us. It's easier to use a core knot rather than setting it, tying knots with a knot pusher. So we try and use a core knot whenever possible. Only when we have shortage of funds to use a knot pusher. So in 1 hour, this procedure can be completed exactly like you would do in a minimally invasive operation. Sir, sir, look at that this one. Yeah. This is a beautiful thing. Even if you're doing thoracic and you have to take a knot, I'll pause it there. This is called, this is actually a published thing. It's called Iacts Score. You make a loop beforehand itself, right over a mosquito. Even the good is and you're good. See that? Free and then there is force and what is good is this. It's really good because you hardly see. Sorry, just go. Slides. That's all. Robotic mitral valve replacement. So the valve basically is starting here. It's a small. That's completely the same. Just write down the names. 18. Seems
We'll see this video once again. Just show you a mixoma how it looks. What they call films. These are all made for commercial purposes, so excuse me for same thing. Iota is now exposed. In robotic, we want to take artificial and take out the needle. For DI, we put vaccine. Because we don't want to keep any heart structure connected to the heart. We will not look the SPC, no IVC is good. You can see that bulging there.
Yes.
So we are on suction assisted bypass, so we are not worried about looping SPC or IVC. You can see that maximum tissue there. The part is suction has been excised. You are watching this at 6 times magnification. So everything looks normal, including the myxoma. So cutting off that sump there, vertical. This is a 2.53 centimeter myxoma, but when you take it out, it looks really, really huge because of the magnification. Also, because of the magnification, everything looks much better than the naked eyes or even the microscope. Look at that. That's all. That's the.
Then comes next. BTC. And then BTC. And then
Just to keep you occupied. What the future can hold. Memory harvesting is fantastic to do for robots, especially with bilateral memory doing minimally invasive. Taking down Rima is really, really nice. We are not to start sewing, so doing anastomosis or doing the Vigra, still are not comfortable doing that. I think we need to do a lot more valves and get comfortable with sutures on the aorta and elsewhere before we head on to that. So, like Dr. Bashi said, it's a lot of practice and it's a lifetime commitment. And it's perseverance. Me and Dr. Hiremat were talking that while it looks very successful now, Dr. Bashi has been doing this for 20 years now. And he's reached success at the end of 20 years. For the younger surgeons, I think most of you should stop thinking that success comes 50 years. It doesn't come. You have to work for a decade. We've been doing minimally invasive for 13 years now. And now we see some amount of recognition. So it's not going to come just like that. It's going to take hard work and perseverance. We start almost getting up. Another 2 minutes. Hello. You can start. You still want to read? I don't think it's good. Yeah. Thank you.
हाँ ठीक है उनको जहाँ पे भी जाना है छोड़ दो ठीक है हाँ जहाँ पे भी बोले उनको उधर छोड़ दो ठीक है जाते हैं 7 बजे के बाद 6:30
Very good afternoon to all of you, and thanks Dr. Hiremat for inviting me to be here and engaging with young people. We're going to just touch base on minimally invasive cardiac surgery. We're not going to make this very elaborate. Like I said, touch base, some basic principles. I think my teachers here, Dr. Sri Krishna and Dr. Tendolkar and so many others will actually elaborate the basic principles much more than what I can do here. So I'm just going to show how we do this and why it needs to be done, and also certain techniques, basically how you select patients, who are the patients you should do this on, because this is never going to be the most important aspect of your exam. This is going to be the last or least important in your exam. Also, what is important to remember is that the principles you learn for open surgery are more important, especially more important if you're interested in minimally invasive, because everything that you do here in minimally invasive is grounded on that, and you need to be exceptionally good with that if you have to pull off a successful minimally invasive program. Basically, the true definition of minimally invasive is you should be able to avoid a sternotomy, you should be able to avoid a heart-lung machine. And I think both of these are possible only with a minimally invasive CABG and a transcatheter aortic valve. No other procedure can avoid both. However, for this discussion, a minimally invasive CABG is one where you don't do a full sternotomy, you could still use a heart-lung machine. And if possible, you will avoid a sternotomy or you will avoid the heart-lung machine. Either one of those. Okay? This was the original definition of Carpentier. This came back way back in 1994 when they went to Malaysia and did the first mitral valve replacement. So level 1 is just like open surgery, big incision, big thoracotomy, and you do the operation. Level 2 is where most of us are stuck in most institutes. A mini incision is about 4 to 6 centimeters. Either you can see directly or you can use an endoscope to watch this whole operation or control this whole operation. Level 3 is a micro incision, mostly requiring a video scope because you generally will be unable to look inside. And level 4 is what we just saw, robotic. With robotic, you don't require an incision at all. Truly speaking, although at this point in time, we still are making a 2 centimeter incision or 1.5 centimeter incision in certain cases to be able to hand over sutures, etc., etc.
Yes.
This is a easier question to answer. Why should we do MICS? Theoretically, many people will argue against the first point, less pain. But yes, less pain definitely over a period of time makes a difference, or the benefit adds a benefit to MICS. Definitely reduce use of analgesia. There are many papers now already proving that ventilation times and ICU stay times are shorter with minimally invasive. Definitely reduce blood loss because you don't do a sternotomy. Although during your early swelling curve, during that phase, reduced blood loss is not something that you see often. There is decreased incidence of wound complications basically because you don't do a sternotomy and therefore the whole concept of deep wound infection is eliminated. Most of these patients, because the sternum is stable, you can ambulate them and they generally get back to a far more active life faster. Duration of hospitalization is controversial. It depends upon your center, depends upon how aggressive the surgeon is. It is possible to discharge patients in 24, 72, maximum 72 hours. But some centers will do thoracotomies, they're still in level 1 and level 2, and keep patients up to 5 days and say there is no difference. Improved quality of life. It's just completed a study. Shortly should get published. About 235 patients. We did a SPF scoring for all these patients, pre and post-op, comparing minimally invasive to open surgery, and the data as far as whatever we have analyzed so far shows that it is significantly better compared to open surgery when you look at quality of life. Can we do this operation and redo surgeries as well? Yes, definitely. What you saw robotically, also minimally invasively, they are better suited to do a redo surgery. Particularly so for valves, not so much for an aortic valve, definitely for a mitral valve or a tricuspid valves, and in certain cases CABGs as well. Basically, the advantage is that you don't have to dissect the heart away from the sternum. It can be stuck particularly the right ventricle, which is more prone to tearing as well as RV dysfunction. Because you don't do a sternotomy, there is less blood loss, less need for transfusions, and definitely these patients go much faster compared to open surgery. We're going to touch base upon these things. CPB for minimally invasive procedures. What is the instrumentation required? Basically, a rough idea of what kind of instrumentation. What are the different approaches for minimally invasive surgery? Whether it's be a CABG, aortic valve, or a mitral valve. What are the indications and contraindications to a minimally invasive procedure? And lastly, complications. There are certain principles that you must understand. The Iacts Score principle is one. I think most of you wouldn't even bother to read about it. The Iacts Score principle is very important, so please go back and brush up on the Iacts Score principle. It's extremely relevant for MICS as far as the perfusion is concerned. In many open surgeries, you might have heard in your wards that the surgeons really dreading low flows. In minimally invasive surgery, it's very common for us to go down to 70% flows or even 50% flows for a considerable period of time without seeing any major adverse events. Of course, you have to look at, when you say low flows, you have to make sure that the most important metabolite is cleared constantly, and that is lactate. So whenever you talk about flow in minimally invasive surgery, whenever you talk about using smaller cannulas in minimally invasive surgery, the basic, most important prerequisite is that the flow is adequate to clear whatever lactate is produced in the body. Because if lactate is not cleared within the first 1 hour or so, this lactate is going to accumulate and subsequently will cause post-operative issues. You use smaller cannulas. Smaller cannulas also means greater resistance. When you say smaller cannulas, again, like I said, you have to look at flows, and they should be adequate enough to generate at least 2.5 to 3 liters of flows. Smaller cannulas means higher resistance, and sometimes in minimally invasive, you could have resistance up to 300 millimeters of mercury. What is important is that when the resistance is high, make sure the resistance is not at the tip of the cannula. You'll not throw plaque, you'll not create a dissection. What you need to know is that the blood pressure at the groin and the blood pressure at the limb, upper limb, where your arterial lines are the same. It's important. Otherwise, you create a problem. In most minimally invasive procedures, it is important to use some kind of an assist for drainage. It could be vacuum assist, it could also be a centrifugal pump. Sometimes it can also be a roller pump. So, whatever you use, some kind of assisted drainage is required because these cannulas are long. These cannulas are also small caliber and require some suction for flow to be maintained. Now, how much suction should we use? The amount of suction we use is usually about minus 40 millimeters of mercury. There are different kinds of suction machines. I don't know if I should go into this much depth, but for you to remember, a conventional suction that comes off the wall does not have a cutoff and is not ideally suited for minimally invasive procedures. What you should use is a suction machine that cuts off the suction when the required negative pressure is reached, so that tissues don't collapse around these cannulas. In many centers, they say we do minimally invasive. They turn on suction, the whole IVC will collapse around the cannula, impair drainage, and that ends the minimally invasive procedure. So ideally, you require a suction machine. One example is an Atmos. An Atmos is expensive, but will cut off the suction machine or the suction at whatever set negative pressure. If you set it at minus 20, once minus 20 is reached, the suction stops. It doesn't just keep sucking air or tissue on and around the cannula. So it's very important. I think Dr. Tendulkar is going to go a lot more in detail about cannulation, different kinds of cannulas, how they should be. I'll just roughly go into strategies for cannulation in minimally invasive. Like with open surgery, you could do peripheral cannulation, you could do central cannulation, as far as arterial cannulation is concerned. In most minimally invasive procedures, when you go to, like we discussed earlier, the class 1, class 2, class 3. When you go to class 2 and 3, generally we go for peripheral cannulation. Peripheral cannulation definitely has disadvantages, more prone to complications, which means that your concept of cannulating a small vessel should be very, very strong. It also means that you will do all these things with utmost safety. That means patients have already undergone an ultrasound, patients are under TE monitoring. You have to make sure that you have not created a dissection even before you start the procedure. All these things have become extremely relevant when you do peripheral cannulation. You also have to make sure that the amount of flows are adequate to reach the brain. It doesn't mean that you do peripheral cannulation, you just started some flows, you don't know how good that is. All these things become important. So when you talk about peripheral cannulation, either you could do axillary or you could do femoral. Axillary in some ways would be more better because the direction of flow is like normal. Now the disadvantage with axillary is that not everybody is comfortable exposing the axillary artery. Usually the axillary artery is very small caliber. Advantage is that the axillary artery is usually free of atherosclerosis and extremely healthy. But because of the small caliber, you often have to sew a graft, and the arterial line needs to be connected to this graft, usually an 8 millimeter graft, which again adds cost in our kind of a setting. Otherwise, axillary cannulation is perfect for most minimally invasive procedures. We usually do peripheral femoral cannulation, and it's important to make sure that the femoral artery is not too tortuous, so we image these patients. We also make sure that it's not, exceedingly calcified, or there are not too large atherosclerotic plaques that you could rupture while putting in a cannula, and then we go ahead and cannulate. Now, venous cannulation, again, you could do centrally. I will go on to the cannulas and also show you how we do central cannulation and how we do peripheral cannulation. So you could do a central venous cannulation with a 3-stage venous cannula, which is a very, very small caliber cannula made by a few companies, which you could insert into the RA. They don't occupy too much space. This is usually relevant only for aortic valve surgery. not for anything else. Peripheral venous cannulation usually is percutaneous, but you would use the same incision that you use for your femoral artery cannulation. Take a processing on the femoral vein, just adjust it to where you cannulate the artery, and then sending a cannulate the vein. We prefer to do it percutaneously, just that the size of the incision can be reduced. If you know the technique, that's the best way to go. Rarely, say you're doing a ASD, or you're rerouting a PFPVC, or you're taking out a myxoma. Sometimes we may have to cannulate the SVC via the internal jugular vein. It's not always mandatory, but a lot of surgeons who are beginners feel uncomfortable doing a mitral or a whatever these kind of procedures with a single cannula. So they do dual cannulation. Just adds another level of safety, but is more cumbersome. Can create more complications because somebody doing cannulation could into the carotid. So all these issues are there, but some people prefer to do it. Usually, the Settinger technique is what is used. It's good to learn how to do the Settinger technique when you're doing open surgery as well. It helps you, do it seamlessly. So for all peripheral cannulation, TE guidance is essential. What are the disadvantages for of CPB in MICS? Because you're doing peripheral cannulation, there's a greater risk of stroke, there's a greater risk of dissection. There can be perforation of intra-abdominal vessels. There can be cannulation injury to the groin vessels. If you pass needle too far beyond, you could go and puncture the posterior wall, femoral artery, cause a hematoma in the peritoneum. That could be likely. Or if you push the cannula very hard, you could perforate the IVC, the intra-abdominal part, and then cause massive bleeding again into the retroperitoneum, in which case your patient could simply be unsalvageable. So, doing all these things under TE guidance with utmost safety needs a certain level of skill, and most of the skill, like I told you earlier, is learned in open surgery and then translated into minimally invasive. Because you're using suction assist, it is possible to have cavitation and air embolism, especially if your profession is ramping up the suction. You keep screaming, there is not good drainage, there is not good drainage, and he keeps on increasing the suction to such an extent that there is cavitation and there is air embolism. So ideally what we do in minimally invasive surgery is that we tell the perfectionist if there is no good drainage, let me know. And then what you do, you ask him to shut off the suction and see how the drainage is. Just last week I had a patient, I kept screaming, not good drainage, he ramped up the suction so much that the entire IVC is collapsed around the cannula. And blood is simply pouring out of the RA and I cannot see anything. I told him shut off the suction. He shut it off. With just gravity, most of the blood is drained. And then I told him increase suction by -10, add another 10, add another 10, until you find that it is just optimal, not sucking too much air, just the blood gets sucked out. A little bit of residual blood is still okay for us to work with. Like I mentioned earlier, a greater degree of monitoring, a greater degree of alertness, not just you, the whole team is required. Failure to establish adequate CPB and the need to convert can be complicated and disastrous, so it is better that you plan for this in advance and make sure that it doesn't happen as far as possible. Briefly, again, Dr. Tendulkar is going to do this much more in detail. Most of the cannulas that we use for minimally invasive are wire reinforced. Either they can be completely wire reinforced right up to the tip of the cannula, and while some of the venous cannula may not be completely reinforced till the tip. Advantage of it being completely reinforced is that you can see the tip of the cannula on the. Disadvantage of it not being reinforced is that the extreme tip of the cannula is sometimes not seen on TE, especially once you've removed the stillet. Then what happens is that there is a propensity that you could push this cannula too far high upwards and you could puncture one of the adjacent structures, usually the nominate, or you could also perforate the roof of the LA if your cannula is not sitting in the SVC, sorry. So they're again available in various sizes. The most common sizes they use in a smaller build, 45-year-old, maybe female would be about 15. You could have variants up to 200 when you use a small cannula, sometimes up to 300, usually in the 200 to 250 range. And in a well-built male, a 19 cannula, well-built, I'm talking about somebody who's more than 80 kilos and tall. A 19 French is more than adequate to sustain good flows. Like we discussed, if you look at this venous cannula, you see that the extreme end of the cannula is not wire reinforced. So once you take out the stillet, although the tip of this cannula may be right at the higher end of the SVC, you could be just pushing it because the anesthetist is no longer going to see, he's only going to see here. So these are three-stage venous cannulas, with each stage draining or supposedly draining a certain area of the right side. So one end will sit at the IVC orifice, the middle part will sit in the body of the atrium, and the tip will sit in the SVC. All of them are passed through guide wires, and I will show you a small video on how this is done. So what is important to understand, all these venous cannulas are extremely thin. Again, like we discussed, they are polyurethane body. They are either wire reinforced or partly wire reinforced. There's a dilator that always locks in the fully extended position. This is going to help you for smooth insertion. All of them have a tapered tip. And once you take off the tip, the cannula alone is blunt. They come in a variety of lengths depending upon what cannula and which company you choose from, varying from 55 centimeters to 68 centimeters. And like I said, if there is a radio opaque tip, it allows visualization during placement. If you are doing a valve or an ASD or a PAPVC or a myxoma, you want the tip of the cannula, which is inserted through the femoral vein, in the SVC. That is your goal. Or even an aortic valve. Unless you want dual cannulation, for every patient when you use single cannulation, the cannula tip should lie in the SVC, not just at the SVC RA junction, up in the SVC, almost at the SVC denominator junction. It's very important. Even the cardioplegia needles here are long. This is the kind of plegia needle that you use. This is manufactured by Medtronic. And this is just a brief video to show both central as well as peripheral cannulation. Even in central cannulation, the aorta may be far away, and using a guide wire, what we call the Sendinger technique, may be more beneficial to do, as well as easier. See that it's a very, very small incision. We tend to separate cannulation, the femoral artery and vein. So we do a very small incision. That's an aortic valve. And you can see through that incision, you also have a cannula coming out. That will come. That is adequate. A good visualization. And if you go further down, so you have a needle, it's very important to get good brisk flow. You have to make sure that you're not hitting the back wall. And as soon as you get good flows, put in the guide wire. Your anesthesiologist is watching on TE, and you can see that the guide wire is seen on TE there. And once that is seen, and you know for sure that there is no dissection, you go in and do that. So this is for venous cannulation, which is done percutaneously. You use a series of dilators over a guide wire. Again, like I told you, everything is done under TE guidance. Currently, because many centers are doing minimally invasive, you have different kinds of dilator sets available. And you can serially dilate. The last dilator is the biggest and almost matches the size of the cannula. And again, like I told you, the anesthesiologist is watching you on DE. You can see the guide wire sitting there, you can see the guide wire moving as I go through this. Then as I put the cannula in, you can see the cannula going into the SVC. But they do not hold it. That's a big dilator. You can see that? It's almost a 24 French dilator. So everything is done slowly, methodically, and there is no hurry to do this. Because one wrong maneuver here, your guide wire will disappear from here. That is your first sign that you've gone beyond your limits of the wall, that vessel. That means you're perforated, and that could be the end of the story. All the time when you do this, your eye is going to be there. You're watching that. When you do this, you're watching that. You can see the camera coming up there. And you don't rely on the anesthetists. You have to watch it yourself while you push it in. See that? You can see nicely guide wire moving. Then you can see the nice camera coming up. All right. Let's go on to. Let's read. Doesn't mean. I didn't even know that it was very nice. All right, thank you. So basically, what I'm showing you is the retractors used for a CABG. This is a thoracotomy below 25th intercostal space. And this is a rib lift that we use. And you see this crouching position. This is what I mentioned, the difference between minimally invasive and robotics. This abnormal crouching position that you adopt to do this operation is eliminated when you do robotics. We take it on a manual test. So I'm just going to run through these slides because they're not very relevant for you. So if you're doing the IMA harvest, again you see there are different kinds of instruments because they need to be longer and they're designed differently. You're using a harmonic scalpel here to harvest the memory, and that's a single shaft clip applicator. So you can use different kinds of energy source, but a harmonic makes it extremely convenient because the number of times you need to click, and every time you click, you have to interrupt your procedure. That is eliminated. And with the harmonic, you can actually dissect like that. So that it's pretty easy to do once you learn how to do it. And usually the time taken for a mammary harvest comes down to about 8 minutes or 6 minutes. I'll just run it through. I don't think we need the whole video. What I want you to see is that the whole mammary we harvested. You can see lung adhesions there. You can see that right down to the top, it's going take down the memory much further up than an open surgery. Almost to its origin to circulate, but usually we stop where we see the artery and the nerve coming together. So these are the kind of tools we use. When many of you need to be comfortable with the word single shafted. Single shafted instruments are these instruments. They don't have two, like a scissors. They're not a pair. They're single. They're single shafted. All of them, like I mentioned to you, are long instruments. Some of these tools are also important because they're very specific to a particular operation. This is a flexible side clamp which helps alone one to do proximal grafts. Also note that the kind of sutures we use will be different from open surgery. They're usually much longer. Most of the instruments, like I mentioned, are also much longer. And most often, you don't tie with your hands, you usually tie with a knot pusher. So this shows you a side clamp being applied in the aorta. So this is a flexible side clamp which you saw earlier. Once it has been withdrawn, you see that there's a chain which lets you or helps you keep it wherever you want, so it doesn't come in your way. And gives you excellent access to the aorta. Rest of the operation or proximal is done exactly like you would do with open surgery. I'll run this so that you're not wasting time watching the operation here. So you could do as many as 2 or 3 proximals on the aorta with a single clamp. Okay, let's go on. For a minimally invasive CABG, these 2 tools are again extremely important. This is a minimally invasive octopus, also called the octopus no, and that's a minimally invasive starfish. They work exactly like the octopus that you see in open surgery and the starfish that you use in open surgery. Just that these are mounted remote from the site. This is how you mount it. This is the mounting rail. The mounting rail is mounted on the part of the patient or the bed of the patient, the OR table. And then you have an arm that folds it, just like that. This is a flexible arm, just like the flexible arm of the octopus that you use in conventional surgery. This again rotates 360 degrees. This is a fixed, solid shaft. So while using these tools, you have to be, of course, careful, but with practice, you become very comfortable with that. So that's a starfish applying the effects of the heart. And when you move the starfish in various directions, each vessel can be exposed. The usual site of entry, again, I said, is the 5th intercostal space, and I will tell you later on why the 5th intercostal space. Just run again videos, you don't want to waste time here. You can see that's a completed graph there. Distal PDA graph. Here. So you could even do sequences. You can also do distal RCA. The RCA is right there. You could do a distal RCA as well. And access to all the vessels is as good as open surgery. And in many cases, better than open surgery. So again, another video, I just see if there's anything important for you. I think it's going to show you the anastomosis well. Can you see that anastomosis? So in practically all cases, doing a PTA is more easier and less cumbersome than even open surgery. So you could use your choice of graft just like in open surgery. You could use all arterial grafts. You could use sequences on the right side. This is a sequence on the right side. This one. PTA PLV sequence. You could use a radial artery and minimally invasive. Harvesting of these vessels is also less invasive in the sense that we use an endoscopic vein harvester both for harvesting the vein as well as the radial artery. This is a radial artery sitting on a vein hood. And what it does is this. Most of the incisions are small, and since there is no disruption to the chest cavity, usually these patients recover much faster. Just to give you a brief idea, on second post-op day, patients are extremely comfortable to walk around like that. Let's go on, let's keep going. A total arterial, if you're using a Rima, you could harvest the Rima from the same side using again long shafted instruments, or you could use a robot and then do a Rima wide and graft 4 or 5 vessels. Caveat, all this comes with practice, and this practice comes from open surgery. So you have to be very good at open surgery before you reach here. This is a brief video which I made for Iacts last year. This shows you the entire operation. It's a 7-minute video, but I will run through it. That's your regular anatomy. This is how we do the thoracotomy. About 2.5 to 3 centimeters. See that? Sorry, inches, I didn't mean centimeters. Okay. And then you enter to the 5th space. Your site of entry is extremely important. It should correspond to the apex of the part. I'm running. You always use a soft tissue retractor. It keeps all the fat and unwanted tissues out. It also helps spread the rib a little bit, gives you better vision. This is an L-shaped blade which we use for the rib lift. And that's how the whole setup is. When we retract here, this gets lifted up and makes a little more space in the chest cavity for maneuvering the heart. And then you spread the ribs like that. We're using a harmonic to harvest the memory. I'll keep running. You can see that the entire length of memory has been harvested. When the pericardium is open, aorta is exposed. We use only 2 stays, one at the apex and the second just adjacent to the aorta, like you see here. This is the aorta, they can stay there. And this stay is of course brought out of the chest wall, the second interspace, there's a small stab. When you pull this, the aorta becomes even more accessible. You can see that the aorta is now being side clamped. And then the rest of the operation just continues like you would do with open surgery. That's nice articulotomy. Use again longer punch and proximals are done exactly like we do in open. Needle angles change a little bit, but not too much. So I'll just run this. It's in the second proximal being done there. You can see the completed 2 proximals. In minimally invasive, the right proximal is usually much more left compared to open surgery because you put a clamp on the left side, the aorta is right up, turn towards left. So, like I told you, if you're doing a sequential, So if you're doing a sequential, this part I think is important. So we place the starfish apex, and once you place it on the undersurface of the apex, you can see that the whole heart can be maneuvered around its axis, and you have access to every vessel on its surface. The only difficulty is if these vessels are intramuscular. You can see a nice PDA there. So practically every vessel can be accessed. Let me go a little down. You've already seen this. I want fingers here. I can show you a total arterial. If you're doing okay. So this is how we close. We put 2 drains and you're out. That feels very well. Looks nice in patients. Like I told you, if you're doing the endoscopic radial artery harvesting, that's how you use an endoscopic harvest. You don't have to do a long incision in hand. And if you're taking down the rima, you can take it down again, like you see in the upper video there, upper picture there. So harmonic scalpel, you can harvest both rima, and usually with 6 inches, it should be adequate to 3 or 4 sequential grafts on the entire surface of the heart. Not pusher, single shafted instruments, various coronary instruments, all of them are coronary instruments. Exactly same kind of instruments that you have for open surgery, just that they're single shafted. 25 degree, 45 degree, reverse parts, same instruments. And when it comes to valve surgery, you have long deliveries and long scissors, exactly again like you have with open surgery. The only difference again is that they're single shafted. So let's look at mitral valve. So for the mitral valve, you have different kinds of approaches that have been described over the years. The most common approach that most people choose to do when they start off the program is usually the 4-inch space, and this is the most common incision. But as they gain more and more experience, they usually move upwards rather than downwards. And this incision usually is a better incision because the mitral valve looks up like that. The mitral valve is not directed like that. So an approach to this incision makes it a little more cumbersome to take certain, place certain sutures, especially in the 5 o'clock and 6 o'clock position on the mitral valve. Like I told you, this is what you call class 2. This is 5 to 8 centimeter mini-thoracic incision. You could also do this by placing the incision a little more medially, in which case you may not require long shafted instruments. So these principles remain the same, whether you go towards robotic, whether you do a larger thoracotomy or a smaller thoracotomy, the relationship between these various ports remain the same. So you could do it like this, again it is hidden. The complication rates in this kind of incision is much less compared to inframammary, but your access to the mitral valve becomes better when you go to the anterior axillary line. And if you did extend this incision a little bit more medially, the whole thing, the whole incision, including the lower end of the incision more medially, you could also do a double valve, the same incision. So the ideal suited patient, of course, is somebody who's slim and thin, and the not so ideal patient is somebody like here. But for the patient, this is an ideal operation. For the surgeon, it is not. So generally, these incisions are small enough that you often have to push the valve inside. Exactly what you've been taught not to do. So that's a 21 sized valve, and your incision, or maybe a 25 sized valve, mitral valve, and your incision is exactly the same. And you see, it doesn't go in, and you have to push it in. But for this patient, once it recovers, this is a better start to deal with. It's also a better injury to deal with compared to somebody who's obese. And if somebody is obese, you definitely rely more on the camera to show you exactly where the knots are going and the knots are placed appropriately. They feel well, young and old, everybody feels well. Let's go to an aortic valve. Now, aortic valve approaches were the first to be described as far as minimally invasive surgery is concerned. Way back in 1996, both Costello and Fawn described various techniques of approaching the aortic valve. You can see about 8 different techniques of approaching the aortic valve, but I think the 2 most common are a right anterior thoracotomy. This is not parasternal, it's right anterior thoracotomy. The parasternal approach was described way back in 1996, and that means you have cut the first 3 postal cartilages. That is parasternal. So this incision is right anterior thoracotomy, and this is an upper hemisternotomy. Usually teed off at either the 3rd or 4th intercostal space. If the sternum is very short, 3rd is usually the right place to go. Some people also do a lower hemisternotomy. So various approaches. How do you decide? It's not one size fits all. There are patients who are perfectly suited for a right anterior thoracotomy, and then there are patients who are perfectly suited for an upper hemisternotomy. So the relationship with the aorta to the sternum, particularly the right sternal border, is extremely important, and also the angle at which the aortic valve looks at. So when we usually do a CT scan for all patients. It's a plain CT, and when you do a plain CT, you look at these points. I will straight away jump to a slide that shows you the picture. The only thing here you need to remember is that the ascending aorta needs to be 10 centimeters or less away from the sternum. It is too close to the sternum, difficult to do surgery. If it is 20 centimeters away from the sternum, the surgeon is going to have trouble. Important to note here, alpha angle is the angle between the midline and the inclination of the descending aorta. It should be greater than 45 degrees, which means the valve is actually looking at the shoulder, not looking at the neck. Here. So this is the alpha angle, and you see in this case the alpha angle is what? Acute or obtuse? You want the valve to look like this. So it's perfect for a second or third space entry. If the valve is straight and looking like that, then it's not good for a right angle thoracotomy approach. And same here, if you look, at least 50% of the aorta should be more towards the right for a right angle thoracotomy approach. Look at this. More towards the left, unsuitable. This is when you will choose an upper hemisphere anatomy. Look at this, 35-degree angle. Valve is looking much more straighter. Of course, with experience, you can do all these as well. But these are the basic guidelines which you will follow when you start with medicine. And for the exam, this is important. Perfect. 50% out, angle out. Clear? Okay. Shall I move? So if you have chosen the right patient for right angle thoracotomy, the aortic valve is simply going to look at you. And this operation is an easy operation. Everything is visible perfectly. Do I need to go through this? I don't think so. If you have shortage of time, let's just keep running. See that? Perfect. Just looking at you. So this is the kind of patient you should be selecting. Small incision. You also do it in these kind of patients. They benefit more than the thin patient. Just that you don't benefit more. You have to be careful, of course. So you could also do a CABG with a minimally invasive area. If you're not getting there, you just jump this. Okay. So if you're doing an upper hemisternotomy, it means your incision on the skin is going to start way down at the sternomandibular junction. Your incision actually starts there, the top end of the incision. You tunnel, put the saw through. Usually use a pediatric saw, cut down, usually up to the fourth space. And this is how it heals. This incision is not here. It's way down, so it's not visible and heals beautifully. I'm done. Same again, you can see the how it heals, and you can see that the exposure is perfect. So what procedures are suitable for MICS? You could do a minimally invasive multi-vessel CABG in whatever format that you want to do it, whether vein, artery, total arterial, radial artery, whichever combination. You can do aortic valve replacement, mitral valve repair or replacement. You can do a double valve replacement. You can do a mitral valve repair. You can do an ASD. You can do a rerouting of a PAPPC. You can excise LA myxoma. You can do LA. You can do lead placements. Perfect. When your cardiologist calls you and tells you everybody lead placement, they find trouble. Offer them this. Do a small thoracotomy and place it to the left on the lateral wall. Perfect. You can do hybrid surgeries for those of you who are not comfortable for minimally invasive multi-vessel. You can always graft those vessels which you can and then send them back to the cardiologist technique. Not really ideal. I'm not a great, fan of this technique, but can be done. And definitely suitable for redo surgeries, particularly mitral valves are exceptionally good with minimally invasive. What are the absolute contraindications? Basic common sense, don't take an unstable patient for minimally invasive. Don't take too complex patients, especially if you don't know what is lying inside. Don't take patients who are morbidly obese. In general, it's not recommended for patients who have chest wall abnormalities, whether it be excavatum or pectus, whatever kind of pectus. Also, you don't want to take patients with severe COPD where they do not tolerate single lung ventilation. If you want to do it, it means that you want to prepare these patients adequately. Maybe if it takes 15 days, you will prepare them with a lot of bronchodilators or whatever, chest physiotherapy, etc., and then do this procedure. Sometimes a heart machine may be required to support. You don't want to take patients with previous lung resections or whatever kind of thoracic surgery. In general, we want to avoid patients with peripheral vascular disease because in case you have to go on pump under duress, you will end up in trouble. Again, you don't want patients with aortic dissection, descending aortic aneurysms, aortic thrombus, etc. Okay. For a CABG, again, you don't want to take patients who are unstable. You don't want to take patients who have a CTR greater than 65, ideally 60. We push it to 65, sometimes up to 69. You don't want to handle patients who have low EF. Again, The same thing that applies to other kinds of minimally invasive surgery applies. You're going to ask me, am I going to get this ideal patient ever? The beauty is that with minimally invasive surgery, a lot of those patients were unsuitable for open surgery. Very old patients, sick patients, bedridden patients, patients on steroid therapy. All these patients become acceptable for surgery, who were once not acceptable. So you're actually including a whole different subset of patients into the surgical stream while we eliminate a few. Okay. I already showed you, some of you, this video. Robotic surgery basically adds to what MICS already offers. There is no rib retraction. And if you speak to some of the patients, they tell you that there is practically no pain at all. There is no rib spreading. It's only a small incision on the chest. The ports are 8 millimeters, and I think in the future you're going to have single millimeter ports. Single port systems, and single port systems have 3 or 4 instruments going through one single port of 20 millimeters or 15 millimeters. And they're really beautiful. The camera, the instruments, everything goes to the port. They all work like snakes inside the chest. There is no clash of instruments, and I think that is the future. And the reason that all of us should get into this game now is basically for preparation for the future. The learning curve is steep, especially if somebody is not doing minimally invasive and they want to jump into robotic. It is practically impossible. Again, you heard Dr. Bashi talk about team, not standing in the OR in the morning. This applies even more to minimally invasive surgery. Team building is extremely important with minimally invasive. Thank you. Are there any questions in specific? Maybe I will take 1 or 2 questions before we. I think the other people are also waiting. Anything? I'm done. Thank you very much. Sorry.
This is the ECG.
Thank you so much. This is such a vast topic in such a short time. Now I request Dr. C.S. say ICC secretary to present the total member to Dr. Satyaki Balas. Someone rightly said that advanced level is mastery of basics. Now we move on to the next session where eminent teachers will help us polish our basics of ECG, chest X-ray, and echocardiography. ECG is a blueprint of working of heart and is very important for any cardiac mission. I request Dr. Prasanna Simhaswamy to guide us through the benefits of using ECG.
It's in the afternoon, everyone wants to sleep, so it is expected that you people will do this.
Not once.
We are sleeping. So, all of you have to participate. This is not a. If there will be a question answered, you have to give the answer most of the time. Because these are things which are expected to know and supposed to be just polishing and brushing. Otherwise, ECG will be an extremely boring topic in the afternoon after lunch. Okay, now what's the goal of an ECG? We are trying to now let us remember that whenever we are talking about clinical picture, the ECG, X-ray, CT, you are using various pieces of information to build up a jigsaw puzzle which will give the entire picture of the patient. Now, what are the things that are learned what are derived from an ECG?
you know about the electrical conduction of the heart. So this allows us to know which are the chambers that are enlarged and what is the type of enlargement. And there will be some specific morphologies of ECG. So, and then an important thing is how does the ECG picture differ from the clinical picture? See, we have been asking every time. This morning we had a fantastic thing where we said that ECG may not be the ECG of the patient because it had no correlation with the clinical picture. And this has happened. People have put the wrong ECG, the wrong investigation. I'll give a simple example. My relative, 88-year-old man, was admitted, and then they came to me with for some problem, and then they told me they got MDR, carbapenem resistant MDR, blah blah, some Klebsiella, everything. Which he was totally asymptomatic. Then we realized that it's not the culture report of him at all. So you must never forget that everything has to correlate. The clinical picture and the investigations have to correlate. So please remember that. That is why I always tell, and this is what is taught to me, is that you make the hypothetical ECG based on the clinical picture. Now find out, does that hypothetical ECG correlate with the ECG that is given? This makes striking differences. And if you see striking differences, you may be able to find out what is wrong, and you may have go back and clinically examine and you may find something which you have missed. Now, we all know the standard protocol for doing reading an ECG, and this is what is taught to us in MBBS. Second MBBS first term is what this is done. So now all of you should know what is standardization, rate, rhythm, axis, low, P, PR, URS, 0.T, U, and additional things like QT and other specific things. So this is the way it is along the axis of the ECG as you move from one end to the other. You should be able to learn. I will not be going through things like Einstein's triangle and all that. I expect that you have read it, the theology of ECG, how the leads are placed. I'm not going to go through it. But some of the things that you must know is what is the standardization and what is that large vertical arrow, how much is that? Huh? That large arrow, not two large boxes. What does that mean in a standard? The standardization signal. Every ECG has a standardization signal. Huh? Okay. And then what? So you should be knowing what is it. And then you must know what is half standardization. When we use half standardization, when the QRS complexes or the voltages are so high that you want to. So please look at the standardization. If you don't look at it, you may make mistakes. Then when are higher speeds used? When the rate is high, or when you want to do certain times. For example, the electrophysiology lab is routinely learned at 100 speed. So now, these are all what is the standard speed in the ECG? 25 millimeters second. One small square, 40 microseconds. And then rate is now the things that you have to know is how do you determine the rate RR interval by 1500 divided by RR interval. If you take in the small squares or the big squares, you divide it by 300. All these things have to be done. A standard question that is asked is how is the rate calculated in atrial fibrillation? You take 15 consecutive rates and divide it and find the average of them. And then now there are certain things which are standardizing. For example, when we are talking of bradycardia, we are talking of brain. When you are confronted with bradycardia, if you have a congenital heart disease with bradycardia, what is your thinking process? What are the possibilities? CCTGA, other part, then congenital heart disease with slow heart rate. TOF with slow heart rate. Just I'm giving an example. TOF with a slow heart rate of 40. What are the things that you think of? Before that, treatment one. Okay, drugs could be there. Then it could be an AV canal. It could be CTGA. So you should think like that. IHD with bradycardia. Right-sided disease. Pre-crux lesion is there. Opcat bradycardia is occurring. Bradycardia is occurring when you are doing an opcat. What is the thing that is happening? Which vessel is being right? So pre-crux, like you don't get bradycardia with the PDA anastomosis. When you are doing the pre-crux RCA, then you are going to get valve disease with bradycardia. Aortic valve disease with bradycardia. You take up calcification, beta blockade, mitral valve with bradycardia, annular calcification on the rarer side, then, but more common, bradycardia with mitral valve disease. Medication, what medication? Beta blockers or digoxin. See, now this is same thing, you have to do the exercise for tachycardia. Okay. Now, so in the rhythm, you should know how to recognize the sinus rhythm. There should be PQRS and this thing, and then you should be able to differentiate varying degrees of heart block. For example, you must know what is a prolonged PR. First case, that will diagnose that the patient is a prolonged PR. You had aortic valve disease with prolonged PR. Unless you know those values, I'm not going to go through all of those values, but you must know how to differentiate first degree, second degree, and third degree heart block, and what is the implication surgically for age. For example, then another thing, access. Do you all know how to calculate the access? Yes, no.
Yes.
Huh? If you do not know, please somebody you must know. You must know what is the normal right axis, what is yeah, we are not going to go through the detail. Now the most important thing is inappropriate axis. You expect an ASD to have a right axis. Suppose you have an ASD with left axis, RC prime. Top with the left axis. Yeah. Top with the northwest axis. See, now you realize now how if you look at it that this is we have discussed it in the morning. So now what I'm trying to say is what is the normal axis and what for that given case and what is the inappropriate. Same thing if you have heart rate, inappropriate heart rate. Top post surgery with a heart rate of 170. Top post surgery first day in the ICU with a heart rate of 170. Junction electropic tachycardia. You would have to do a little bit more of analysis of the ECG, but JET is one of the things that you have to think of. So now you have to think in that way. Loop. Now again here, what is clockwise loop, anti-clockwise loop? I'm not going to tell you, you're going to deny. But now I'm going to ask you, top with the anti-clockwise loop, ASD with the anti-clockwise loops. Yeah. So now you've got to think in this manner. Now an important thing is what is an interval and a segment. Many people make this mistake. An interval is that area which is between two waves, whereas the segment is and then a segment can involve one or more waves. Now the PR interval prolongation for prolonged PR, what are the possibilities of a prolonged PR in congenital heart disease? PR prolonged in congenital heart disease. ASD will prolong PR. Which is the disease with a long stretched bundle? Right? An AV canal type of disease, primum ASD, AV canal. So you must know those things. Now one small thing that you should be doing because this is going to we are encountering it more and more nowadays with a lot of drugs like cardon and other things is the recognition of long QTs. You can use Bezet's formula, but the simplest way to do it is at no time should the QT interval be more than half of the RR interval. So you can take a piece of paper, put RR, fold it into half, and it should be shorter than the QT. If the QT is more than half RR, and you should not open your. I can even do a transesophageal electrocardiogram in that boy. Oi, you know that you can take an ECG called as a transesophageal electrocardiogram. Now, you should also know ST segment elevation, ST segment elevation and depression in various diseases. For example, if you find ST segment depression in aortic valve disease, strain pattern. But if you get ST segment depression in ischemic heart disease, it's again ischemic. And then if it's elevation, you have to start thinking in terms of now P wave. Points to note. For example, this is a standard thing that you must know is LA enlargement. What you say? Negative terminal deflection in lead V1 more than 1 millimeter in depth, or you can say 1 millimeter square area. The negative terminal deflection. We have shown that in the morning. When you are asked P mitral, what does P mitral mean? What is the depth of the notch? 0.5 millimeter. This thing and the width is also 0.5. And the height should be more than 2.5 millimeters. How is it caused? Common question asked is how is P mitral caused? there is superimposition of both the enlarged LA and the RA forces, one and the other, which causes the Cameron hump. When ASD you must know what is P congenital or tricuspidal or P pulmonale. All that it means is that it is RA enlargement and P wave is more than LE2 is more than 2.5 millimeter. Then another thing again, ASD with abnormal P wave axis. That is, if you find the inverted P wave in lead 3, because many people don't understand P wave axis. So remember, in the P wave in lead 3 is inverted. What is the possibility? No, all answers in ASD is not osteopenia. Sinus venosus. Now you have to know the term Himalayan P wave. What does Himalayan P wave mean? It means a very large P wave. It can be formed classically described in FC. Another place where you can get a Himalayan P wave, remember, is in tricuspid. This here is a big large. Now we have gone through this. Bad disease with first degree heart block. Then, we've already done that. Now, if you have first degree heart block and tachycardia in a valve case, in a heart valve case, you are having first degree heart block and tachycardia. 8-year-old boy having fever, inappropriate tachycardia, first degree heart block. Rheumatic heart disease. Remember that. Carditis. It can be myocarditis. It can be any form of carditis. Diphtheria carditis. Any form of myocarditis causes inappropriate tachycardia, but we are at river with disease. So we watch fever, cardiac disease, and heart block I've done. And all these are ways that the same question can be asked. This is practically important. QRS, you must know how to identify what you should know what is the normal QRS bit. And you must know what is incomplete right bundle branch block and complete right bundle branch block. How to differentiate it? RSR dash pattern, I've given you the time. Now, the common question that is asked, I'm not going to go to the data, but I'm going to ask you, what happens to the incomplete right bundle branch block after surgery in an ASD? Huh? Now, as a corollary, what happens to the split after surgery? What is the split before surgery? What happens after surgery? 1% answer right. It remains white, but it is not fixed, it's mobile. Why? What hangout? No hangout. Now what is remaining? The electrical component is not, only the mechanical component has been corrected. Okay. TOF. Now you all know that what is the classical description of TOF QRS? Sudden transition, we discussed it. Now, if you do not find a sudden transition, see everything, I'm expecting to find something, I don't find something. If there is an absence of sudden transition in TOF, no. I don't find a sudden transition in a TOF. What should I do? Something else you must ask. ECG should be retaken. And what is supposed to be taken? The sudden transition may have occurred much more rapidly, so you have to take the right-sided lead. If you have, what is the ECG in a patient with a single ventricle? What is the classical description? See, they're all asked in the exam. Monomorphic or stereotypic, they all remain the same. There is a QRS like that. Okay, and if you find a splintered QRS, see, these are things which are asked in the exam which you should be knowing. If you see in the exam, Epstein. Common thing in the exam, and now another thing. You will be telling that Q wave. What is the infarct Q wave and what is the non-infarct Q wave? I see a Q wave in the ECG. I must say that this can be called an infarct Q wave or a non-infarct Q wave. How do you diagnose it? More than 25. An infarct Q wave is more than 25% of the RLI. Now, Q wave, what in left ventricular volume overload, where do you find the Q waves? V5, V6. And what is the relationship of Q wave and loop? 2, 3 AVL is clockwise loop and 1 and AVL or in the lateral edges. You must know the ECG features of an NMI. This is something which has been taught you in first and in second.